Okay, I would, good morning, and I'd like to call this meeting to order, but prior to that, I'd also like to remind everyone to please turn off their cell phones, or at least put them to silent. And Blackberries do make static on the feedback, so I'd please appreciate for them to be off the table or off. And as you may notice, there are board members that will be using laptops. They're doing that to access the materials of the board electronically. And the board, I want to ask Mr. Einer to come forward, please, and take the roll.
Dr. Bishop? Here. Dr. Carrion?
Here.
Ms. Chang?
Here.
Dr. Diego?
Here.
Dr. DeRusso?
Here.
Dr. Gonadev?
Here.
Dr. Levine?
Here.
Dr. Lowe?
Here.
Dr. Salmonson?
Here.
Ms. Shipsky?
Here.
Ms. Garvislavsky?
Here.
Thank you.
So we have a quorum. Thank you very much, Mr. Einer. I also remind you that this is Mr. Einer. If anyone wants to have the opportunity to speak, we welcome public comment. Please make sure you fill out some of these slips, or one of these slips, please. Fewer is fine. And make sure he has them.
I have the entire board today.
Prior to starting with item number 2, which is public comment, I want to recognize a board member who is serving today at her last meeting. Hetty Chang was appointed to this board in 2004 and reappointed in 2008. She has served in many capacities in this organization, stepping up to chair committees, serving as the chair of a panel, and serving as secretary to the board, and now serves as a board member on the Federation of State Medical Boards, representing the interests of California. I would like to call Hetty up to present her with an award as a token of our appreciation of her time served on this board and say thank you for your engagement and participation and your passion. Yeah, good. And giving voice to many issues that we've addressed recently. Wherever you'd like to take your opportunity to speak.
I guess I'll have to say this for the first time and the last time. I do want to thank all of you and the staff member especially for a fine 8 years. It has been very rewarding and I really enjoyed it. And as I'm going away, I will still stay on the Federation of the State Medical Board for 2 more years. My term expires then. One thing I wanted to, because everywhere I go with the Federation, California has always impressed me and impressed the rest of the country that we are a very high standard, well-run, group. I can always say California is doing it this way and they will listen. So I want to encourage all of you to keep up with the good high standards that we had before. I guess I have to say this one. In the process of getting the reform, and it was great to be able to have insurance for everyone. But I think the process is how to maintain the quality of the physicians to the best standards that we have. It will take some effort, and I'm hoping we do not dilute. Now, this is my saying because there will be some shortage of physicians and shortage of health worker in general. But my thought is, please do not dilute the quality of our doctors and then keep our quality up. Thank you all.
Moving back to the agenda, item number 2, I have the following speaker slips for items not on the agenda. As I indicated in my opening remarks, please try and keep your comments to 3 minutes, and less would be better. So starting off, let's have Mr. Cuny come forward. Frank?
My name is Frank Cooney. I'm the Executive Director of California Citizens for Health Freedom, and I've been going to board meetings for about 20 years now, longer than any board member, I think, onto it. I welcome you to Northern California, and I want to urge the board to consider looking at a bill that we will be introducing next year and possibly sponsoring or supporting a bill that will make integrative treatment of cancer legal in California. We have over 2,000 people I know go to Mexico each year for treatment that is not available in California. Under the current law, it is a criminal offense for a physician, naturopathic doctor, to do treatment of cancer. It can become a felony offense. That law prevents many hospitals and other groups coming into California and offering integrative treatment, more advanced treatment. And Senator Vasconcellos, years back, passed a bill that required the medical board to have a committee on alternative medicine, and that committee looked at alternative treatments, and the board sponsored the bill that made non-conventional treatments legal in California, but we're now trying to deal with a law that exists in the other code and change that law, and would appreciate whatever the board would do to it to help work on the process of changing it. Senator Vasconcellos tried to introduce a bill on that, and he did the non-conventional medicine, and the board did not have the opportunity to follow through on it because of budget cuts that existed at that time on borrowing the board's money into it. The last chair of the Senate Business and Professional Practice Committee, I'm trying to remember her name, that brought the revisions in the board through the process, also sponsored a bill to do it, but unfortunately it got killed in the Health Committee. On the Assembly side, went through the Senate, and that when a board puts a bill in, at least their experience with the non-conventional medicine, there were only 2 votes total opposition through both the Senate and Assembly. Thank you very much for your time, and welcome to Northern California. Oh, by the way, you're invited to have some free peaches over there.
Thank you very much. Next on my agenda, Rahan Sheikh, please come forward.
Thank you, Madam President, for the opportunity. And how could the board meeting could complete without my remarks? So first of all, I want to apologize, Dr. Dhanwa, who I was distributing some flyers at the Caesars Medical Association, and I could not give you one. I thought I will bring same for Dr. Bishop at the same time. So this is our flyers that I was distributing, one copy for each of you. I have a spare copy if anyone wants. Secondly, I am here to introduce all of you to University of California at Davis. It has higher educational standards, and the graduates of the University of California, they are considered competent to practice in the state of California. And here is a certificate issued by University of California to my wife, Dr. Farzana Sheikh. She is here. So today we are bringing a pilot program that she can practice medicine in the state of California because she is graduated from University of California at Davis. You have a copy. So since University of California has already recognized, the board has a burden of proof if you want to oppose this thing. So anyone has any objections to this proposition?
You remember, Mr. Sheikh, my admonition is that this is not a conversation. This is your opportunity to speak to us, so please use your time appropriately.
Okay. Since you don't have any objection, I consider that motion is adopted. Thank you.
Madam Chairman and President, if I may be heard, the purpose of public comment is the board cannot take any action during this action except for the determination whether to put it on on the agenda for the next meeting. So there was no action taken by the board on this.
Correct. Thank you. Next, Tina Manassian.
Thank you.
Good morning, Madam President and board members. Tina Manassian. I'm here on behalf of the Consumers Union Safe Patient Project, a nationwide campaign that is organizing patient safety advocates from across the state of California as the California Safe Patient Network. Since California is such a large state, medical board public meetings are routinely inaccessible for consumers who cannot afford the funds and time to travel the length of California to attend in person. Many of the consumer activists that we work with are survivors of medical harm, and some are disabled as a result. For these well-informed and passionate activists, travel to medical board meetings is even more difficult, and in some cases not possible. One very important request the Consumers Union Safe Patient Project California Network has been making to the medical board is that you begin providing teleconferencing of your public meetings to allow members of the public to participate in your public meetings remotely. By teleconferencing, we mean opportunities for the public to listen to medical board public meetings by telephone and to allow public testimony by telephone. We are not urging the medical board to establish remote locations from which the public can participate. We want the public to be able to use their own cell or landlines to call into the meetings from wherever they are. The California Health Care Acquired Infections Committee and the new California Health Benefit Exchange are Bagley-Keene governed entities that provide such interactive teleconferencing successfully. The Consumers Union Safe Patient Project believes the Bagley-Keene Act supports public participation by teleconferencing and that the medical board is misinterpreting and thus failing to abide by the Act when they fail to keep up with the new technologies that can facilitate public participation in government. We urge the board to instruct its staff to develop plans for providing teleconferencing for the public for future quarterly board meetings and committee meetings. Thank you for your time and consideration.
Thank you very much. Next, I have Ann Robinson.
Madam President and board members, I'm Ann Robinson, and I'm also with Consumer Union Safe Patient Project, and I've come from Chico. We have some issues to put before you. I'd like to raise one thing now. Consumers Union's Safe Patient Project is concerned about the unbalanced nature of the medical board's membership. The medical board has a total of 15 seats. The law requires that 7 of these be filled by public members. The remaining 8 are physician seats. At the moment, unfortunately, there are 7 physicians on the medical board and only 4 public members. A relationship that should have been close to 50-50 is now askew with nearly twice as many physicians as public members. This creates a dramatic imbalance on the medical board. We are concerned about the implications this has for priority setting and policy and process decisions being made by the medical board now. Certainly the legislature envisioned a balanced viewpoint on the medical board when it assigned 7 of 15 seats to public members. 2 public seats that are gubernatorial appointments expired in June. Since the appointees holding these expired seats have already served 2 terms, as you know, they must leave the board after a 60-day grace period at the end of July. This will leave the medical board with 7 physician seats filled and only 2 public seats filled at the end of this month. I'd like to share with you a letter we sent last week to Governor Brown raising these concerns. The letter is signed by the leadership of Consumers Union, ARP, California Pan-Ethnic Health Network, CalPIRG, Center for Public Interest Law, University of San Diego School of Law, and the Latino Coalition for a Healthy California. We hope that medical board will also work to call this important issue to the governor's attention soon. Thank you.
Thank you. Yvonne Chung.
Good morning. I'm Yvonne Chung with the California Medical Association. We just wanted to bring the board's attention to a brochure that has been produced by the California Medical Association, the California Medical Association Foundation, with support of the California Endowment. It's intended to help patients understand their new benefits, highlight opportunities to obtain or change health coverage, and provide timelines for when these changes will take effect. And there's links to resources where patients can find more information are also included in the brochure. We've also produced the brochure in other languages. It's available in Spanish, Vietnamese, and in Chinese. And we have copies available in the back of the room, and we are more than happy to send copies for distribution to your offices as well. Just let us know. And we just wanted to let you know that this resource is available. Thank you.
Thank you. So I have no other public comment slips, so we're going to move on the agenda. And I'm going to ask Dr. Nuovo, who I didn't see. Oh, I did, right in front of me. I apologize. Please come forward. I've been looking. So please have a seat. Before you speak, I apologize. We're going to have the approval of the minutes from the last meeting. Do I have a motion for the May 3rd and 4th meeting notes to be approved?
So,
Do I have a second? Second. Do I have any public comment on the minutes from the May 3 and 4 meeting? Do I have any any corrections or additions from the board members? Okay, all those in favor of the minutes being approved as written, please say aye.
aye.
Any opposed? So the minutes are approved. So now I would like Dr. Nuovo from the University of California, Davis, to provide us with the annual report on the Medical Board UCD Telemedicine Pilot Program. And ask that, given we have new members, since this has been brought before us in the past, I would ask you to give a brief historical overview as well as information as the scope and the view of this pilot project, if you wouldn't mind.
Thank you very much. Yes, I'll incorporate that into my presentation. I've worked hard to being respectful of the a number of agenda items. I'll incorporate that into my talk, and I'll try to keep this under 10 minutes.
Thank you.
A purpose of this project was the development of a diabetes self-management education program delivered via telemedicine to patients in rural communities in California. Our efforts started in 2003, and we're in the process of analyzing our data. There's a bit of a travelogue of slides incorporated into this of the places that our team has been throughout the many counties through northern and central California. This is just one from up in Tule Lake, way up north. The genesis of this project came from AB 329 Nakanishi, an assembly bill required to conduct a pilot program to develop methods using telemedicine model of delivering health care to those with chronic diseases and delivering other health information. My background on this is that I started about 14 years ago now, a diabetes disease management program through the UC Davis Health System, in which we're now looking and managing 30,000 patients with type 2 diabetes just within our health system, a disease which is an epidemic, not just in California, but across the world. Just another place that we've been in our travels. I do have to acknowledge all the people and all the groups that have participated in this, the medical board, the chronic disease management program, which was responsible for the educational content of this intervention, the Center for Healthcare Policy and Research, which helped with all the analysis, and the Center for Health and Technology, which had all the capacity for the telemedicine connections. Another place that we were. A lot of people were involved in this. I won't go through the list of everyone, but there are even more than just these names that helped with this particular project. And then, of course, I have to acknowledge all the efforts of the people, the physicians, the staff, and especially the patients in the 9 clinics willing to participate, who came from Nevada County, Sierra County, Plumas County, Tehama County, Siskiyou County, Mariposa County, Trinity, Humboldt, and Amador County. So we tried as hard as we could to get a representative sample. It wasn't perfect, but we tried as hard as we could to do that. Again, the goal was to test a model for improving access to diabetes self-management training and resources to these patients in these areas. The rationale is that the informed, activated patient in concert with a prepared, proactive healthcare team can improve outcomes. This comes from something called the chronic care model, and I incorporated the website if any of you have interest in pursuing how this is a very different approach in caring for patients, not just with diabetes, but with any chronic condition. What we did, the thing to keep in mind is that this was a one-time 2-hour class on diabetes that was focusing on self-management support to patients who received care at these 9 clinics. A one-time 2-hour class. Keep that in mind as you look at the results that we have of our intervention. This would give you a sense. On the left is one of our health educators, Isela. On the right is one of our health educators, Mauricio. This gives you a sense of what it would have looked like from the patient point of view. They met, if you will, patients on the telemedicine link and gave a 2-hour class in which they gave the content of their talk, which was presented at a previous board meeting, and then would have time for interactive questions. We did extensive survey of all of the participants in these rural clinics. Extensive could be in caps. Patients who participated in this project gave us a lot of information on demographics, how they were managing their diabetes, their knowledge of diabetes, their confidence in management of diabetes, their perception of care in their clinic, and so forth. Great deal of information. And we followed up by assessing all of these elements 6 to 8 weeks after the intervention, and we even did a chart audit at the site. So these are some of the findings very briefly. We've had 239 participants to date. If you had to just look at the averages, the average or typical patient was in their 60s, a woman, white, with some high school education. About a little more than 2/3 had access to the internet, and most were Medicare and Medi-Cal. One of the things that we'll be presenting in our final report is why we didn't get a population demographics that we thought we would get, and in particular more Latino involvement in the project. We were quite surprised about that. We're doing a lot of work to sort out whether the clinics had self-selected to participate, whether the population we received is the population that they're caring for, or there were some other barriers. This is an example of one of the barriers. Our health educators told us stories repeatedly that patients would tell them, if this is a 2-hour class, I'm going to have to leave early because I have to move the irrigation pipes. And so we did some interventions to try to accommodate that. But that was a real issue, that jobs affected their ability to participate in an education program. The demographics, these next few slides just reflect that the demographics and some of the features of this population are so typical of any practice, not just rural practice. Most had diabetes for at least 5 years. 9% didn't even know the type of diabetes that they had. They were on these particular kind of agents. Again, this pattern reflects what goes on in most practices around the state, at least from the data that we look at. Most people with diabetes have other chronic comorbid conditions, and so did this population. I didn't put depression here, but depression is a common comorbid condition in diabetes. It affects outcomes, and it was one of the more relevant ones that occurred in this population as well. So these are the results that I want you to take a look at. One was that patients were asked a series of questions about essentially reflecting how the practice that they're at supports diabetes self-management. And there were 20 questions about this. Questions like, has your doctor or anyone in the clinic had a discussion on how diet or exercise influences your condition? Or has anybody in the clinic had a discussion with you about setting goals? And these were the findings. 1 is, just to go back, 1 is none of the time, and 5 is all the time. The average scores across all clinics were 2.5 to 3.6. This would be the equivalent of about a C- on a report card. It is not a reflection of the quality of care in these clinics. In fact, when we've done this exact same questions in our own clinics, this is about the same kind of answer. Most clinics are not geared up to help with diabetes self-management and self-management support. The concept is called the tyranny of the urgent. The urgent issue gets in the way of dealing with the core issues of the chronic condition. We've also asked a lot of questions about, are you taking care of yourself, looking after yourself, are you exercising, looking after your feet, getting your eyes examined once a year? How confident are you? Confidence is something I could talk about for an hour. It's a big deal. Many patients with type 2 diabetes, with any chronic disease, feel overwhelmed. And when they feel overwhelmed, oftentimes they and their providers give up. And this is what we found after the intervention, was that there was a statistically significant reduction in feeling overwhelmed with their diabetes from the pre-test time before they engaged in the 2-hour session to the follow-up period. Specifically, just under 20% felt overwhelmed, a pretty typical number, with their diabetes, and 5.4% felt overwhelmed at the 6 to 8 week post-intervention period. There was also a change in observed number of days that patients did physical activity, at least 30 minutes of physical activity, and checked their feet. So the exercise pre-intervention was about, the typical person was exercising, and that could just be walking. We gave a broad definition for exercise, about 3.4 days, whereas the mean went up to 3.9 days after the intervention. Patients also check their feet more often. That's a big deal when it comes to diabetes, and I'll show you in just a few minutes why. So we went from 4.2 to 5.6 days. Knowledge of diabetes was assessed very carefully, and there were a series of questions, and just to give you a sense of what we were asking, how much do you know about the kinds of things that would be important, the effect of carbohydrates, reading food labels, and so forth. And what we discovered was that there were significant changes. And again, when I'm using significant, I'm using the help that we received in our, with all our statistical support. We were able to demonstrate that at the 6 to 8 week follow-up period. So, what did we find in this, as we're still analyzing the data, still working on our final report, which we'll present in the fall, is that patients' self-confidence improved, their knowledge improved, their self-care behavior in all elements, including things such as exercise and foot care, and this all came from a 2-hour class. There are a lot of other findings that we will be presenting down the road. Some of these are qualitative. Now, I'm not targeting the Tule Lake supermarket, but we found a substantial number of barriers traveling around and going to towns. The concept is called the food desert. It simply means that it's awful hard to find the things, the fresh fruits and vegetables and good things that you're supposed to be eating when you have a chronic condition. Many of the facilities were gas stations. Many of the grocery stores were gas stations in which there was very little opportunity to purchase things that one would consider helpful in managing diabetes. We are respectful that one of the things that we're going to be looking at and presenting in the final report is outcomes on costs and the cost of doing this type of intervention, the impact on the cost of diabetes, which is substantial. And we just want to give you a brief sense of what we're looking at. Again, what we discovered was that patients were looking at their feet far more often. Why is that a big deal? Well, patients with, first of all, patients with diabetes on average incur costs 2.4 times more than their age-matched cohort. And foot pathology is the most common complication of diabetes, leading to hospitalization. Others may challenge it, but I promise you, foot pathology, meaning ulcers, osteomyelitis, Need for amputation is the most common complication of diabetes down the road, leading to hospitalization, and accounts for 1/3 of the cost of diabetes care. These are roughly the range. Again, this is a rough range of the cost in this country currently of managing an uncomplicated foot ulcer, complicated foot ulcer, and amputation. So I guess I'll leave it at that nice picture at the end. So again, we will be presenting far more detail at the final report, but what the findings that we have are findings that are consistent with other studies on education interventions, and it seems that the initial efforts of Nakanishi in the Assembly Bill can demonstrate that an education program has the possibility of improving outcomes in a very common chronic condition.
Thank you very much, Dr. Nuova, for that presentation. Are there any questions from board members? Dr. Levine?
Have you, and this is a powerful technology applied primarily for an educational purpose in self-care. Have you thought about the likelihood of success of actually using the technology for care delivery and interaction with clinicians?
We have, and I could talk for a long time about that, unfortunately. What was interesting was the lack of interest. I probably need to find a better word than lack of interest, a lack of capacity of clinics to get engaged in this project. It was a big barrier. It's the tyranny of the urgent, all those things, some of the things that got in the way. For example, we went to Visalia trying to, again, we were trying to target a population we thought was important. There was a manager change, physicians changing and so forth. It was just not much of a priority for the providers or the practices. They were incredibly helpful at getting us enrolled patients in the project, but that is a big challenge, and it is a barrier that is difficult to overcome.
Dr. Diego, I'm sorry.
So, like you said, this isn't a good representation of California. Do you think with if you reach out and get that representation, the Latinos, the less educated, because I think you said 76% had high school, do you think the results will be different then?
Hard to say. I've worked with others. I don't know if you know America Bracco from the Latino Health Alliance. In my discussions with her, it is very likely that this type of education program would be effective, but I don't think I think one of the findings that we'll have are recommendations is that we targeted clinics for these interventions to be done. I see no reason why the same intervention couldn't be done at a community center, at a church. I think we would have, one of the recommendations will be just targeting clinics may have been inadvertently a barrier to accessing everybody or a larger population. So if I was to redo AB 329, I would have also targeted churches, community centers, other places where people gather, even grocery stores for that matter, to be honest. I would go right to where people are as a means for improving access to their homes as well. Why not?
Dr. Ganadev?
Just looking at your results, actually they're amazing, but you think there is a selection bias the way just 1 2-hour class you can show statistically significant difference in their exercise, looking at their feet. As a vascular surgeon, I take care of all the complications of the diabetes, including losing toes and feet. So that's why I'm just curious, if you picked up a community centers rather than these clinics where could be motivated, pre-selected patients who are there. So that's what amazes me is the 1 2-hour class can give such a statistically significant difference in a population which is not the population you were looking at when you started.
Excellent point. The concept is called readiness to change or stages of change. 20% of population with a chronic condition are ready and motivated and activated to make lifestyle changes. We selected for them, I'm sure. How do you help the 80% of the population who may feel overwhelmed, who may be struggling with depression, who may be struggling with financial issues, other things that are more important to them, to help move them along. A lot of the efforts that I did mention, America Bracco is an expert on that, is using community activists to help move people who aren't ready to do health behavior change. So yes, you're right. This was a self-selected population. They also had to do an incredible amount of paperwork as part of this. There was a lot of data collection, which is off-putting to most people, and took a lot of personal time and commitment to do that. I'm very delighted and grateful that they were willing to do so. But you're right, this is a selected population.
Any other questions? Dr. Lowe?
So thank you very much for the wonderful presentation, Dr. Novo. As you recall from the last presentation, this is a board-sponsored project of $400,000. Is that correct?
Yes.
So I agree with Dr. Levine that this is wonderful technology looking for an application. And to me, the thing that would make me a believer that telemedicine is ready for prime time is that if with this education you can tell me that the hemoglobin A1C is 8.6 before and 6.0 after. I mean, we need objective metrics to tell us that our investment is giving us a good return.
I agree, and we are collecting that data, and that will be part of our final report, including our specific recommendations. We did do that as part of our study. We did pre- and post-chart audits as part of this to look at hemoglobin A1C as an example metric, blood pressure control, lipid control. We did look at those, Dr. Lowe.
Dr. Carrion?
Thank you, Dr. Novo, for your presentation. Reviewing the success of the telehealth programs around the world, the main reason why they fail is because they don't do what they call a needs assessment analysis. Basically, what you are doing is go to the community and present your program instead to go the other way around and see what are the needs of the community and who is going to pay for that. Because the failure is, the main reason why these programs are failing around the world is financial. Who is paying for these services? And I think the partial success that you are having is because you are going to have doctors and patients who they don't know what is this. And I think it should be the other way around. First, go and see what they need and who is going to pay. Second, you are going to need to do what they call market analysis. And third, your business analysis. That is the process how the experts recommend today to implement a successful telehealth program.
I agree with you completely. One of the specific ways that that was reflected is if I had a slide on the number of clinics that were unable to participate, I think you'd be impressed at the number of places that we contacted and worked at to see if we can get them engaged in this project who are unable to. Most of it came from, again, I call it the tyranny of the urgent, but most of it was the financial piece. We are just in so much chaos right now. This is a low priority for our practice. We recognize that we have many patients with diabetes, but this is not something that's a high agenda item. And we didn't have, we did make queries that will be in our final report of at least what prevented you from participating. But you're right, it would have been wiser from the beginning, and reflecting back on AB 329, to look at more of a needs assessment. What does the community at large really need and want, as opposed to what was part of the project was telemedicine is great, it will do all these improved outcomes, let's roll it out. I agree with you.
Thank you.
Dr. Bishop?
I think your work's great. This obviously is a worldwide, statewide, countrywide problem. Have you considered, or have you already collaborated with others in other parts of the country, other parts of the state? It seems that it would be very cost-effective to collaborate, pool resources. The education should be the same throughout, perhaps different languages. The focus may be slightly different, but basically medicine is medicine, diabetes is diabetes. It just seems to be wonderful if we could collaborate and pool resources and brains.
Exactly, and those are my efforts from gathering all this data is then going with other groups. I'll be presenting this information at the November meeting of the California Rural Health Association. I have colleagues across the state who have similar interest in chronic diseases, so yes, there will be continued discussion. It doesn't end here with my presentation or with the final report that comes with the board.
Is this kind of a groundbreaking thing you've done, or has this been done elsewhere previously?
There are similar types of interventions that have been done in other states, and the findings are pretty close in that, we get people who are motivated and ready to change, make changes when they receive the appropriate information. And oftentimes it isn't generated out of the physician's office.
Do you have any other questions of Dr. Movell or statements? Thank you very much for your presentation. It's very interesting, and I wish you the best of luck as you go forward. It's a situation that what we are finding in society, I think we all know that given the opportunity for education and information, people do want the information, and with that information it gives them the power, the tool to make change. And this hopefully will start to advance that opportunity as we move forward with health reform in general.
And again, on behalf of my team, thank you to the board for your support for this project.
Good luck. Look forward to your final report, I guess. So now we're going to move on to the adoption of emergency contraception protocols, and ask Ms. Harold, the Executive Officer of the Board of Pharmacy, and Ms. Smith-Crowley, representing ACOG, to please come forward and present this item. I would like to remind the board members that this issue has been before us before. We've had lots of discussion on it. It has been very intense, and I would hope that we all realize that now what this means is that we're all on the same page with these revised protocols. So please, your presentation.
Good morning, and thank you very much. This is a collaboration between two key boards where pharmacists will be able to manage and provide emergency contraception pursuant to the protocol that is done by the medical board. So you are adopting a copy of the protocol. We are adopting a copy of the protocol, or you're approving it. We're actually adopting it as a regulation. And so we've made one small technical adjustment earlier this week. I believe Tim is passing it out. It's a formatting issue. Where is he?
Pass.
Okay. It's on the last page, and it occurs in the chart. And it's a clarity issue. It went from one tablet twice a day to 2 tablets. And we've even highlighted the change for you. If I can find it myself. Here it is. Thank you. We have been very pleased to be working with Shannon and her group. We've used the California Pharmacists Association in various phases. We've brought in technical experts to assure that the protocol that is developed is concurrent with appropriate methodology that's out there. And one of the problems we have before is the drug companies keep developing new forms of these things. So just enough to outdate our fact sheet or our protocol as soon as we do it. The last time we did this was in 2004, and it seems to work well. We've had no complaints from any patient regarding implementation of this, which has been now on the books for about 8 years. So I would respectfully request the approval of the medical board, and should you have questions, we have someone here to help.
Are there any questions from any members?
Yes.
Yes, Dr. Carrion?
I am an OBGYN, and I am accustomed to this. Let me tell you what is my personal feeling.
Okay.
I think that we are transferring the responsibility from the doctor to the pharmacist. And this is something that we are going to setting a precedent that in the future we can have problems. If this medication today is going to be handled by the pharmacist, in the future is going to be another medication that maybe also is going to be handled by the pharmacist. If you read very careful the recommendation of Amanda Davis, a pharmacist, she's completely 100% right. Many of the pharmacists today, they feel very uncomfortable doing this. And now, with this new medication by the name Ella that is in the market, is going to bring more morbidity and maybe mortality. This is something that is going to need to be studied very, very careful, the steps that we're going to take. That's all.
Dr. Bishop?
I'm clearly ignorant as an anesthesiologist about this topic. My only concern was, is there any protocol or anything in place to prevent a individual who, well-intentioned but ill-informed, might ask for the same drug from multiple pharmacists and receive an overdose with any toxic consequences?
Well, to a degree, most of this is already, if you're over 17, is already over-the-counter medication already. Dr. Carrion's concern about what we call conscientious objectors, in terms of a pharmacist that prefers not to provide emergency contraception or other kinds of contraception, we have a law that provides that every pharmacist has the ability to decline to dispense such medication. The pharmacy itself has to have a written policy, and they work that out ahead of time so that the patient can still obtain any medication that's been legally prescribed for the individual. But a particular pharmacist does not have to go against his or her moral objections to dispense. And you also asked some technical things, so.
Also, not every pharmacist participates in this program. Pharmacists that do participate have to undergo, I believe it's a 2 hours training. So
they say only 1 hour.
Is it 1 hour now?
I thought it was 2.
But this is in addition to their existing training.
It's only 1 hour, and it's clear here. And in 1 hour, I don't think a pharmacist or any of us is going to be quote unquote an expert giving this medication. Let's go be realistic.
Dr. Carrion, I'm going to have to interrupt you. We've had the discussion of what is appropriate protocols and what is appropriate procedures, and this is for the pharmacy board to regulate their members with. What we're going to be doing now is just adopting the protocol so that they can take care of their half. We're not going to not do this based on, unless the board is going to decide not to adopt the protocols. But the object being is that the discussion has gone forward in previous meetings as to the pharmacist who doesn't want to do this. The issue of what a pharmacist can or cannot dispense is a pharmacist situation. We're not adopting a protocol for what a doctor has to dispense here. We're adopting the protocol to be on the same page with the Board of Pharmacy. Correct? Okay, so I just want to make sure that we're all clear on this, that we're not looking to tell doctors what to do. We're just going along with the protocols that have been agreed upon by the experts, from what I understand. Okay, and Ms. Shipsky?
Yeah, I had a question on the statement that's in here where it has procedure number 3, and I gather this is the direction to the pharmacist to communicate to the patient. But the phrase down at the bottom, other options for emergency contraception include consultation with your physician regarding insertion of an IUD. The inference there is that an IUD is for emergency contraception, and it is not.
I agree with you. Part of this, though, is that we believe, and this is exists pretty much what's been around for a period of time. Keep in mind, this is an update. Right. Part of the concern is that what could have led to the need for emergency contraception was a lack of understanding about various forms of birth control, and I think that's the intent. There's also a fact sheet that has to be developed.
Well, that's the case, though, but it specifically says IUD. There are obviously many other forms of contraception, and so my concern would be if there's some, it just sounds like the inference here is if this didn't work, you need to go see your physician about an IUD, and that might be appropriate for the that patient, and that's not the only form of contraception.
It's a question of, I think what Ms. Shipsky is getting to is why is a pharmacist making recommendations about a medical procedure more than just suggesting the patient see a doctor?
Could we get that struck? Because I just think that that's instructive for a patient that maybe not perhaps be appropriate.
It's 5 words. Yeah. You can approve it by striking that if you wish.
Because you could also bring up abstinence and things like that too, but, you know.
We're not looking to rewrite, okay, that's a good, I mean, you're bringing a good point, but let's get everything on the table, and then we're going to take a recommendation of what to strike, what to leave, and what to move forward with, okay? Is there, Dr. Carrion, I apologize, I don't want to, we're not going to start this all over again. That's my concern.
No, that's fine with me, but this is, I want to bring some points of concern.
Right.
Since this is my specialty, and I handle this every day, okay, I think I am entitled as an OBGYN and as a member of the board express my concern.
Oh, please.
That's all. That's all.
But do it from the perspective of the pharmacist delivering this procedure, and from the perspective of the pharmacist delivering the protocol, not from the doctor's perspective. That's what I'm looking for information on. Do you have concerns about the pharmacist and what the pharmacist is going to do as to the quality or the quantity of the meds, or the giving out the meds to a specific request? Or
yeah, but
okay, please.
The pharmacy is not a place to treat patients. The pharmacy is a place to give the medications that the doctor prescribes.
This is under an emergency circumstance. This is
Yes.
not a regular place that you're going for prescription. This
Yes.
is not that idea.
I understand that it's an emergency. But being an emergency also, if this medication is not given properly, is going to create some morbidity. And the typical case here is this new medication by name Ella, the term you are very familiar, that basically what does is abortion. Well, the literature is very clear that the dosage normally is 30 milligrams, and the research studies show that 1 milligram is enough for what? For depress the corpus luteum. And that is how is going to happen an abortion.
Okay, so let's, 1 second. Kurt?
Madam President, members, kind of stepping outside my sandbox here. I don't often interpret pharmacy law, thankfully, but it's my understanding, Ms. Harrell, that the authority for a pharmacist to prescribe emergency contraception already exists in law.
Exactly.
Okay, and what this is sort of one of the, I guess, methodologies by which a pharmacist can provide EC is if they do it in accordance with the standardized procedure or protocol sort of developed and blessed by the medical board. Is that essentially correct?
That's one way. There's 2 ways. This is one of them.
Okay, so this is one of the 2 ways, but the authority standing alone is already in law.
Yes. Okay. And we've had the protocol. This is really an update of the existing protocol to make it more current.
Okay, so by the board's action today, obviously not to misstate the obvious, but we're not going to overturn existing law where the legislature has spoken. What we're going to do is sort of put our stamp of approval, on you will, on the protocols that would allow, what's that? Revised protocol, sorry. That would allow a pharmacist to essentially dispense EC.
Correct.
Okay.
Okay, so, Dr. Salmonson?
No, I clearly don't have any additional knowledge, but from a procedural point of view. Is the question, I mean, I guess my question now is, what is the medical board's role? It seems the board of pharmacy would be autonomous in this regard, and perhaps our acting on the protocol seems a little irrelevant. Perhaps I'm not understanding the procedure. Who can explain that?
This is an area, and perhaps the attorney can do this. This is an outgrowth of a major policy area going back probably about 2000, 2002. Are you comfortable talking about this, or I can talk about it? All right, about 2000, because patients not getting in to see appropriate practitioners timely. So the accessibility of the pharmacist in an area where it's a pretty clear-cut process, you can develop a protocol. Although under protocol, pharmacists can manage patients for doing drug therapy based on the parameters of the protocol. The intent of this was to have the medical board and its technical expertise develop a statewide protocol that could be implemented statewide, under which pharmacists could provide emergency contraception. And within that, there has to be outreach activities and certainly a fact sheet that's available to the public so that they become better aware of what's being done. In addition, the pharmacist is required to consult and advise. And part of the comment that you indicated was really, it should have been perhaps part of the consultation, not part of the protocol.
Okay, does that answer your concern, Dr. Simonson?
Well, I think it helps clarify.
Good. Okay, so let's move on this.
Sorry, can I have one last
Dr.
comment?
Diego, please.
I just what you said right now is, so the medical board will establish the protocols for the pharmacy then to dispense a medication. In the event something happens, who gets sued, right? If the protocols are under the guidance of the medical board?
It would be if anyone gets sued, I believe it would be the pharmacist that used the protocol. But the protocol is there and it's state policy, and by doing it in this manner, you're basically establishing this is appropriate in these circumstances. And if something goes haywire or inappropriate, then it would be the pharmacist. But again, this is very safe. The FDA has approved it for anyone over 17. In the last couple of years, when this process started, that was not the case.
Okay, so in addition to striking the language of the type of recommendation that a pharmacist would make, that's a medical recommendation, we'll strike that. Is there any other additions to the revised protocols? Are there any public comments on the revised protocols? Oh, Dr. Lowe?
So I too am uncomfortable giving a stamp on this protocol, since this is an area not of my personal expertise. I mean, shouldn't we have people that are expert in this area review the protocol before we give a stamp of approval?
Could we hear from ACOG now?
Actually, again, on behalf of the American Congress of Obstetricians and Gynecologists, we easily spent 40 hours on making these simple changes. And we, in addition, we have OBGYNs that are, in addition to being OBGYNs, have an additional 1 year of family planning fellowship. And so those physicians are the ones with whom we've consulted. And part of the issue is there's a lot of, as Ms. Harold was saying, the science changes a lot, the information that we have changes a lot. So we need to continually update this. But I know through our organization, we have thoroughly vetted this and feel very comfortable with making a recommendation that this be approved by the medical board.
Well, I'm concerned with that point that Ms. Shipsky brought up. I mean, other options for EC include consultation with your physician regarding insertion of an IUD. That has nothing.
That's what we're going to strike.
I know, but the fact that that made it through this committee makes me uncomfortable that it wasn't reviewed in adequate detail. I mean, that thing has nothing to do with the time of day. It's totally out of place. And just the fact that that made it in there makes me feel very uncomfortable.
Ms. Smith-Crowley?
Actually, it is the standard of care for if there is somebody who's had more than 5 days since unprotected intercourse, may have an IUD inserted to help prevent a pregnancy.
That's for prevention, but this is for emergency contraception.
Right.
I think there's a little bit difference there, isn't there?
It's a fine line, I think, isn't it?
Right. Emergency contraception is used to prevent a pregnancy. And there's because of medication, there's a time.
That's already happened, right?
My understanding is this is not to create anything more than the result of a pregnancy. It's not to stop a pregnancy that has already occurred or started the process. This is only if the option would be that you could not get pregnant from, that you might get pregnant from unprotected sex. It's not if you are pregnant. This is not at all to do with that. So the issue is to adopt these revised regulations, that ACOG has agreed and worked with the Board of Pharmacy, and I assume with our Executive Director, Linda Whitney, that the 3 entities that have oversight to make sure that the rules and regulations are as clear as possible as of today. As we go forward in the medical community, there will always be advances and changes. They'll come back and ask again for revised protocols. That the request is that I would like to have a motion to approve the revised protocols. Do you have a motion?
So moved. I do want to make sure that it is a law that emergency contraception can be done by the pharmacist. We know that, and this what I'm looking at, this is pharmacy board and the medical board working together to come up with some standards. That's the only thing I'm looking at in this policy. Anything, nothing more than that, and nothing less. So that's why I'm comfortable in making a motion to approve.
Madam Chair, the only thing that, and I sense, because I'm hearing this from the physicians, that is there any way, though, there could be reference to the fact that if it says where the treatment is, if more than 72 hours, the LA may be more effective. Can there be an indication at the end that you should consult a physician or a healthcare provider? So it's very clear that the pharmacist is directing that person. If in fact this doesn't work, you need to go see a healthcare provider.
That is very clear on the fact sheet that was developed to go with the initial protocol. I just don't have a copy of that with me today, because the intent is not to prevent a patient from seeing a physician. It's to solve the immediate emergency. And then I think part of the reason we've got this in here, and pieces of this are coming back to me. I'm not an expert. We had experts working on it. We are just moving it to you.
I just think under the aegis of the procedure, and it says when a patient requests emergency contraception, the pharmacist will ask and communicate the following.
Right.
Well, I think we should direct that the pharmacist has to also communicate that if this doesn't work, you need to see a healthcare professional, healthcare provider. So it's very clear that the patient isn't just left with, well, if this doesn't work.
My concern is that if it's new or added text versus if it's already in the original protocol, does it assume that it wasn't in the original protocol by inserting it now?
That it was not in the original protocol.
So my concern with the clarification that Ms. Shipsky has asked is then it would reference that maybe it wasn't done, because if you read the modified text on page 2, at the bottom of page 2, it says new or added text is shown by double underlined, thus added language. So it's not new text, it's not added text, it's already existing text. So the idea of adding it now, is that going to predispose people's opinion that it was never there before? And that's my...
Well, Madam Chair, in all due respect, though, however, if this is deficient in any way, and we're being asked to approve it, I think we have to very clearly support the fact that the pharmacist should be giving the emergency contraception. However, if we're giving that pharmacist any kind of direction, the other part of the direction is that the pharmacist shall communicate.
Okay, that's fine.
And a good pharmacist would do that anyway, but we can't assume that.
I understand that. The protocol needs to be complete. So you have had a chance to review this prior to this meeting. This is now a 15-day comment. We've already had the major 45-day. Before we released it, we brought it to you, and I had the pharmacist expert that we brought, this a women's health expert in pharmacology, and then the American College of Obstetricians and Gynecologists. We had Shannon here, and I think you brought an expert actually with you. So we've had some of this discussion before, but like anything else, sometimes subsequent discussion leads to additional points. And so we can refine this a little bit. The intent is not to prevent the patient from getting to the physician if this isn't effective. And in fact, as you say, that would be the normal part of the consultation you would expect, because it's a follow-up activity. How can the patient self-monitor herself in this case? But.
Right. Dr. Ganadev?
I agree with Ms. Shipsky. It's repeating it is not a problem, important point. So even if it was there, if you can add on, I think it adds value. That's all it is.
Okay, so with those additions, Do I now have any public comment or any more comment?
You'll have.
Do I have a second? I had a second. I had Dr. Gonadev and Dr. Manischewski.
Madam President, if I may, I'm going to offer a legal comment. I think the board needs to have a little bit of specificity here about what it's actually approving. So I have on page 1 of 5 on, I guess, the latest and greatest, which is what Tim handed out. My understanding of the motion would be that we are going to strike the words on the last paragraph on page 3, on page 1 of item 3 procedure. It says other options for EC include consultation with your physician, period, and we're going to strike regarding insertion of an IUD. That's what I had. Now I'm a little bit fuzzy about what we're going to, apparently we're going to add something, whatever that is, to somewhere about informing, directing, if something doesn't work, presumably if this emergency contraception doesn't work, we're going to refer that person or the patient or whoever is receiving it to a physician. Is that kind of the understanding? That I'd sure like to know where we're going to put that.
If there's a double request?
No, I'm just
Actually, Mr. Hepler, I think if you end it with consultation with your physician, period.
Okay, so that's the only amendment then?
So if you look at the paragraph that's underlined currently, it says, if more than 72 hours have elapsed since unprotected intercourse, the use of Ella may be more effective than whatever the other drug is. Other options for EC include consultation with your physician, period. We okay with that?
Yes.
Dr. Levine?
I have, sorry, but from a grammatical perspective, consultation with a physician isn't emergency contraception. So I think the language needs to be amended to say, for information about other options for emergency contraception, consult with your physician.
So other options, so read your sentence, please.
For information about other options for emergency contraception, please consult with your physician, period.
Mm-hmm.
Or healthcare provider. Yeah.
Thank you.
So with healthcare provider?
Yes.
Okay, so does the maker of the motion agree to the amendment?
I do.
And the second? Yes. Any questions, any public comment now on the new revised? Dr. Salmonson.
That's a question. How is the consumer to know whether it worked or not? I mean, are they told like there's a missed period, they should go for a pregnancy test anyway, they should buy a pregnancy test kit and do their own test?
I believe that's in the fact sheet.
That was in the fact
But
sheet.
I have a comment. I think that the obvious would be not just other options, consult with your physician, but if the person is going to get emergency contraception somewhere, they should say, it should be said, and consult with your physician.
You should follow up no matter what, right?
Exactly. No matter what, here's your pills now, you make an appointment with your physician.
To see,
or health, I'm sorry. With your
but you need follow-up, right?
healthcare
Just don't
provider.
take the pills.
Regardless.
Wing it.
Yes, regardless.
I get a dime every time I say that. From whom?
Okay. So, Dr. Levine, you want to revise your correction?
Sure. Okay, so
Today?
Dr. Levine, if I may, if you would leave under the 72 hours alone and just ask to add a second or another paragraph that would specify that, because what you're talking about doesn't really relate to 72 hours.
right. So, so are you saying take out the whole second sentence?
No.
Okay, so leave for other options for emergency contraception, consult with your physician, period. Or healthcare provider. Another dime. We're going to have a penalty jar.
No, it's kind of like anytime you use the committeeman, it's committee person or
Right.
chairperson, same idea.
So, I'm being re-educated here. And then a new sentence that says, please follow up with your physician
Or healthcare provider.
after the use of emergency contraception.
How soon should they follow up for a pregnancy test?
We're talking about human beings here that are walking into a pharmacy. We're not talking about micromanaging what they do or what they don't do. The object is to give them some tools to make the right decisions. Going and meeting with your health provider is a tool. Whether they do it or not, there's not a gun to their head. I mean, we have had a horrible tragedy in this country today, for those of you that don't know about it, and anything we can do to get away from the use of weapons, I'm right there right now. So let's get this moving, because it's starting to... I'm going to tell you, the vetting of the language, we understand what you want on there. We understand very clearly what is to be there. The physician and healthcare provider to be part of the mix. So you're going to put a paragraph, put a sentence in there, making sure that happens. Now,
actually 2 sentences.
Put 2 sentences in. Put 3 sentences. But that's 2 sentences. We're going to agree to 2 sentences. Okay?
Got it.
But I'm going to tell you, I can't get through this meeting if we're going to spend 2 hours on who and how often and who's going to open the door on which side of the store. And I apologize, but this is starting to, we need to move this forward. I'm sorry, we really do. This has to come back? We're going to have to do this again?
Well, we can take this as a final motion. We can bring it to our board. Our board's going to have to notice it. Then it'll have to be released for comment again. We're running close to the 1-year date that we have to do for the regulation.
That's what
anyway.
I thought.
And so there is a risk, because our next board meeting is the end of October, much like yours. And so we met earlier this week.
So then if you want it back to this, you want it to come back, it can come back. It's the same time of the year. I thought we were supposed to do this today.
I don't think it would need to come back unless our board changes it or we get additional comments.
So let's we have a motion to adopt. We have a second to that motion. We have clarification of the language. We've asked for public comment. All those in favor of the motion with the additions and corrections and grammatical improvements and inclusion of healthcare provider, please say aye.
Aye.
Any opposed?
Aye.
Okay, any abstention? Okay, 2 abstentions, 1 opposition. Okay, thank you. So now we're going to continue on the agenda. With Ms. Smith-Crawley, no, apologize, Ms. Harold.
Thank you. And thank you for your comments. Doing regulations is sometimes messy. This has not been too messy yet, so thank you very much.
Oh, this has not been too messy? Excuse me.
If they all go this difficult for you guys, you ought to come watch what it's like for some of us sometimes. So, no, thank you very much. This is part of the process, and you want to develop the best regulation possible for the public. So this is part of the process. I've been asked to provide a brief update on, and I heard the brief, update on what the Board of Pharmacy is doing, where we interact with the Medical Board of California. Our board is very excited to have this opportunity. Ms. Whitney came to our board meeting earlier this week and provided an update on some of the activities that the Medical Board's doing with us, and now it's my turn to reciprocate and provide you with a brief update on what we're doing. There is a lot of overlap, and where physicians and pharmacists need to be working together more, and so we're very appreciating of this opportunity. So the biggest thing for us right now, I suppose, is the possible means by which we deal with cures. There is a bill in the legislature that I'm sure is on your agenda. Mr. Desaulniers has a bill in where they're looking for funding. It is coming near the end of session, and we're not sure what's going to happen with that particular bill. But the concern is the CURES program, which is a very vital program, certainly for our board, and I understand that you use it very similarly to the way we do, may have trouble with its funding in the next year or two. So they're looking for funding sources as an alternative to shutting it down. So the Board of Pharmacy voted to approve or provide a support position on SB 616 the other day, which basically commits us potentially to having a fee increase for our pharmacists down the road. There's no fee amount out there. It's a $5 a year fee right now is what they're proposing, but there is buy-offs from other sectors that have to be involved. But the Board of Pharmacy, which has relatively low fees anyway, is very interested in ensuring that program continues. We use it to trigger investigations and to amplify investigations. So, are there any questions about Cures or our role there? We provided the initial funding about 15 years ago for the program to get it automated. Now it's near real time, and the last step is to make it more user-friendly so that when you're seeing a patient or when you're dispensing a drug, you can quickly access and see where that patient has been in the recent past or even as long ago as a year. So we're very interested in that. In that vein, we're also talking about a pain summit with the medical board, which, have you discussed this at all with your board?
Yes, but it's our next agenda item.
Oh, your next agenda. Okay, so I'll hold off on that one. The other thing that I would like to mention that's coming up for the Board of Pharmacy, we are walking into pharmacy practices. We are discovering in skilled nursing facilities. We're discovering in hospitals. We're discovering in various environments that there are various forms of automation equipment that are out there. They take a Pyxis machine and go way beyond what a Pyxis machine does in a hospital. Existing California law with respect to automation is relatively restrictive, and so it outlines the specific components that you can have in any kind of automated dispensing device in any particular environment. And what we're finding is we will walk in during an inspection, find a machine that has features or very broad features that are not covered in existing law. So we are going to hold a one-day summit where we're going to invite various technology vendors to come in and show us what they have. We will in advance have a list that, for example, in a skilled nursing facility, it's got to be pre-labeled, it's got to be this, it's got to be that, and a pharmacist has to check it or whatever the requirements are. There are means by which you can do video release of medication. So you've got a pharmacist in a pharmacy and in a clinic hundreds of miles away. The pharmacist can review the patient's chart, the medication, and then release the drawer that has the drug. But there are machines that go far beyond that now. And so what we're going to do is set it up based on the environment in which the machine is set. This is what law provides for. This is where the machine does not fit. And then hopefully let them take legislation next year to advance it so that technology can help us all provide better care to patients. But it needs to be done appropriately. And so we don't want these machines out there that are not authorized for use. And for us, it becomes a very difficult thing to shut down somebody that's spent me a sizable chunk of money to put this machine in, only to find out that they can't use it. So we're trying to do this in the openness of sharing what's going on. So they've got machines that do IV compounding, all kinds of things. So that will happen on October 24th in Sacramento in the main Department of Consumer Affairs building. So,
any questions of Ms. Harold? Dr. Dussault?
On the Cures, back to Cures, has Cures considered pursuing an FQHC status where perhaps if would be granted, it would have funding stream for the pharmacy piece of it?
I'm not quite sure what kind of funding that is. I'm unfamiliar with the acronym you used.
That's the Federal Qualified Health Care status.
The Affordable Care Act money. Not that I'm aware of, but this is a system we all use. All practitioners can access it for their patients. We access it for our dispensers.
I see.
Any other questions on this specific item? Okay, we're going to continue with number 7, update on controlled substance forum, and Ms. Whitney is going to participate with Ms. Harold, please.
Good morning. Ms. Harold and I discussed this item with the Board of Pharmacy. To lead into it, I would like to let you all know that we have a retired annuitant, Janie Cordray, who is the main staff person who has been working on this to organize it for the two boards to make sure that we have the correct content, that we'll be able to contact the correct individuals. As a retired annuitant, there is a potential that her position will not be considered mission critical by the administration. We certainly do consider it mission critical because we find that the controlled substance issue is very, very important to discuss with the prescribers as well as the dispensers. So with that, any update on how we're doing with the forum that you want to talk about?
No, I think at this point we've got our board presidents very interested. It's only been staff discussions at this stage where we're discussing where we're going with the forum, and we intend to broaden it a little bit in the future. But at this stage, we're still trying to figure out dates. We're still trying to figure out where we're going. But every day it seems that we're finding increasing evidence of the widespread problem with prescription drug abuse in this country, and particularly the diversion of controlled drugs. And it's becoming a real problem.
We did mention at one point in time we thought late November. Unfortunately, one of the speakers that we really wanted to have at the meeting, Dr. Fishman, will not be available. So now we're looking at the first part of 2013.
But the goal is to really address some of the issues where we have common overlap. Some are more specific to physicians and other prescribers. Some are a little more specific to pharmacies. But the overall goal is to ensure patients that have pain needs get pain treatment, and those that are abusing the system don't.
Madam Chair.
So to remind, one second, Ms. Shipsky, to remind the board, this board did participate and did conduct a pain summit several years ago. It was done by a task force with a roundtable with all engaged parties, including people from OxyContin, from whatever part of the country they were in, doctors that dealt with intractable pain, and to set up protocols. And that was exactly the same issue then. I guess it hasn't gone away. That patients that have pain need pain medications, and doctors will not be punished as a result of having a treatment plan, a good faith exam, and all the regular protocols, what a doctor does in their practice in order to ensure patient safety. So I'm sorry that this is continuing, that this is an issue that hasn't gone away, but I'm glad you guys are in the process of addressing that. So,
and I'm
Ms.
wondering
Shipsky?
if that note in a future agenda item, what we could explore is the County of Alameda just passed an ordinance called the Safe Disposal Act, where they're going to be requiring manufacturers of particular prescription medication to have a program whereby they take back the medication, the unused medication. And it's not just an issue because people are getting access to it, but it also is an environmental issue because these medications are being dumped into the water system. So I think it might be helpful, and perhaps maybe we could work with the Board of Pharmacy to really try to promote that, because as a local official, we have difficulties. We've had the water tested, and medications have shown up repeatedly in the water system, and so this might be something we
It might be interesting. Los Angeles County also does some things with pharmacies taking back meds. And
they're
there might be-
requiring the manufacturers to actually
That's even better.
provide some kind of process by which the unused meds can be disposed of safely.
So we'll put it on an agenda item for future comment.
Yeah, there are a couple of items in there. At the end of September, any of you that have unused samples, it's really aimed at the public, but the DEA now has sponsored drug take-back days to help take these drugs out of circulation. Because for patients, if they have unused controlled drugs, they can't give them to a pharmacy, they can't give them to anyone else. The only destruction method that the DEA and the FDA both recommend is to wrap it up in duct tape with kitty litter and throw it away. Right. And but it's to make it unpalatable so it doesn't become a substance abusing risk. But the real problem we've got, and Alameda is looking at product stewardship, which is going to have the producer pay for the cost of destruction.
Absolutely, because you have to pay for the
which is-
law enforcement that needs to be present. We do these take-backs as well, and so that's the other aspect of it.
So it might be very helpful is that when you come up with things like this through your board and your information, that you share it with our board, so we can put it on our webpage, we can put it out as an alert to our constituents, our doctors, and our consumers, and that way sharing of information is a good go-forward basis to promote good public policy.
I will say that in the future, you can expect to see more in the area of appropriate drug disposal for the public, as well as for example, residents care, the residential care homes, and especially the skilled nursing facilities, where there are just tons, literally tons of drugs that we don't have a good way to dispose of. And they're over-dispensed at the one end, but then you become a destruction issue. And we really, even with the collection boxes, California hasn't addressed the issue at the level it should. And that's something you're looking at that I know we're going to be involved in next year.
That and syringes, because as a requirement
The
now
syringes are a
that
huge
they
problem.
cannot be put in the trash, and so we've got a problem
We have a
with
problem
consumers
with
who
that
have
in
no
LA
place
too.
to put them.
And there's a real substantial health risk to anybody downstream from that.
Okay, thank you very much. Dr. Carrion.
Yeah, a brief comment. I think this is the second or third time that we get an update. I think that we should take action, and both boards, we should try to get this forum as soon as possible. Experts we have around the country and around the world. If Dr. A is not available, well, bring Dr. B. But this is just delay and delay and delay. Please, let's go take action in this forum and let's go get some results.
Okay, Linda, here we go.
You've got your marching orders. Thank you. Thank you, Dr. Karian. Okay, so thank you very much for being here. Thank you very much for your report. Anything else? So now we're going to, yeah, right. Now we're going to move to item number 8. And Dr. Lowe.
Thank you. I'd like to call our Chief of Licensing, Mr. Kurt Warden, to help with this presentation. The agenda item is the Special Faculty Permit Review Committee update. And just as an overview, the Special Faculty Permit is a section under 2168 of the Business and Professions Code that allows an internationally trained physician who is sponsored by the dean of a California medical school and has been recognized academically eminent in his or her field of specialty by the Medical Board of California. So that allows them to have a permit that authorizes them to practice with all the rights and privileges of a California medical license only in the sponsoring medical school and its formerly affiliated hospitals. So with that background, we had a committee meeting on let's see, what date was it? June 14th, 2012. We reviewed 3 applications, one from UCLA, one from UC Irvine, and one from UC San Francisco. So our first candidate that I'd like to present is Dr. Ursiz, and Mr. Warden will present his background.
Okay. Dr. Ursiz's specialty area of expertise is liver transplantation, more specifically in situ splitting of a liver for transplantation. Dr. Ursiz attended and graduated from the Istanbul University of Faculty of Medicine in Turkey. He obtained his postgraduate training at the same university from 1982, and also at the Selisa Efta Hospital of Istanbul, and he provided training from 1982 through 1991, including the transplantation surgery, which was done at the last 4 years of his training from 1987 to 1991, and hepatopancreatobiliary surgery unit. He's had visiting institutional appointments at UCLA as a visiting research scholar in 1992, a visiting associate researcher in 1995, 1998 as assistant clinical professor of surgery, 2003 as an assistant adjunct professor of surgery, 2004 associate adjunct professor of surgery, 2007 adjunct professor of surgery, and 2011 he's been appointed as the health science clinical professor and professor of clinical surgery. Dr. Ursiz is known throughout the United States and internationally as a leading expert in situ splitting of the liver for transplantation. He has trained 43 fellows who have completed 2 years of fellowships and is currently training 3 more fellows at this time. Dr. Ursiz has performed 18 lectures and presentations in the U.S. and internationally, and also provides consultation services regarding liver transplantation for the One Legacy Liver Advisory Committee since 1999, and has approximately 60 peer-reviewed publications and has written chapters for 7 different liver transplantation books, and has written 1 guidebook on liver transplantation. And that concludes my presentation. Dr. Ursiz.
Okay, so the committee is comprised of a member from each of the California medical schools, myself, who is chair, and Hetty Chang, who is a member. And the committee voted to recommend that the board approve Dr. Ursiz for a special faculty permit, and so I would like to make that motion.
Do I have a second? Second. Do I have any discussion on the motion? Do I have any public comment? Do I have any comments from any of the members of the committee? All those in favor of the motion, please say aye.
Aye.
Any opposed? Okay, thank you. That one is done.
The second candidate is Dr. Galicetti, who is from UC Irvine.
Okay, Dr. Galicetti graduated from the University of Rome, was Spezia Faculty of Medicine in Italy. He also has a PhD in education as a molecular physiology and biophysics from Vanderbilt University. He did his postgraduate training in Rome at the same medical facility that he graduated from 1986 to 1993. He's done postdoctoral training in research pulmonary, exercise science and pulmonology, molecular physiology and biophysics, and also endocrinology. I forgot to mention that Dr. Glicetti's areas of expertise is pediatric diabetes, endocrinology, metabolism, and obesity. He has a institutional appointment at Vandenberg University since 2001 as a research assistant professor and Division of Diabetes and Endocrinology. 2002, he's assistant professor in residency at Department of Pediatrics at the University of UCI. In 2005, he was a professor at the Department of Pharmacology. 2007, associate professor in residence in Department of Pediatrics and Pharmacology. 2011, associate professor as in residence and Department of Pediatrics and Pharmacology. Dr. Gliccetti has been awarded research awards from the Southern Society of Clinical Investigators and the Outstanding Young Investigator Award from his from Association of Patient-Oriented Research in 2001. He is in receipt of the prestigious NIH K24 Mid-Career Award that recognizes both scientific innovation, outstanding mentorship, and clinical transitional research. Dr. Glicetti's research has been published in scientific journals, and he has served as a peer reviewer for over 30 different scientific journals himself. Dr. Gillespie has 81 peer-reviewed publication articles and 18 articles for books chapters. This concludes my presentation, Dr. Gliccetti.
The committee recommends that the board approve Dr. Galicetti for a special faculty permit, so I make that motion.
Do I have a second? Any public discussion? Any discussion from any of the members? All those in favor, please say aye. Aye. Any opposed? Thank you. That carries. Dr. Lowe, continue.
The final candidate is Dr. Cilio, and he's from UC San Francisco. He is a pediatric neonatal neurologist. Very unique field.
Okay. Dr. Cilio, as Dr. Lowe said, his specialty is pediatric neurologist with a specialty in neonatal seizures. She graduated from the University of Rome, and I don't know, La Spezia in Italy. She also has a PhD. She graduated with a PhD from the University of Harvard in pediatric sciences and graduated from that in 2002. She retained her postgraduate training from the same university in Rome for neurology. She did other postgraduate training at the Catholic University of Louvain in pediatric neurology. She did in Belgium and also followed up on more pediatrics in Belgium in that same hospital, and did a final postgraduate training at the Bambino Gesù Children's Hospital in Rome in pediatric neurology. She also has done specialty training in neurophysiology at that last same hospital. She has she's at the University of San Francisco, University of California, San Francisco. She has the visiting professor appointment since 2008, associate professor, 2009 as associate adjunct professor, and 2011 as a visiting professor. Dr. Slow has been invited to make presentations in the U.S. and internationally on 45 occasions. She has 34 peer-reviewed publications. She has 6 books and/or chapters for books. She was awarded the presidential chair from UC San Francisco in 2011, which calls for her to develop and implement interdisciplinary program for neonatal neurophysiology. Dr. Cilio is the project leader and principal investigator for the prestigious multi-center research grants with the European Commission and the Italian Ministry of Health for rare neonatal neurological disorders and genetics for the basis of neonatal seizures. This concludes my presentation.
Thank you, Dr. Lowe.
So the board also recommends that we grant her a special faculty permit, so I make that motion.
Second? Okay. Any public comment? Yeah, Dr. Board comment, sorry.
This is the last candidate, that's why I just want to ask the committee, is there a limit, the number of people who can do this in each medical school? Is there a requirement of ABMS certification, any of those, or is there a limit how long these people can be in practice?
There is no limit. The requirements are exactly what I stated, and that is that the committee, which is comprised of somebody from each of the medical schools, that the person be internationally trained, sponsored by the dean of the school, and recognized as academically eminent. And so that's pretty general, and so the committee is very specific, and they look it over very carefully, and when everybody decides and agrees that they are, then they get a permit. So in the entire history of the program, there have been less than 25 total. So there's not a lot.
Yeah, that's my concern there was that if the number is high, it's an unfair advantage we are giving to one segment of physician employers, not to the others, and also unfair advantage we're giving to a certain number of people compared to anybody else who wants to come to California. So that's
These are individuals that are practicing only in the hospital, university hospital situation. So this is only a hospital-based practice, hospital-based education. This is not to any other general hospital or any other general community. These are preeminent people that are only practicing in a hospital-based and teaching in a hospital-based situation. So understand that very clearly.
Yeah, Madam Chair, I got that very clearly. That's where I was showing that it is somewhat of an unfair advantage to those institutions compared to the others. That's all I was pointing out.
They have an unfair advantage because they are the teaching hospitals in the state of California. It's sponsored by the state of California.
And also,
legislature said so. That's why they are special.
I would take exception that it's not an unfair advantage. I don't think that any of these...
I apologize. That was meant tongue-in-cheek. Because
I don't think that any of these
unfair advantage
candidates would entertain the thought of going into private practice or working in another institution. I mean, if they wanted to work at the Mayo Clinic, I'm sure, which is, an academic institution, but, well, they have a medical school, but let's say like the Cleveland Clinic or something, a very eminent clinic, they probably could get some kind of permit to work there as well. So I don't think that these are people that would be interested in working in private practice. So it's not really an unfair advantage. I mean, their focus is so unique and specialized, it's a very unique situation. So the final thing that I'd like to do is the University of California, Irvine has requested that their member be changed.
Wait, excuse me, Dr. Lowe, we haven't voted on your motion.
Oh, I thought you did.
No, we've had
Okay.
discussion. Any other discussion from any board members or any of the public? So all those in favor of the motion as stated, please say aye.
Aye.
Any opposed? Okay, now you may continue,
Well,
please.
see, his discussion wasn't related to that, so I didn't think, I thought we had
I
approved it.
apologize.
So, sorry. Anyway, the University of California, Irvine has requested that they change their committee member from Dr. Hubble to Dr. Wadi Najim, who is the Dean of, Associate Dean of Academic Affairs. So I'd like to make a motion that we approve that change.
second.
Do I have any discussion, any questions, board members? Dr. Diego?
What was the committee?
Special Faculty Permit Committee.
That one, okay.
That committee. So they just want to change their member from,
So do all those universities have somebody sitting on this?
yes.
All right, very good.
Every university in California with a medical school has a member on it.
And
And
most
the
of them,
member is some kind of a dean.
yeah.
Okay, thank you. All those in favor of the motion? Oh, excuse me, did I have public comment? Any public comment? No, thank you. All those in favor of the motion, please say aye.
Aye.
Any opposed? Thank you. Dr. Lowe, before you start on agenda item number 9, I just want to have make a remark. And I want to thank you for, take a moment and thank you for your time and commitment to the Physician Assistant Committee. I know that in January, with the inordinate strain on your time commitments, that you asked to be able to take leave of chairing this committee, and I want you to know that on behalf of this board, we thank you for your dedication. Finally, now that I understand the process, we've heard, and I looked into I would look to any physician member sitting on this board to participate as chair of this committee. I'd like them to let me or Ms. Whitney know about that, and we will figure out if we can get you confirmed by the governor. So now moving on to number 9, I want to thank you seriously. But now you're going to be relieved after this meeting, I promise.
Thank you.
Relieved to be
I've
relieved.
enjoyed working with the people from the PA committee. It's just that there's so many demands on my time, and with this new business in enforcement that's taking so much more time, it was impossible for me to go to all their meetings and to perform adequately. Anyway, so the PA committee update for today is that the meeting was held in May, and since the last medical board meeting, about 175 licenses have been issued by the PAC, and there are now over 8,500 PAs licensed in California that are current. They have 70 complaints pending, 25 investigation cases are pending, and there are 45 probationers. 24 cases are awaiting administrative adjudication at the Office of the Attorney General. At that last board meeting, they considered a regulatory change dealing with personal presence of a supervising physician. Remember that the medical board is responsible for regulation regarding scope of practice issues, and we're going to hear about that on the next agenda item. Upon review of the draft language, the board members requested that the PAC review and revise the proposed language to address the Medical Board of California's concerns and resubmit the revised language at a future medical board meeting. There was further discussion, and it was suggested an informational presentation be made to the board regarding the PA scope of practice. So we're going to hear that next. The PA regulatory proposal dealing with preceptors in the PA training program was modified to address the concerns raised by the CMA and the California Academy of Physician Assistants. This proposal currently is out for a 15-day public comment period. Next, the PAC is working on to incorporate the uniform standards of SB 1441 for substance abusing licensees into the PAC model disciplinary guidelines. The PAC held an interested parties workshop on May 15th to discuss incorporating the uniform standards. Draft language is being developed. In regards to the sunset review for the PAC, this bill is currently moving through legislative process and incorporates several changes to the PAC, including the name change from the Physician Assistant Committee to the Physician Assistant Board, inclusion of Section 800 reporting requirements, and changing the composition of the new board, which the executive officer can discuss in the next section. If passed by the legislature and signed by the governor, the new board would be in existence till 2017. Lastly, the PAC is considering implementing an examination for new applicants for licensure, which would focus on the laws and regulations governing the practice of PAs in California. That concludes my report.
Thank you very much, Dr. Lowe. I'm going to call up number 10 to discuss the physician's scope of practice. Ms. Portman, the Executive Officer of the Physician Assistant Committee, and Ms. Grivet, the member of our Physician Responsibility Committee and a physician assistant as well. Please, thank you for being here today.
Thank you. Okay.
Sometimes.
Good morning, thank you. I'm Alberta Portman, Executive Officer of the Physician Assistant Committee. I'm here to provide you with some information about the PA Committee and the profession. First, I'll provide you with information about the history and current status of the committee. Later, Beth will discuss with you the PA practice from a licensee perspective. The PAC was established in 1975 after recognition that there was an increasing shortage of healthcare services in California. The goal was to enable physicians to delegate healthcare tasks to qualified PAs. There have been changes to PA laws and regulations throughout the years that have encouraged and allow for greater utilization of PAs in California. For example, increasing the number of PAs a supervising physician can supervise from 2 to 4, and a revision to chart signatures 10% to 5%. The PAC currently has 9 members. We're a healthcare-related committee that's part of the Department of Consumer Affairs. As you can see, we have a physician member from the medical board, and we currently have 3 to 4 meetings a year. As Dr. Lowe mentioned, our Sunrise bill is currently going through the legislative process. That would change the makeup of the committee to include 5 physician assistants, 4 public members, and retain 1 medical board member who would be a non-voting member of the committee. As with all other boards and committees within the Department of Consumer Affairs, our mandate is consumer protection via licensing, discipline, etc. As Dr. Lowe mentioned, we currently have 8,500 licensees, and we issue about 55 licenses per month. Additionally, we are also mandated by law to maintain a drug and alcohol monitoring program. Currently, we have about 24 participants in that program. As you can see from the screen, our priority for the committee is protection of consumers through licensing, education, and objective enforcement of the PA laws and regulations. The Physician Assistant Committee and the Medical Board of California have a unique relationship. As you're aware, a PA may only practice under the supervision of a physician. As part of our ongoing relationship with the Medical Board, we have agreements to maintain our information technology system, as well as having the Medical Board staff handle our complaint and investigative services. The system works well since oftentimes complaints involve both a supervising physician and a physician assistant. I would just like to take a moment to thank Dr. Lowe for his participation on our committee since he was appointed to the committee in 2008. We have enjoyed his time and sharing of his knowledge while serving as a member. This concludes my presentation. If I can answer any questions for you.
Are there any questions directly? No, continue, please.
Thank you.
So we're just having a technology realignment.
I'll just introduce myself. I'm Beth Grivet. I'm a practicing physician assistant in family practice in Orange County, and I appreciate the opportunity to share a little bit about the origins of the profession as well as the scope of practice of the physician assistant. I think what I wanted to do is just kind of give a real brief overview. I know there's members of the committee that use physician assistants and public members or members of the audience that do, but I think it's worth going a little bit into depth about our profession and our relationship with physicians. So as Ms. Portman said, we always work with physician supervision. We really promote the physician assistant physician team, and we do provide a broad range of diagnostic and therapeutic services. We can basically be found in just about any medical specialty and any practice setting. So anywhere a physician practices, we can practice in that area as well. Our duties also include education, research, and administrative activities. Where our profession came about is kind of interesting. We basically the first class graduated in 1967 out of Duke, as really sort of an answer to what to do with corpsmen coming out of Vietnam who couldn't practice as a civilian. So when they graduated, the first class was just 3 students, but they were all military veterans. And we've grown now to, I think even 156 is inaccurate. There's probably closer to, I think there are over 160 education programs in the United States. We currently have 9 accredited programs in the state. And as was mentioned earlier, about 8,500 licensees, which makes up about 10% of the population nationally. So our education is a little bit varied, and the interesting thing with our education is we've always been very competency-based. There has been a move now to introduce the master's education as the entry-level education for PAs, but there are many PAs practicing that do not have a master's degree, myself included. And I think it's important to realize that we have traditionally allowed education to move forward in various settings to increase the diversity of our profession. And we're actually very proud of the fact that we can maintain standards through our certification and our high level of education through our accredited programs. The programs last about 24 months on average. There's 2 to 3 year programs out there, but the first year generally is a didactic on core sciences, and then the second year is generally rotations. Physician assistant students go through usually 4 to 6 week rotations at various sites, and we basically act like an intern or resident and work on the team providing services in the hospitals and outpatient settings. The reason the master's degree is such a vital component of the structure of education in this state is the first 3 programs listed here, Stanford, San Joaquin, and Riverside, are actually on the chopping block because our national accreditation for PA programs will not allow a physician assistant program to continue to exist if they cannot provide a master's degree by 2020. These colleges do not have a mechanism to provide a master's degree because they're not master's level institutions. And so these 3 programs, although they provide education less expensively and to a more diverse population, may cease to exist in the next 8 years. We also see, currently we have 3 programs that are seeking accreditation in this state. And probably we will see a few more. Initial licensure is granted through obtaining certification on a national basis, and in order to obtain certification, a PA must graduate from an accredited PA program and must also pass the national exam administered by the National Commission. In order to maintain your certification, which is the PA-C, you must log 100 hours of continuing education every 2 years, and you must sit for a recertification exam every 6 years, although in 2 more years we'll be going to a 10-year cycle for national certification. However, this state and a few other states in the country do not mandate that you maintain national certification, and in response to that, the PA committee passed regulation a couple of years ago that does require 50 hours of continuing education every 2 years. So if you see a physician assistant that just has PA after their name without the -C, it means that they're meeting that requirement through the state, but they're not maintaining their certification for whatever reason. So PA duties vary. We can certainly do history and physical exams. We can order and interpret labs. We can develop and initiate treatment plans, provide patient education. In this state, we don't write prescriptions. We write drug orders, but they look a lot like prescriptions, and they take them to the pharmacy and fill their medications with them. And we can perform minor outpatient surgical procedures and first assisted surgery. I will make a point, since part of the presentation was regarding surgery, is we can never be a primary surgeon, and as long as the patient's under sedation. So when we talk about minor outpatient surgical procedures, PAs can perform any kind of surgical procedures as long as it's in the scope of their practice, as well as long as the patient is not under sedation. So, but in the surgical suite, we can first assist. We do still see about half of our PAs that are in primary care specialties, and we are getting about 55 applicants each month that are newly licensed in the state. I just want to bring a couple points. The physician assistant used to have a supervising physician that was licensed as a supervising physician. That went away probably 10 years, 12 years ago, where there's no additional now application for physicians to become physician assistant supervisors. And so now, as long as you're in good standing with the medical board, you can supervise a PA. We do have a delegation of services, and that does delineate our practice, and our scope is limited to the scope of practice of that physician. And I think that that's a really important concept. Even if I'm totally competent to do a procedure, if my physician that I work with that's not part of their routine practice, I can't perform that while I'm under their supervision. And again, we don't use the word independent, we use the word delegated autonomy, because we do work with a physician, and we work also, in the eyes of the law, we're considered an agent of the physician. So orders that come from a PA would be treated as if they were given by the physician. And a supervising physician can supervise up to 4 PAs at one time. Again, the supervision requirements, just briefly, I know Ms. Portman alluded to a little bit, there's a 5% chart co-signature and review. All Schedule II medications the charts must be countersigned within a week, and we do work off of protocols, and that has to be mutually agreed upon with the PA and the physician. Reimbursement payment goes to the physician. Basically, Medicare allows for a deduction of 15% when a service is provided by a PA. And I think the most exciting thing for me in the profession right now is some of the challenges and opportunities that are available with healthcare reform. I really see the physician assistant focusing on prevention, a lot of the chronic care management, performing annual wellness exams for Medicare, and focusing on quality metrics and patient satisfaction. I think part of our challenge is making primary care more attractive to PA students. And if you can precept a student as a physician and show them how exciting and fun family practice can be, I think that that's the big challenge that we're all facing, and trying to open up their eyes to that ability. Our compensation, although the curve is not quite as steep, but it follows along physician salaries. So if you're working as a plastic surgery PA, you're making more money than I am.
Isn't that the case, right?
Yeah.
It's a challenge for all of us. Thank you.
Dr. Ganadev, and then Dr. Diego, and...
Yeah, actually my group has been employing physician assistants for about 30 years. And also we train the students from Longland and Western U. It really works out well, and we have a residency program in surgery and orthopedics, like Dr. Bishop mentioned. The specialty training is getting more and more in physician assistants, and my group, my physician assistants actually do well in burn unit, well in ICU, and well in surgery. So I think it works out. It's a very good relationship, actually. My question is, though, when the new board comes on in 2017, would it have any relationship with the medical board, or is completely separate? And those are the issues I was thinking. Wanted to know.
Well, the new board will continue. This Sunrise bill will just extend the board until 2017, when another review will be done. So we will continue to operate as the Physician Assistant Committee, although we may be called board if the bill goes through.
It's just to extend their ability to continue doing what they're doing today. Dr. Diego?
Having trained 7 physician assistants in my career, and having only 3 of them stay in primary care just drives me crazy. Mm-hmm. Is there a mechanism for the other specialists to train these guys? Because, quite frankly, I've said no more. That's it. I'm a primary care provider. I totally believe in that. So are the specialists in the burn unit and those helping with the training? Or is there a mechanism to make sure that happens?
I'm not sure. Helping in the training to get them to stay in primary care? Or?
No, just the training. Initially, the training was all set to be primary care-based focus, right?
And
then they left.
Right. So the question is that have you stepped up to the plate to request from specialty organizations, specialties to step up to the plate to help with the training of PAs?
Absolutely.
So that if plastics want to have plastic PAs, they don't go through primary care training to get more money?
Madam Chair, I can answer that. Actually, now there are PA residencies. That's what I was talking about. We have an additional year of training in general surgery, orthopedics, OBGYN. So this is after the PA school. So there is, that's what the specialties do. So the advantage of that is when, if I want to hire a physician assistant, it's so easy to hire somebody we trained so that they can work with us.
So I think that Dr. Diego's question was, is that the beginning of training starts off in the general practice, family practice consideration office for training? No? They automatically go into a training program in plastic surgery? Or
they have 1 year of clinical training, and that will go through multiple rotations, just like a medical student does, surgery, family medicine, internal medicine. So that's the part of the school 1 year training. Then if they want additional training, that's when they do
okay, then I understand. Thank you.
The other mechanism to do that, there are some core rotations that are mandated by the accreditation, to keep the PA program accredited, but there's some flexibility. So if a student knows they want to go into a certain specialty, they can request additional rotations during their original training.
Ms. Chang?
I'm just trying to figure out, the number of PAs is 8,500, and the number of physicians in California is 125,000. So are we looking at 1 to 10 physicians are actually using? Is that 1 to 10 or 1 to, I was using the calculators trying to figure out what
I don't know, some do and some don't. I don't know that there's a correlation.
No. Now, I guess, so the law says 1 can supervise 4 is actually pretty reasonable. Okay. Now, does the DO, this is a different question, I know the DO uses PA too. Is there a percentage differences or anything like that?
There's no difference from our standpoint as far as who can supervise. It's difficult to track who's supervising because they don't have to apply for licensure any longer. So I couldn't tell you how many physicians are supervising PAs because no one knows.
I have a question to you, for you on when you were speaking about the schools that might have to close as a result of not having a master's program available. The educational system in California has some creative mechanisms by which, if you're admitted to school A, you're guaranteed admission to school UCLA. Is there an opportunity that you're looking at that might allow you to use the local colleges and state universities as a pathway to
and that's really where the glitch is right now. It says, because a lot of the program, Riverside now will sort of bridge you to a master's program, but the current regulation or the current accreditation standard says that it has to be the program that's training the PA that grants the master's degree. You can't partner with another institution. We've had discussions with CSU. We've had discussions with, lots of options, legislative approach. We're looking at many different mechanisms.
The reason I recommended and requested that question is because through the Health Professions Educational Foundation, which is also part of this arena, I have made a specific, not for PAs, a request for information on a pathway situation where we could work together. So I know that people are thinking about creative opportunities, so I'm hoping that you're doing as well.
Yeah, and if you have any suggestions or
more than if you put some money to the table, we could probably come up with some plan faster. But that's where my mind is. Where's the money? Dr. Bishop?
Just to follow up with my initial question, since this was a question asked me by my recent Senate confirmation hearing, and they said, what is the medical board doing to help with the problem with underserved areas? So might I suggest, and this may already be happening, Dr. Lowe is very aggressive, and is this already happening that the boards are working together to address this issue of how do we encourage our practitioners? What can we do as a state? And my response to them was that the legislature has to be involved since they have the purse strings, and perhaps we can have some way to underwrite some of the educational expenses to have these people stay in an underserved area. So I'm just suggesting our boards work together on this topic because I think it's a real critical one for the legislature and I think for our state.
Dr. Bishop, let me just remind you that $25 of your licensing fee of every doctor in the state of California is going to the Health Professions Educational Foundation, which provides money through the Thompson Fund for loan repayment. So the medical board was the entity that started that, housed it, birthed it, and expelled it. So,
Yet it's a drop in the bucket compared to what we really need, I think. So
that's very easy. I would agree with you, but as you said, the purse strings are where the situation is.
And
Dr. Lowe?
I did figure out my numbers.
Yes.
It's 100 to 7.
100
100 physicians, 7 of them
PAs.
use the 7 PA to go with 100 physicians.
Oh, okay.
So just to put things in perspective, can you talk a little bit about nurse practitioners, how they are similar or different, and how some of the nurse practitioners do similar things as PAs, so that really changes the whole ratio?
Yeah, I think our scope of practice is very similar, and I know Ms. Shipsky can chime in at any time, but I've worked alongside nurse practitioners in family practice, and we're doing the same thing, seeing the same patients. The education and how we got there is a little different, and our backgrounds are a little different, and there's minimal differences in the laws that govern our practice, but it definitely increases our numbers if you're looking at nurse practitioners and PAs as a total.
Thank you very much. Any other further questions? Any public questions? Thank you, Dr. Lowe. Thank you. Thank you for your presentation.
Thank you.
It's Portman, Ms. Grivet. I just had to find my place. I apologize. So now I'm going to ask for Dr. Kaufman to come forward. I'm going to go on to number 11. We're going to have a presentation on the use of electronic health records. And Dr. Kaufman is an associate professor at the Philip R. Lee Institute for Health Policy Studies and the Department of Family and Community Medicine at UCSF. She has engaged in health workforce policy and research for over 20 years. And a more complete bio is located on page 145. So Dr. Kaufman, thank you for coming, and please begin your presentation.
Thank you very much. It's a pleasure to be with all of you today. I've been asked to give you a whirlwind tour, and Linda was very clear that it needed to be a whirlwind tour of a report that our team at UCSF released last month in June, entitled On the Road to Meaningful Use of Electronic Health Records, a survey of California physicians. And I do believe you got the report prior to the meeting, and it's got a lot more detail than I'm going to be able to share today. We did this survey in partnership with the medical board, with funding and support from the California Department of Healthcare Services and the California Healthcare Foundation. First, just a little bit of background. The HITECH Act of 2009 authorizes Medicare and Medicaid, what we call Medi-Cal in California, to make incentive payments to hospitals and clinics for meaningful use of electronic health records. And it's estimated that the HITECH Act will generate a total of $27 billion in payments to physician practices and hospitals over 10 years, with about $2 to $3 billion of that going to California hospitals and health professionals. There's a large body of literature that suggests that broader adoption of electronic health records has potential to improve prevention and early diagnosis and yield other benefits for medical care. However, there are also a number of concerns about EHRs and their effects during initial implementation and beyond, and particularly concerns about whether EHRs are designed with physicians and other health professionals' needs in mind, and whether they distract from provider-patient interactions, disrupt workflow, concern that they might actually increase rather than decrease errors, and reduce quality of care. So it's within this context that we were asked to obtain baseline information about the availability of EHRs in California physicians' practices prior to the implementation of the Medi-Cal EHR incentives and payment. The providers and hospitals became eligible to start signing up for those payments in late 2011. Our survey was a supplemental questionnaire that was sent out at the time of biennial physician licensure renewal, and we sent it to MDs whose renewal dates were from June 1 through July 31st, 2011. So we sort of grabbed a snapshot of 2 months in the 24-month cycle. Just as with licensure renewal, generally physicians can choose to respond on paper or online, and I believe we had about 70 to 75% responding online. And we combined those results of the supplemental survey with information from the medical board's mandatory survey and material in the core license file database. We asked physicians not only whether they had an EHR, but about the specific functions of that EHR. And we asked specifically about functions that are part of the meaningful use objectives that the Centers for Medicare and Medicaid Services have set for the Medicare and Medi-Cal EHR incentive payment programs. In other words, it's not enough for hospitals and eligible health professionals to show that they have an EHR. They've got to show that the EHR has specific functions and that they're using those functions in a meaningful way. So here at the top you have a list of some of the core objectives. These are objectives that every health professional, every hospital has to meet. And then at the bottom, the menu objectives we measured. And as the term menu implies, physicians, other clinicians and hospitals can pick among the menu items to choose which ones they want to implement. And you'll see this covers a range of things from patient demographics to providing patients with access to their own records. So it's quite a comprehensive set. Now I'm going to turn to some of our results. We distributed the survey to approximately 10,000 physicians and really appreciate the medical board's help in sending that out. Of those 10,000 physicians, about 7,900 had a practice zip code in California and provide at least 1 hour of patient care per week per their response to the mandatory survey. And so that was really the population that we're looking at, because to even begin to be eligible for the Medi-Cal incentives, you've got to practice in California and do some patient care. And then of that 7,900 or so, 5,384 completed the EHR supplemental survey. So that's about 68% of those who are eligible. And I know if any of you have been involved with physician surveys, that's a very high response rate for physicians. And we know that that's due to our ability to include the survey with the license report, licensure renewal materials. You know, you have a captive audience when you send out those license renewal materials. And so I think that really helps us and others to leverage that to get information that I think will be useful to the board, to policymakers, and the public. Whoops. Okay. All right. Let's not skip to the end. So this graph just shows you the proportion of physicians who had any electronic health record. In the dark blue bar, dark blue slice of the pie, 71% of the physicians said they had some sort of EHR in their practice. And we used several different terms for EHR to try to make sure they understood what we meant. So that's, I think, the encouraging news. The less encouraging news is on this slide. Only about 30% of the respondents had an EHR that met all of the meaningful use objectives we measured. About 41% had an EHR but didn't meet all of these objectives. So I think the message, we've got a lot of EHR adoption, but we're not quite there for meaningful use, at least as CMS defines it. This is just a summary of the availability of specific EHR functions. And the bottom line here is that physicians were more likely to report that their EHRs had functions that could help them in their encounters with individual patients, such as a feature that let them take clinical notes, something that let them list patients' medications and any medication allergies. That was more common than functions that would enable them to communicate electronically with other providers, other facilities, say with the hospital, or to communicate electronically and share records with patients, or to perform quality improvement, quality management functions. Some of them definitely had those capacities, but it was less common than the functions that would help them with the individual patient encounter. This is just a graph comparing California to the United States, and here we compared our data with data from the National Ambulatory Medical Care Survey. This is a national survey that the National Center for Health Statistics fields every year. So here we are looking at those physicians in office-based practice in California relative to office-based practice in the U.S. And here we see we're a little ahead of the curve. About 68% of our respondents had some sort. Actually, I should back up. These data are all from the NAMCS, the National Ambulatory Medical Care Survey. So some of the percentages are a little lower than our survey, basically having to do with differences in our survey methodology and theirs. But using the NAMCS data, 68% of California physicians, and 68 had some kind of electronic health record versus 57% in the U.S. 44% in California had what NAMCS defines as a basic electronic health record versus 34% in the United States. The NAMCS, the folks who do the NAMCS surveys ranked the states by rates of EHR availability, and we're 11th in the U.S. So we're not number one, but we're definitely in the top 20. And I think, as we'll see later, a lot of that has to do, I think, with our medical marketplace and the decisions that some of our larger medical groups like Kaiser Permanente have made around EHR adoption. This slide just shows us the factors associated with having an electronic health record in your practice. We found higher rates of EHR availability among physicians in large practices, such as Kaiser, hospital-based physicians, urban physicians, and younger physicians. Practice size had the largest effect, as we'll see on this graph. And so this is EHR availability by the various practice types that were response options in the survey. And Kaiser Permanente at 99% had the highest rate of EHR availability. Dr. Levine, I sort of wonder about that 1% at Kaiser that don't think they have an EHR.
I agree with you. I can't imagine who they are. Maybe it's senior staff not seeing patients. Well, if anybody who sees patients, there are no paper charts anymore. So there may be some people who don't actually realize they're using an electronic health record.
Right. And the VA and other large practices have high rates of adoption. The lowest rate of adoption is in solo practices, and then down toward the bottom, community public health clinics. So Dr. Diego, that would be where Golden Valley and other community health centers are, a lower rate of adoption. And now remember, this is the rate statewide. There are some community health centers that do have pretty sophisticated electronic health records. This is just saying when you look across all of them, the rate is only 54% versus 99% for Kaiser. We did then also ask about physicians' plans regarding the EHR incentive payments. And keep in mind that this was done these went out in the spring and summer of last year. So this is baseline data before the incentive programs went live. So at that point, about 12% planned to apply for Medi-Cal incentive payments, 10% to apply for Medicare incentive payments, 15% thought they'd apply for one or the other, 39% said they don't plan to apply or need more information. I think if we redid the survey now or in the future, that would probably drop. I think there have been really concerted efforts to educate physicians about the HR incentive payments, and the board has been involved in working with DHCS on that. Based on the responses to the survey, we estimated that 17% of physicians with active California licenses are eligible for the Medi-Cal incentive payments, and that's based largely on the proportion of their patients who are on Medi-Cal. You have to have at least 30% of patients on Medi-Cal unless you're a pediatrician. For pediatricians, the rate is 20%. And that's simply because pediatricians are much less likely to qualify for the Medicare incentive payments, because as a pediatrician, you just don't see much Medicare, if at all.
Oh, disabled. Patients who are disabled.
Right. You see some, but it's less likely that you would qualify for the Medicare if you're a pediatrician. And so CMS's judgment was for pediatricians, we'll set the bar for the Medi-Cal incentive payments a little lower. We found that eligible physicians are more likely to practice in community and public health clinics, not surprising given the missions of those clinics. also more likely to practice in rural areas or to be primary care physicians. Some important limitations of our survey is that data are self-reported. We're taking what the physicians tell us on faith. Not everybody completed the survey. Some responses were incomplete or implausible. And we didn't include other health professionals who are eligible for the Medi-Cal HIT EHR incentive payments. So that includes physician assistants, nurse practitioners, DOs, and dentists. So I think we've learned a lot here about physicians, but can't say so much about other professions. I will tell you that there is a report in the works from a survey that was done of nurse practitioners and nurse midwives that will be coming out later this year and can be made available to you if you're interested. Some implications, I think there are opportunities for ongoing education and outreach about the incentive programs, and that should involve DHCS, CMS, the regional extension centers, which are funded by the federal government for the exclusive purpose of expanding use of EHRs, and that there's roles for the medical board to be involved further as well. Probably important to emphasize use of certified electronic health records. These are electronic health records that are certified as meeting the meaningful use standards. Important probably to place the highest priority for outreach on community, public clinics, and small practices because they have the lowest rates of adoption at baseline. And lastly, we think it would be helpful to do the survey again in 2013 to assess the impact of the incentive payments. And indeed, I've had conversations with your executive director and deputy director and folks at the Department of Healthcare Services, and I think we're all hopeful that we can do that. I think this has been a good partnership in terms of generating useful information, and we'd like to continue working with one another. And then lastly, thanks to Linda Whitney, Kim Kirschmeyer, and others at the board who've been incredibly helpful to us and to my other colleagues at UCSF, Department of Healthcare Services, California Healthcare Foundation, and the California Medicaid Research Institute. And hopefully we've got time for a question or two.
Do you have some questions, Dr. Gonadeb? I see. Thank you.
You must have found a loophole for the physicians to fill out the survey. Just send it from medical board. They get so worried they fill out any survey which comes from medical board. It sounds like. I'm surprised to see 39% were not even going to really get something which we, the physician leadership, worked so hard to get that funding in my previous life in 2008, actually the pediatrics 20% came from California pediatric doctors.
Oh, okay.
Who came to us at CMA. I was the CMA president. We took it to the Congressman Waxman, who was the chair of the Senate, the House ENC committee, and he put that into the bill. So it's when you start locally how far it can go. But what puzzles me is how many doctors are not really looking at to get that, because if you don't, you're going to be penalized next. So that's what surprises me.
Right, and you're making an important point that I didn't mention, that on the Medicare side, you will be penalized, and I'm going to get the year wrong, but that in several years you will be penalized if you're not having, by the Medicare program, if you're participating, if you don't have an electronic health record. So I think I would say two things. A lot of these docs said they needed more information. And as I say, I think if we did the survey again now, hopefully some of those physicians have been educated by the board, CMA, and others. But I think you're right that there's a need for ongoing information and a better understanding for those that aren't applying what's the rationale behind that.
Dr. Diego?
Two comments or questions. One of them is, do you think maybe the 39% were planning on not having populations in their patients in their practice that would cause a penalty? And the other is there a way to provide a list for those providers that are trying to do this to choose the electronic health records that will get them to meaningful use?
So I think on the first question, we did have a response option of whether you think you're not eligible. And so this 39, and that was 19%. So one would hope that in that 39% are people who don't think that they're eligible, but I think that may be part of it. We certainly do have a lot of practices that do not see Medi-Cal patients, and we have some that do not see Medicare. So that may be part of it. And then to your second question, I think the Office of the National Coordinator for Health IT has tried to provide a lot of guidance about certified EHRs, and the regional exchange, regional exchange centers in, let me make sure I get the name right, regional extension centers here in California, and that's CalHIPSO in the north, and then LA County and Orange County have separate. That's what I think they've been trying really hard, is to push out the information not only about the benefits EHR, but how to get an EHR that's going to achieve meaningful use. And maybe Dr. Levine can speak to that too.
Yeah, I think the number actually of ineligible physicians is fairly large in California, because if you participate in Medicare through Medicare Advantage, you're not eligible for the meaningful use incentive.
Well, I would defer that to Dr. Larry Dickey, who runs the program at DHCS, because I think the answer is yes or no, depending on the specifics of your Medicare Advantage plan, but Dr. Dickey's the expert on that.
I know that
maybe what needs
your docs are not
eligible.
So, but maybe what needs to happen is that the medical board needs to partner with such organizations to do outreach, and through our newsletter, through other means, along with a concerted effort from the specialty boards, as well as the health plan organizers, to try and get this out there, because the idea that it's available, there's incentive plans, and that in the event you don't want to do this, you're going to get charged for that luxury of not doing it, may be something that, it's like having broadband in your community. There are certain communities that just can't put their arms around it. There are people in their community that can't put their arms around yet an iPad, but I'll get there. So the issue is that technology is coming and reform is coming, and we can help get it out there. And I have to tell you, I think that it's an exciting opportunity, because I think that we've all seen it work. So other questions, Dr.
Right. And I think, Ms. Whitney, you did put an item in the newsletter, I think, at some point in the past, and I know you've talked to Dr. Dickey about additional newsletter items.
We can do more. We can always do more.
Okay.
So I think that those of us in the practice of medicine would agree that electronic health records have been very helpful in many, many ways. But it's also very, very costly, and I think it's unlikely that any amount of incentive money is ever going to come close to paying for the cost of true EHR. So the reason solo practitioners can't afford to do it is because there's just no money to do it. Secondly, I think that this whole concept is fantastic, and while it's very easy for a system like Kaiser or UC Davis, who can afford Epic, which is the Rolls-Royce of EMR, that they should have had some ground rules for all of the companies in this field who really are in the field to make money, so that there would be more compatibility. In other words, if you can't afford an Epic program and you have an EMR in your office, you can't have an easy way to import x-rays into your EMR so that they can be easily seen like they are in Epic. Nobody can afford it. So they should have had some guidelines and rules. This is the DICOM format that's going to be sent by your radiologist to your office so that you can have access to the actual x-ray, or some kind of rules like that. So I think that it's nice that we have EMR, but I think that we need to backtrack and set some rules for these companies so that there can be more compatibility and interchange.
Well, I think those are excellent points. I think that if there's a way for the medical board and those of you on the board in your organizations to make your voice heard to CMS and to Office of National Coordinator, that's what I would advise. I think those are incredibly important points.
No, this is not something the medical board can do. I mean, we're trying to protect our people, but we have limited resources. We have no state money. We have money from our licensee. This has to be a national mandate from our president through his Secretary of Health. I mean, this is not something we need to do. It's something that the government has to do from the top, just like they made a standard for x-rays. They made the DICOM standard for x-rays about 12 years ago. And it was done at a high level, and when people said they weren't going to play, the practitioner said, we will not buy your x-ray equipment if you're not part of the DICOM standard. So now it's become a worldwide standard, but it took somebody at the government level to make that mandate. We can't do it at the medical board level.
No, and I recognize that, but I think what Dr. Gunadev gave us is an example of a case where pediatricians in California coming to the CMA, and educating the CMA about why this was a priority. I think the CMA and others were able to educate government. So I think you're right, it has to come from the top, but sometimes the interest and the concern has to bubble up from the field in order for that to happen.
And are you able to take the message back that you've heard from members of concern that there is a platform that's necessary for basic technology to be available, so shared responsibility of the technical skill set would be available? I mean, I can tell you, I sat with a former speaker of the legislature in Los Angeles, the electronic medical records at a clinic, and he didn't understand it, nor did I when we walked into the hospital. Mm-hmm. We understood it very well when we walked out. He's no longer in the legislature. But by the same token, the same token is that you have a united voice. You're doing this survey. You're hearing from people what the weaknesses and the strengths are. Mm-hmm. Can we work together and look to you for some, guidance as far as what you're doing in the future, as far as maybe we can, tag along with it. But I think Dr. Lowe is exactly right that this is bigger than all of us combined.
Sure.
But someone's got to address it.
Well, I think, our role as academics at the university is not necessarily as advocates, but I think certainly if we are able to go forward with a second round of the survey, it would be very helpful to have the board's input on what questions to include. Understanding, of course, that with surveys there's always a trade-off between making it longer so you can get more information and making it short enough that people will actually fill it out. So, again, I think those are great points.
Okay. Dr. Salmons, I'm going to try and hear from first people that haven't spoken.
Well, I can only echo Dr. Lowe's points, but as a sole practitioner in that minority, I guess, it doesn't have the EHR, I can tell you that it's going to have to be shoved down my throat because it is incompatible now and not affordable, because I have investigated it. And even fine hospitals have incompatible systems with each other. So right now it looks like an improved billing mechanism, but the other shared information is not there. And basically, yes, I would invite a more extended survey because I would like to be able to express that, because ultimately I do think it's excellent, but it's so not there yet.
Mm-hmm, mm-hmm. And I just would add the NOMC survey did have some extended questions, and a lot of the responses were very much like yours.
Dr. Dussault?
Yeah, I have a question and perhaps a comment on the core objectives that relates to the patient demographics.
Right.
Did maybe I missed it, but what did you find in that regard? How aggressive are these folks that using this system beginning to collect that particular data?
Let me see. That was not the most frequently used, but pretty widely available. And remember, we asked folks, is it available in your practice, and do you use it? Mm-hmm. And that was one in which there was a fairly high rate of use. Some other things, like, let's say, quality indicators, a number of the doctors use them, but others would say, well, yeah, we have it, but I'm not using it myself.
I think what I'm getting at here in terms of a comment, for the meaningful use, we at the UC Davis designed an instrument to drill down and collect the ethnic profile of patients so that in the future we will be able to have a sense of who our patients are, so that we can begin to intervene in terms of reducing health disparities. It's particularly in light of the healthcare reform that's coming down the pike. And I think this is one really significant objective that I think the providers at least should concentrate on.
I think that's a great point. We asked a very general question about whether you were collecting patient demographic information. We gave race ethnicity as an example. So this is a case where we've got some general information, but we were not able in a 2-page survey to drill down as far as you're drilling down at Davis.
Yeah, just a comment. Like many things, the designers of the grand blueprint honestly had no idea about the complexity of execution, and much of the utilities that you describe under advanced systems actually have to be bolted on. They don't come with the electronic health record. And to Dr. Lowe's point, a common platform is a start, but you can't communicate between our EPIC system and yours. We can't even communicate with Southern California, our Southern California region. We completely underestimated the amount of ongoing adjustment, development of tools to extract the quality data that had to be bolted on. I don't think the vendors understood what scale and scope was going to be. And so we have what I think is going to be really a 20-year journey to achieve what the incentives are beginning to assume, beginning in, as of 2016, I think, the penalty kicks in. So, I think you're right. This is this is not flipping the light switch. This is a work in progress, for sure. Very much.
Well, just to put it in perspective, I mean, Kaiser's invested initially over $1 billion. It's now $4 billion. So they started with $1 billion. They're up to $4 billion now. This is a huge cost, and nobody's helping to pay for it. They want it to come out of the provider's pocket.
Well, I mean, I think the incentive payments are intended to help pay for it. Whether they're really sufficient, they may not be for someone like Dara Salmonson in a private solo practice, but there is some. I mean, I think we need to acknowledge CMS has put some money on the table.
So maybe we need to have some kind of written policy within this opportunity of a return policy. If it doesn't work, at the end of 5 years, we can return it and get our money back.
Talk to your vendors about that.
State policy. I'm looking at it as someone specifically in the audience. State policy we need to write.
To be fair, I mean, in spite of the costs and in spite of the, as you outlined, the hit on efficiency and the need to almost redo every kind of work process, there isn't a physician in our system who would go back to the old days. I mean, just the notion that you have the x-rays, that you have the notes that you need is an enormous benefit in terms of actually providing care.
It's not saving you any money. The net cost is still greater than what you're saving, no matter how good it is.
But they can afford it.
Right. Yeah, but so that brings down to that point is I did hear some projections about the future, and one of them is the small solo practitioner will disappear because they cannot afford all the costs. And you were looking at 20 years total implementation for this. I'm hoping somebody is putting more thought into helping at least the rural areas solo practitioner and to make it's a workable situation, because the projection is only the big and people like UCLA, like Kaiser, would be able to function well in the future. But I did want to say, I'm a patient with the Palo Alto Medical Foundation. They had a very similar system. It was wonderful for a patient. And there is, I personally wouldn't mind paying a little bit to make it happen.
Eddie, you're paying every time you go in and are using the services, trust me. Dr. Diego, I saw your hand a minute ago.
Yeah, I just wanted to say, I think that's why it's so important to try to keep our, our physicians informed in terms of which ones of those EHRs are the right choice to make. I think that's something that the medical board can definitely do, because some people may not be able to access those lists from CalHIPSO and all that, you know, as much as you distribute information. Obviously, if it's coming from the medical board, they're reading it, right?
I would hope so. So again, that's maybe an opportunity for the board to partner with CalHIPSO, at the very least, maybe to have them make a presentation. And then secondly, is there information like these lists that could then be replicated in medical board communications, so that if they're not paying attention to CalHIPSO, if it's coming from the medical board, maybe they will read it and that'll help them.
Any other, Dr. Donovan, and then let's wrap this up.
On that last one, I just want to make a point. It's very difficult for the medical board to make specific recommendations because these are proprietary private companies. CalHIPSO can do that, and that's what their job. Or CMA can do that, that's what their job. But medical board is difficult because these are all private, so non-open source companies which are putting out these.
Absolutely. We're well aware. Thank you for calling that to our attention. So I want to thank you very much, Dr. Kaufman, for your report. It's been very informative, and the best of luck.
Thank you so much, and we look forward to being able to work with the board in the future on this area.
Thank you. So I'm going to move on to item number 12. Okay, so the executive committee met on Wednesday, and we heard testimony on SB 1483, and we will have a position to present, recommend to the board. And I would like to take, are we going to do the legislation now? You want to take legislation now? Okay. So Ms. Simoes, would you come forward and make a presentation on this bill? And we'll do this one first, and then should we just do regular, and then we'll do the legislation after, as part of this, after this, okay?
Okay.
We're going to do all legislation right now.
But we're going to do the portion.
We're going to do the portion of this one from the executive board first. Thank you. Perfect. Good morning.
Good morning. Okay, so if you please refer to your legislative packets, we're going to discuss SB 1483 first. SB 1483 Steinberg is sponsored by the California Medical Association, the California Hospital Association, the California Psychiatric Association, and the California Society of Addiction Medicine. First, I would like to thank the author's office and the sponsors for addressing many concerns raised by the board in its previous analysis. The previous major issues of concern with this bill, that it was located in the Board's Medical Practice Act, that it did not identify a state agency to have oversight of the committee and the physician health program, and that it did not identify a funding source, have been addressed. To briefly review the bill, this bill would establish the Physician Health Program, which would be administered by the Physician Health, Recovering, and Monitoring Oversight Committee, also created by this bill. This bill now places the committee in the Department of Consumer Affairs and would require DCA to select a contractor to implement the Physician Health Program, and the committee would serve as the evaluation body of the Physician Health Program, or the PHP. The PHP would provide for confidential participation by physicians who have a qualifying illness and are not on probation with the medical board. The PHP would refer physicians to monitoring programs through written agreements and monitor the compliance of participants with that agreement. It's important to note that the PHP would not actually provide any treatment monitoring services. This bill would require the committee to report to DCA on the outcome of the PHP, and the bill would require regular audits of the PHP. This bill would increase the physician and surgeon license renewal fee by $39.50 to fund the cost of the PHP and the committee. This bill would define physician and surgeon as a holder of a valid physician's and surgeon certificate. It would also include students enrolled in medical schools approved or recognized by the board, graduates of medical schools and residency training programs, or physicians and surgeons seeking reinstatement of license. Although the board believes that applicants would still be required to report this information on their licensing application, it is a possible amendment to require to specify this in the bill. This bill would also require the PHP to have a system in place for immediately reporting physicians who fail to meet program requirements to the board. The system would be required to ensure absolute confidentiality in the communication to the board and would not be allowed to provide information to any other entity. Although this bill requires the program to report to the board participants who fail to meet the requirements, it does not specifically require reporting to the board of those whose treatment does not substantially alleviate the impairment, those who withdraw or terminate prior to completion, or those who after an assessment are unable to practice medicine safely. It appears this lack of reporting was an oversight in how the bill was drafted, but this is a possible amendment. Lastly, this bill would increase the biennial license renewal fee for all physicians and surgeons to $39.50 by $39.50 to fund the cost of the PHP and the committee. This would be effective January 1st, 2013. Board staff does have a concern with implementing the fee increase on January 1st. The board sends renewal notices to physicians 90 days in advance of the expiration date. For licensees with the renewal expiration date of January 1st, the renewal letters go out on October 1st. With the transition to a new computer system set for October 15th, the board's current computer system is frozen and no new changes can currently be made. The new system will not be able to accept revisions until mid to late November, and then the programming time to accomplish this update, to revise the renewal forms, the website, cashiering, etc., will take approximately 3 to 4 months. Board staff would not have time to update the computer system, revise the renewal forms, get out the renewal letters by October 1st, 2012. Board staff instead would either have to delay the renewal of those applicants or have to send an additional letter requesting the $39.50 in renewal fees. The additional workload would result in a fiscal impact to the board of $20,000 if it stays as it is with an implementation date of January 1st. The board would be able to implement this bill in a more efficient manner if the increased fee has a delayed implementation date of July 1st, 2013. This would give the board until April 1st, 2013 to update the computer system and revise the forms, and would allow the board the necessary time to do this within its normal workload. As Ms. Yaroslavsky said, this bill was discussed at the Executive Staff Committee meeting on Wednesday. Some important things to point out before we start discussion on this bill is this bill is not the same as the board's diversion program. It does not divert people from enforcement. And so it's a program created and it's intended to be basically like a referral system to refer physicians to monitoring programs. Physicians would pay the cost of the monitoring programs. This program doesn't actually provide monitoring services, but it also does not divert people from enforcement. And so that's just an important difference to point out between the two programs. If the board were to find out, if this, a physician was participating in the program and the board was to find out that something happened regarding patient care, we would do the normal complaint process that we would always do. So this would not exempt these physicians from enforcement or divert from enforcement. So I just wanted to point that out before discussions ensued. So I can defer to the chair on what happened in executive committee? Okay.
Thank you, Ms. Smith, for that explanation. The executive committee voted to recommend to the board a neutral, if amended, position with these amendments. One is to clarify applicants must report on medical board applications. The change effective date to renewals from due July 1st and after, and clarify that reports must come to the board in a section 830.10, parens E, paren 1. So that is the motion I'd like to make, and I'd like a second to that motion. Thank you for the second. So now we're going to have discussion from the members of the board, and then we will take public comments. So let's start at this end. Dr. Carrion, you have any questions?
No.
Okay, not yet. Okay. Dr. Simonson?
Well, I'm trying a math problem, and let's see if I got it right. So if we have 125,000 licensees...
The microphone, please. Microphone.
125,000 licensees, and so if it's $39.50 per cycle, I'm doing 20 per year. It looks like $2.5 million a year in the program.
You probably have to defer the sponsors, but I think that's in the right ballpark.
But the participant would be paying for the actual treatment.
Correct.
So it's unclear to me, like, how many employees, I mean, what are we getting for that $2.5 million per year? It's that somehow got turned on to math all of a sudden.
The sponsors would probably have to speak to that.
Okay, I'll welcome that. Thank you.
Dr. Lowe, do you have some questions?
No, but it's not just the medical board that's going to have to pay. It's all the different boards, right?
No, this is only medical board.
Just the medical board, because this is only impacting physicians.
This is only physicians. This is not for the entire health professions boards.
The CARES program was everyone. That might be what you're thinking about. The CARES program does different, but this is only impacting physicians and surgeons.
Dr. Giselle?
No comment at this time.
Okay, Dr. Diego?
No comment.
Ms. Shipsky? Dr. Levine? Ms. Chang?
I'm going to listen to topic comment.
Fine, that's fine. Dr. Ganadet?
I'll wait. I have comments, but I do want to listen to
Okay.
others.
Dr. Bishop?
My only comment is it seems like it is a lot of money. I'd like to hear where the money's going. I'd like to have some accountability for it.
Okay, and on that, just really quickly, it is important to note this money, the funds are subject to appropriation by the legislature, so that does mean that there's a budget process in place, that the, it may not happen up front, but once, they have to get appropriated to this fund and appropriated to the program, so there is an accountability system, at least in the legislature, where they have to prove to the budget committees in order to get that money appropriated, but I just wanted to let you know about that.
Madam Chair, but because of the budget situation, could they not in fact decide to appropriate some of this money into the general fund?
Well, it's
subject
to appropriation, so.
they
Yes,
could,
the answer to your question is yes.
Okay. Can I ask a procedural question? Why this was brought up in the executive committee?
So that we could have a full discussion of an issue that is bigger than the time we had allotted for this meeting. It took probably a good hour of discussion, and to be honest with you, that's why we put it there. Executive committee is open to any member that would like to be there. So
I understand that, but this is not a usual issue for an executive.
No, but the executive committee had members of the public there as well who addressed these things.
I'm fully aware of that, but again, that on the regular agenda, usually under legislation, that's where it is, and where then people know to expect the conversation to go on.
Okay, thank you. Okay, so now we're going to have members of the public. I'm going to ask Randall Hager, and I apologize again for mispronunciation of your name because I don't remember what it was on Wednesday. Hager. No, there was a woman Hager, so I know.
Thank you, Madam Chair. I am Randall Hager. I represent the California Psychiatric Association. I am the Government Affairs Director, and the CPA is one of the four co-sponsors of this legislation. We've been working on this with other partners for 4 years. I'll just say real briefly that I think what we have tried to do, and I think we have by most measures achieved in our bill, is to present a new model that is a public-private partnership. It's based on public health principles. And as you read through the bill, I think you'll see something very different, particularly in the outreach and educational functions of the spelled out in the legislation. So, without belaboring it, because you did get a very good analysis from your staff, I'll just say that I'm very happy to be here today. I'm being allowed to testify. I can answer questions, and we are here to ask for your support.
Thank you. Yvonne Chung?
Good morning, Yvonne Chung with the California Medical Association. We too are a sponsor of this bill, and we are here to ask for your support as well. We did want to answer some of the questions that were raised regarding the question of, the number is roughly about 2.2 million in renewals, and how that number was sort of arrived at. To give you some context, the average annual cost of the previous diversion program was about $1.2 million a year. It's generally acknowledged that was pretty underfunded based on the ratio of monitorees to case managers. It was understaffed. Looking at, we look at other states, how much they spend. The Lawyers Assistance Program, which is sort of highly regarded as well in the state, they actually spend about $2.7 million as their annual budget in terms of the types of activities. And we envisioned it as being a very similar kind of model in that they too do not provide direct treatment and monitoring services. They provide more of a case management function. So it would depend on, you ask how many staff. At this point, it'll depend on what DCA ends up contracting out for, and they'll get bids back in terms of the exact number of staff. But it's envisioned that there would be sort of case managers that would oversee, the entire continuum of care for a participant, from treatment and monitoring and biological fluid testing, any other ancillary services that they may be participating in, and sort of overseeing that and making sure that the providers are doing what they say they're going to be doing. So hopefully that answers your question. I'm happy to answer any other questions that the board may have on this issue.
Okay, so Ms. Chung, Chang, you have questions?
I just want to clarify.
The microphone, use the microphone.
Oh, okay. I just want to clarify this point about what the new organization is going to do. Okay. Now, from my understand at the executive meeting and here today, it sounds like that medical board is going to be just the bank. We collect the money and we turn it over to this new organization or new committee.
That's correct. That's absolutely correct.
The new committee does not do any testing. They just monitor. They're going to hire someone and monitors the future program. So it's different than what we were doing. It actually seems to be a very simplified process than the previous process. So if previous process only cost, even it's underfunded for $1.2 million, why are we needing that much money at this point?
I'm a little, in terms of the structure, it actually is, the purpose of the oversight committee will be to act as the state agent that will be responsible for overseeing the evaluation of the program, making sure that the vendor is doing what they're supposed to be doing. The composition, if you'll see in the legislation, of the oversight committee is clinical experts. So their job is to, oversee it, make sure that they'll be the ones that will be getting information from the vendor about the participants and making determinations as to, whether or not they're progressing appropriately within the program. They will also be the ones that will be making reports to the medical board as well, pursuant to the statute in terms of participants who have not completed the terms of their contract with the vendor, who are withdrawing from the program or otherwise, excuse me, or are otherwise not completing the program. So they will act as the source of communication with the board.
So, right.
Right. And they will also be responsible for designing the program, and specifying what the program ought to look like.
So they will define the program. Right. And by the participant, there will be somebody else actually monitoring.
The day-to-day will be done by a vendor.
This is only an oversight board that's being created, a 14-member board that's being created to establish a program that the participant will pay for fully and will pay every expense and cost fully. I just want to correct what you said a little bit before, that in the past when we had a diversion program, the issue I thought that helped to give impetus and rise to this new idea was the expectation that with the numbers that we had in diversion were much less than what was represented in reality in society.
That's true as well.
So what I just wanted to clarify, because earlier I felt weren't exactly clear on that. So that the issue here is that they're going to be using some of these funds to do tremendous outreach. Right. But it is just a pass-through of money of $2 million to this new funded board if the Department of Consumer Affairs, the legislature, and the governor decides that this is going to be an appropriate use of dollars. Any other questions? And the reason I really appreciate you staying here to answer questions is because you guys were the impetus in getting this written, okay?
And we want, we're not attempting to be confusing about this. We want to be as clear as possible.
I just want to make sure it's very clear. Also, what I'd like to ask is, would you be willing to accept the 3 amendments that we've recommended?
We would have to go back to our coalition, and I know that we are actively pursuing other amendments as well with the author's office, so that's probably a better question for the author's office.
Any questions? Questions?
Madam Chair, is there a way to put into the law that the funds raised could not be subject to borrowing?
We would certainly.
I'm a little concerned that this is being kind of promoted as as they look for ways to fill in gaps to perhaps say, oh, we have this source now we will borrow. And then, and then the fact remains is then you have a committee that isn't properly funded because the money is someplace else.
Two quick points on two of these recent comments. There is a provision in the bill that says that these monies may not be used for any other purposes.
So we have that in our
yeah, we
rules.
we've addressed that, maybe not better than you have, but we have that provision in the
Could we
bill.
find
To the
out
extent
if that's-
possible, we're putting in language that will.
Yeah, if that's sufficient. It's not for other purposes. Borrowing is not considered to be using for other purposes because the intent is they will put it back. So, I think that in light
That might be a sure way of getting the bill killed.
Well, no, but I think it's, I think that may be a little bit why that there's some support for this, is that it looks like it's another little pot of money to borrow from, so.
Do you have any other questions for Ms. Chung or Mr. Hager? Thank you. I've got a public speaker's comment. Please, thank you very much for your time being here today. Julie D'Angelo Feldman, would you come forward, please?
Good afternoon. As I said, Julie D'Angelo Falmouth from the Center for Public Interest Law. As I said to you in May, this bill is not yet cooked. It's now July, and the bill is still not yet cooked. There are still a lot of things wrong with this bill, some of which are pointed out in your staff's analysis. It creates a new state regulatory board at a time when the governor and his administration are trying to constrict government. It allows private trade associations to dictate, the same trade associations which are the sponsors of this bill, to dictate the membership and control of the new state regulatory board. It requires you to fund the new board and its vendor with physician licensing fees, thus tying you, in the eyes of consumers and the media, to this new program over which you will have no control. And that was a huge problem for this board when it voted to oppose AB 214, a very similar bill, in 2008. It will cost doctors over twice what they paid to fund the old failed diversion program, yet we have not seen any fiscal analysis supporting the new surcharge on physician licensing fees. We don't know how the money will be split up between the committee and its undefined, unspecified staff and this vendor. It is still incomplete. There are holes in the bill. And it doesn't even do what it purports to do. It purports to set up a certification program for private companies that monitor substance abusing doctors, but there's no mechanism and no standards for the certification of these programs. But the most astonishing thing that this bill does is not mentioned in your staff's analysis, and it requires you to recall some history about your failed diversion program. That program was created as part of this board in 1981. And shortly after it was created, this board established, at the behest of the California Medical Association, a liaison committee to the diversion program. The liaison committee existed for 24 years, and it was controlled by representatives of 3 of the 4 sponsors of this bill: California Medical Association, California Society of Addiction Medicine, California Psychiatric Association. Because of the existence of the liaison committee, this board did not exercise meaningful oversight over the diversion program. It left that to the folks on the liaison committee. As most of you know, the diversion program failed 5 performance audits during its 27-year history. And as a result of the 5th failed audit in 2007, this board voted unanimously to end the program. The liaison committee was in place during 4 of the 5 failed audits, and it failed to even address, much less resolve, any of the deficiencies identified by any of those 4 sets of auditors. This bill hands control of this new program back to the same organizations that failed to properly police the diversion program, along with a significant amount of public money. And what is even worse, this bill requires the new state board to hire and oversee a vendor that will carry out much of the on-the-ground work. A very recent analysis by the Assembly Business and Professions Committee of this bill, and the analysis was dated June 26, reveals that CMA in 2010 and the other sponsors created a California Public Protection and Physician Health, Inc., or CPPPH, a nonprofit organization. And they created this because they were unhappy with this board's decision to end the diversion program. That assembly analysis describes the 37-page business plan of the CPPPH, which includes the passage of this bill and the eventual conversion of the program that it creates back into a true diversion program. The very thing that this board voted to abolish just 5 years ago. And the CPPPH's website reveals that that many of the individuals who control it are the exact same individuals who sat on the liaison committee, which failed to properly oversee your diversion program for 24 years.
Julie, you're going to need to wrap it up.
I thank you. So the bill not only hands control of the new state board to the trade associations that's sponsoring the bill, it hands control of the vendor potentially to the same folks who failed to properly oversee your program. This is appalling. We have asked Senator Steinberg to make significant amendments to this bill, including a provision saying that anybody associated with the old diversion program or the liaison committee should not ever have a management or supervisory role in this, either the program or the vendor. We ask you to take that same position. If you want to adopt your staff's recommendation of neutral if amended, we hope that one of your amendments will be just that, precluding anybody who was connected to the diversion program or the liaison committee to be in a management or supervision role in this new program. Thank you very much for your attention.
Madam Chair, can I ask a question?
Sure.
Julie, has the senator responded at all to either the criticisms and or the proposed amendments?
It's my understanding that the senator is working on this, but this is July, and you're not going to have another meeting before the end of the legislative session. You can't take a position on a bill you've never seen, so you need to take a position on the bill as it exists today.
The reason we're taking, the recommendation is a neutral unless amended position is so that we may remain at the table as far as being participatory in the discussion process. So I just want to make sure our board understands that we're not giving up that responsibility yet. So Dr. Salmonson?
If I may ask you a question, you went through those titles pretty quickly. Did I understand that the group that will be selecting the vendor is comprised of some of the same entities?
There's a bunch of different levels here. It's very complicated. This new committee will exist within the Department of Consumer Affairs, and the department will have some sort of oversight responsibility over the committee. The committee is responsible for overseeing a vendor, which will do this on-the-ground work. The department is responsible for doing an RFP, a request for proposals from prospective vendors, and initially selecting the vendor, but the committee will oversee the vendor. The obvious intent of the new nonprofit created by CMA and the other sponsors is that this new vendor, which is a tentacle of CMA and the other sponsors, will apply, the new nonprofit will apply to be the vendor. So not only will the committee be controlled by representatives of the sponsors' trade associations, the vendor will also be a tentacle of the sponsors' trade association.
Thank you.
And they're the same exact people who sat for 24 years failing to properly oversee your diversion program. We think they've had their chance. They've proven that they don't know how to run one of these programs that will successfully protect patients from substance abusing doctors.
Okay, I'm going to cut off that discussion. And do you have any questions? Yes, Dr. Bean?
Just a point of information. Julie, you said a significant transfer of public funds. My understanding is this is funded by the fee on licenses.
Yeah, those are public funds. Physician licensing fees paid to the Medical Board of California is public money.
There will also be the cost. There will be the cost of setting up the board and maintaining a board or a bureau under the Department of Consumer Affairs.
From licensee fees?
It does, but those are fees that are paid to the state of California.
That's your public part.
That's public money.
So once they are paid, they become public funds?
Yes.
But they're not funds that the state would have otherwise? I mean,
no, right, exactly.
No, but it could be used for... There's no other public general...
There's no general fund contribution. This is paid for solely by physician licensing fees paid to the medical board. Medical board is solely a pass-through.
Right. We've gone through this. We've gone through this. Okay.
Becomes a source.
So now we have one more speaker slip, and that's from Tina Manassian.
Tina Manassian, patient advocate, victim and survivor of a doctor in your defunct diversion program. I'm not representing Consumer Union regarding my opinions here. Some of you know my story and some of you don't. I was a victim of a doctor who was part of the defunct diversion program. He not only enrolled in diversion once, but twice. At that time, the board allowed him to enter into diversion twice. With this bill, how many chances does a doctor get? And how will you know that? According to this bill, it says you only know they're in this program if they're a graduate or if they're a student. I think you should know who everyone is in this program. First of all, I encourage you to oppose it. I don't support it, and I encourage you to not support this bill. What happened to me and countless other victims, it was very, very sad. But I'm here to tell you that by creating another diversion program, even though they don't call that, it looks like it smells like it, I think it's another diversion program, and I encourage you not to support it. The Medical Board of California should know about everything and anything in terms of doctors. Your paramount priority is to protect the patients of California and consumers of California. No program should be allowed to be run by other entities without you knowing about it, especially this program that these doctors are trying to create. In my opinion, this is the fox guarding the hen house. It's the same old program again, except like Julie said, it's run by the same exact people, and you were charged by our legislator to protect the patients of California, not monitor these doctors. However, you should know about every participant that's in the program. When you keep doing the same things over and over and over, expecting a different result, it's called insanity. And that's part of psychology and treatment. You can't allow these doctors to go into this program without you being aware of. I don't think the only time that you should be aware is when a doctor is being disciplined. You should be aware about everything that happens with a doctor. When I was injured by this doctor, he lied to you several times over and over and over because he was an addicted doctor. Number two, he tried to dilute his urine. Number three, he was able to hire his office manager, someone he can hire and fire. He paid a salary to. You allowed him to hire his office manager to monitor him during diversion. In this program, the CMA and their friends are trying to create the monitoring mechanism. Who is it?
Tina, you're going to have to wrap it up.
Who is it? I believe it's the same people. They're all somehow related, like Julie said. So I encourage you, and I want to remind you that your paramount priority is patient protection, and oppose this bill. Thank you.
So now, do I have any additional comments from members of the board before we take a vote on this? Ms. Simos, thank you. Dr. Ganadev?
Madam Chair, thank you. If this was similar to old diversion program, I absolutely have no interest in supporting it. But I'm not looking at this one as a program similar to old diversion program. My concern is the public members who spoke about public protection. That is my number one priority here as a medical board member. What we are doing is, in my mind, without any kind of a program to support except for a few for-profit programs, we're just keeping our head in the sand and saying that, well, if they comply to us, we'll take care of it. If we don't know, we don't know. So I deal with medical staff. There are a lot of medical staff members who want somebody referred somewhere there. Office staff wants to refer somebody somewhere there. We don't have a mechanism. So and these people actually are harming public. I agree with you. These people are harming public. They need to be, they cannot escape the medical board punishment. But also these people need some help, not some of them. So that's all I'm looking for. So I'm actually okay with neutral if amended.
Okay, do you have any other comments from any of the, yes, Dr. Summers?
Well, I think I do remember the previous audit, at least one of them. And one of the pathways to diversion program was the voluntary participation, and that's what we'd want, participation before adverse outcome. And yet that was the smallest number of participants, and I am not seeing how this program is going to have, this nebulous outreach. I'm not seeing how this program will get the preventive component that we're hoping to get.
Well, thank you. Do I have any additional? Oh, sorry, Ms. Cheng.
Well, right. Well, Sergeant, I think several thoughts crossed my mind, but the thought which bothers me probably the most is I think Judy's comment about the same people may be going to be able to take hold of the program and doing the same thing, and then eventually convert this program into a diversion program. Now, since you're looking at this, I'm just asking to see what's the possibility of this happening.
They wouldn't be able to change it to a diversion program until they change law again. So at that point, if that could be their business plan, but this bill does not do that. So if they wanted to do that in the future, they would have to change law to allow for diversion from enforcement. Everything that we do in enforcement would remain the same. I mean, physicians now can go to substance abuse, treatment monitoring programs, and we don't know about it. It's something that's allowed for them to do as preventative measures. But if they do something that affects patient care, then that's when the board would become involved. And the other thing to remember is DCA does have to do the contract for this, and so it has to go through the state's contracting process. So although that there may be a program that the sponsors are hoping gets picked, it still has to go through the regular contracting process that the state uses. So it's.
Is there a way that we can do it so we'll make sure there's no conflict of interest in or that possibility to happen?
Ms. Chang, do you have an amendment that you'd like to add to the amendments we have listed?
Yes, I would like to do that, and the amendment would be to prevent the conflict of interest people, would that be the right words, to be involved in the committee or in
or the board,
or doing it, or the company who's doing it.
Okay, so the amendment you're suggesting is to prevent a conflict of interest by involving anyone or any entity as a member of the their newly configured board, or okay,
from the board and
or receiving contracts from.
Yeah. Yes. Because it's sort of, well, I was on the board. It was such a painful decision to remove the diversion program, and I really do not want to see it happen again.
So I will accept, as the maker of the motion, I will accept your additional amendment. Who is the second of the, you second, will you accept? So those, now we have to have public comment on that, on the amendment? Yes? So do I have any public comment on the amendment that's been added to the 3 existing amendments in order for this board to vote whether or not to adopt? Yes, Dr. Gunninger?
Can I have staff comment on it? I want to know more about it. This looks so global. I'm not sure what exactly.
The problem is that we don't have we don't have anything in writing. We don't have anything tangible to look at because there's not been a bill that has been. They're in the process of creating the bill. So that what we're doing is by having the discussion and having the amendments that we will allow this board, in fact, to vote to support this on a go-forward basis, to be at the table to have the discussions. We haven't seen it. We can still, when push comes to shove, we'll see the bill, and we can't?
I just wanted to maybe have Kurt speak to like what we can actually include, because this has to go through the contracting process, and I don't know what the standards are for saying who you can pick and who you can't. So I just want to make sure it's feasible for us to.
Thank you, Ms. Mose. My understanding of what we're talking about is, with Julie's comments in mind, is that not actually who's appointed to the committee, but essentially how the RFP, how the contract is solicited. That's my understanding of where the board has the most concern over the conflict of interest. Would that
I understood from Ms. Cheng that she had concerns on both sides, the participatory vote.
Yeah, because if people who are on the board really, for the future board, really couldn't be the past person who were, I don't know how to.
I think you're looking for transparency, total transparency.
Yes, I want,
and
yes.
total absence of conflict of interest is what I heard you say. Correct?
Yes. Maybe you can.
No, I'm kind of listening to you for a few years. I kind of get what you say. I think that's right. So, Dr. Ganadev, that's the situation right now. There is no bill. We don't know where there's no, but it hasn't been decided. Has it been decided? Oh, I apologize. There's a bill. I'm getting tired.
Right. So, no, my understanding is, Ms. Chang's amendment is that the people who are on some previous committee, they cannot be on the new committee. That's totally different from institutions who are sponsoring the bill, which you can't eliminate the institution, California Psychiatry Association or California Medical Association. That doesn't even make sense. But if it is the people, I'm okay with it. Just the members who were on that previous committee cannot be on this newly created committee, one of the amendments. I don't have any problem with that.
Okay. So do I have any other public comments on the amendment that's been added to the 3 previous amendments that was recommended by the executive committee to this board to vote on? I see some, yeah. Okay, so we're going to give you a second bite at the apple.
And it'll be just a second. Randall Hager, again, we will look at those amendments. We have actually already heard concerns of that sort, and there is a discussion in process. So
Good.
Thank you.
Good, thank you. Ms. D'Angelo, Feldman.
Thank you. Just to briefly clarify what I was asking you for, I would hope that one of your amendments would prohibit anyone connected with the former diversion program or the liaison committee to be in a management or supervisory position either on the new committee or at the vendor.
Ms. Chang, is that what you were trying to express?
Yes.
That's what I thought. So the language you've got the language, okay? So I'm going to ask now for vote. All those in favor of a support if amended. No. A neutral, if I'm sorry. I'm really getting tired. A neutral unless, if amended. Say aye. Aye. Any opposed? Any abstentions? Okay, so would you like to continue with the legislation, please?
Okay.
Briefly, please.
It is brief. I only have 4 bills to go over. Okay, so first I wanted to report on legislative outreach pursuant to strategic plan, goal 4, objective 4.1. I contacted 8 legislative district and capital offices to let them know about our quarterly board meeting and to extend an invitation and provide information on our board meeting. I've also contacted capital offices, including the Senate Office of Research and the Senate and Assembly Business and Professions Committees. And one of those staff is here today. I continue to meet with Capitol legislative and committee offices on a daily basis on our sponsor bills, bills we have positions on, and on bills or issues that surface that might impact the board. The legislature is currently on summer break until August 6th. Now, if you would please refer to your legislative packets. The first page is the tracker list, and everyone should have got an updated tracker list. I would like to note that the status of 4 bills are changed, and they've become chaptered, which means they've been signed into law by the governor. The first one is AB 1533 Mitchell, which is actually the board's sponsor bill. So this is good news. This is the bill that would authorize a pilot for the University of California at Los Angeles. This bill passed through the legislature with no votes and no opposition and was signed into law by the governor on July 13th. I would like to thank Assemblymember Mitchell for authoring this bill and the UC for their support as co-sponsors. The next bill is AB 1548 Carter. This is a bill that prohibits outpatient cosmetic surgery centers from violating the prohibition of the corporate practice of medicine and elevates the penalties of violating the corporate practice of medicine prohibition. The board took a support position on this bill because it will help to prevent further offenses and help commit consumers with business models in violation of this law to reconsider and revise their business practices. This bill is also signed into law by the governor. AB 1621 Halderman is the bill that exempts physicians working on trauma cases from current law that requires physicians to provide specified information on prostate diagnostic procedures. The board took a support position on this bill, and it was also signed into law. The last bill that was recently chaptered is AB 1896 Chesbro. This is a bill that aligns state law with the Federal Patient Protection and Affordable Care Act and exempts all healthcare practitioners, including physicians, that are employed by a tribal health program from attaining California licensure if they're licensed in another state. The board did not take a position on this bill. On your tracker list, the sponsor bills are in pink, and we already reviewed one of them. We'll review the other one. The bills in blue will also be discussed, and the board needs to take positions. The bills in green are bills that we've already discussed and have taken positions on, so we won't be discussing these unless a member would like to. Are there any questions on bills in green?
No.
Okay, if not, let's move on to SB 1575 under your Omnibus tab. This is the bill as a vehicle by which omnibus legislation has been carried by the Senate Business and Professions and Economic Development Committee. The omnibus language would allow the board to send renewal notices via email, would clarify that the board has enforcement jurisdiction over all licensees, and would establish a retired license status for licensed midwives. This bill is currently in the Assembly Appropriations Committee. The board is supportive of the provisions that impact the medical board. Now let's move to 2011-12 legislation. These are the bills in blue. And now we only have four bills to cover. SB 122 price. This will actually be discussed as part of the licensing committee update, which is the next agenda item. So we'll move on to SB 616, Desagne. This is the bill that was discussed by Ms. Harold briefly. This bill would establish the Cures Fund, which would consist of contributions collected from organizations for purposes of funding the Cures program to be administered by the Department of Justice. As Ms. Harold said, there's ongoing meetings. The bill doesn't really specify what funding source will be used to fund Cures, only that Cures needs to be funded. So we as the board generally support funding Cures. The board believes Cures is a very important enforcement tool and an effective aid for physicians to use. The board does currently help to fund Cures at a cost of $150,000 this year, but these funds can't be used for staffing. DOJ is having some significant issues with not enough funding for the Cures program, so the board is actively participating in the meetings with DOJ, the legislature, and other stakeholders. And so we would like to suggest that the board actually support this bill.
So do you need a motion?
I need a motion.
So I'll have a motion to support. So moved. A second. Do I have comment? Do I have public comment on this bill? Can I ask if the drug companies have been approached to fund it?
Actually, the drug companies are in the meetings, and they've been asked. They kind of set up maybe like a $5 licensing fee on all the boards that use Cures, and then a lump sum.
No, that's not what I was talking about. I was talking about.
I'm coming to. So then a lump sum from like the drug manufacturers, the wholesalers. There's a list of people, and I think right now the lump sum they're asking is $700,000 to start up a modernized Cures system. So.
Okay, all those in favor of the motion, please say aye. Any opposed? Thank you.
And I'd like to say Kaiser is the only one that came to the table and said they'd be willing to, publicly, and said they'd be willing to help fund Cures.
It's amazing when you have money what you can do.
Okay, moving on. The next bill, SB 1236 Price, and this was briefly reported on by Dr. Lowe and Ms. Portman. This is a sunrise bill for the Physician Assistant Committee. This bill will rename the committee to the Physician Assistant Board and extend the sunset date till January 1st, 2017. This bill would also create a retired license status for PAs along with other provisions. This bill would also revise the makeup of the members of the Physician Assistant Board. Upon expiration of the current medical board member, this bill would require a board member to be appointed to the PAB that's also a member of the board, but the member shall serve in ex officio capacity. And that would be a non-voting member whose functions will include reporting to the board on the actions or discussion of the Physician Assistant Board. Board staff is suggesting the board take a support position. The board would continue to perform investigative services for the Physician Assistant Board, and the board and PAC currently have a cooperative working relationship. And this bill would still maintain close ties with the board and the Physician Assistant Board. May I have a motion for support?
Motion. Second. Any public discussion on the motion? Any questions or concerns by any of the board members? All those in favor, please say aye. Aye. Any opposed? Thank you.
Okay, lastly, SB 1237 Price includes language to extend the sunset date of the vertical enforcement program to the same dates as the board sunset, from 1/1/13 to 1/1/14. This change will allow for the full evaluation of vertical enforcement as part of the board's 2013 sunset review process. Board staff is just making the board aware of this bill, and no position is needed at this time.
So I'll take one.
Okay, so that concludes my presentation on 2012 legislation. Are there any questions?
Doesn't seem to be. Thank you very much.
The next, there is the regulatory status of regulatory action, agenda item 13B, and these are in your board packets. The chart includes the status of all regulatory proposals that are in process. Are there any questions on the information included on this chart?
Any questions? No, thank you.
That concludes my presentation.
Thank you very much. And to conclude my presentation on the executive committee not only met about the legislation SB 1483, but also on the recommendation on the executive director's annual review. And I am pleased to make sure that the audience is aware, as our executive director is aware, that she came through with flying colors and will be with us for another year. And thank you and congratulations. I hope it's congratulations. Doing a good job. Doing a good job. Well, he didn't talk to me first, otherwise we could have changed our discussion. So I'm going to move on the agenda to number 15, physician responsibility, 14, sorry, licensing update. I apologize. Ms. Shipsky, did you have a question?
When are we going
to have a break? Soon.
Can we have a break for 5 minutes?
A 5-minute break?
It's lunch, so
it's lunch.
Take a lunch break.
Yeah.
Okay, so we'll have 15 minutes. It's now 12:35. I'm going to suggest that we're back in our seats ready to continue at 10 to 1.
Yes, ma'am.
That's 15 minutes by my watch. Exactly. Lunch, restroom, whatever you need to do. Check out, go check out the weather. The sun is shining. Life goes on.
I think the standard labor law is a half hour.
That's all after you...
And 2 10-minute breaks.
But I don't know that would be true if we were full-time employees. Going to go back to number 14 with the licensing committee update and possible consultation of recommendations. Dr. Salmonson, I've also asked staff to try and shorten their presentation.
Okay, very good. Well, I'm going to give kind of an abbreviated report and say that staff, and I won't mention because they're all excellent, but various staff members updated us on the staffing issues, the business process reengineering recommendations, an update on the implementation of SB 100, the outpatient surgery center requirements, and the fact that this information is now available on the website, and we had a demonstration of that. So I'd invite everybody to, in the future, go to the website and check out that process and give us some feedback on how that's doing. But it looked really like it's up and running. We also had a presentation on the allied healthcare professions that are under the domain of the board, and also a presentation on continuing medical education and the fact that some physicians have failed their audit, and with automation we may have even more consistent information on that. We had an update on the implementation of the polysomnographic program and the various levels of providers. We did also find out about the licensing application, and there were no changes to the application at this time. Then, to our really robust discussion, it was really begun with an excellent overview of the recognition process of international medical schools. And this was provided by Dr. Silva, who had been a dean at UC Davis and has extensive experience in the recognition process of the international medical schools. I think a highlight of his talk was that the USMLE, the test, as a standalone, is not a sufficient evaluation for the adequacy of medical training, though an important factor, and that's why the recognition process of the international medical schools is still important. Then Mr. Warden and Mr. Hepler brought forward a legislative proposal, and this is really to consider providing an alternative pathway to eligibility for licensure for applicants who have had some or all of their medical school training at an unrecognized which may mean not previously evaluated or disapproved medical school. And we recognize that this is a balancing act between allowing physicians who have in other ways perhaps proven themselves to get a license, but obviously our primary goal is protecting the public, so we have concerns about this possibility, and I'd like to hear from Mr. Warden and Mr. Hepler to state what the actual legislation could provide and get the board's input.
So I'm going to remind you that we have public speakers as well, and whatever it takes, it takes. I just want you to know that we've listened very well and haven't forgotten yet.
I'm going to give you an abbreviated version
I appreciate
of yesterday. And so basically, there was language previously in Senate Bill 122 that would allow the board to, or require the board to license individuals who obtain some of their medical education or all of their medical education from an unrecognized and or disapproved school. And the language that was in there had some specific things that were even actually less than what is required of some of our current licensing requirements. So in your licensing packet on page 150 was the whole analysis of that, and the specifics of the overview of that was on page 150.1 of what was actually in the language, and basically it was to take and pass a written exam, recognized by the board, hold an unrestricted license in another state, country, in the military for 5 years, had no disciplinary action, completed 1 year of medical postgraduate training, and had ABMS certification and was board and no grounds for denial, which is not equivalent to what a normal international graduate would require for licensure at this time.
Normal?
Well, I say normal, I mean an applicant for international, as we currently have it. So, usual is a better word. You know I'm not normal, so we'll go on from there. So,
so moved.
We didn't have any public discussion.
He's moving whether or not he's normal.
There's a possibility of 16 combinations of medical schools, education combinations that we came up with that is available out there, and that's on page 150.2, which was sort of important for you to sort of understand how many types of schooling processes that would be there and how it could affect the board. As the way the bill was previously written, it would increase the board's workload probably quite a bit and would require all of them to go through the ARC. I estimate, based on how it was previously written, we would get at least 200 applications a year. And the amount of workload that was determined that would be, you're looking at, that was on, what page was I on that? That was on page 150.4 where I did the analysis of that. It would require basically 25 hours per quarter for ARC reviews alone. That's a significant increase, and I would need additional staff to do the preps for all that. An average prep for an ARC memo is 20 hours, not including the initial review of that or the follow-up for the manager and the chief. Staff came up with, after meeting with the sponsor of the bill's staff, a possible alternative to the language that would maybe provide more consumer protection and still meet some of the requirements that the sponsor of the bill was looking for. And that is in your attachment number 2, which is on page 150.10. The original language was in attachment 1, which was in page 50.8. And there was one amendment that was recommended for our proposed language, and that was to include the board's authority to adopt regulations to further define it. And I'll let Mr. Heffer go from there.
Thank you, Mr. Warden. Madam President, members, I think the easiest way to think about this bill, as I said yesterday when licensing committee had a robust and animated discussion on this issue, was that attending a disapproved or under this proposal, attending a disapproved or an unrecognized school does not act as an automatic bar to licensure. And it's important to remember two things. What we're talking about here is not the automatic granting of licensure. It's a consideration that these applicants will be eligible for licensure, and when a person is found not eligible, it's not the same thing as denial. So what we're talking about is as Mr. Warden talked about, is what came out of SB 22 and what this board is contemplating putting in to SB 122. And I'll just go through kind of the nuts and bolts of it. If the applicant had attended a disapproved school, what we talk about, much like we have in other code sections, we require essentially 20 years of licensure, an application of active practice and licensure in another state. If you are from an unrecognized school, which means perhaps we haven't gotten there, it's 10 years. Also, you have to be board certified. You have to pass the USMLE. You can't be the subject of disciplinary action, and you must also have completed 3 years of postgraduate training. That's 1 year additional, if I'm correct, Mr.
That's
Warden,
correct.
from the traditional or regular international medical school graduate. You're not subject to denial for the usual causes under 480, which is criminal conviction, a bad act, that sort of thing. And you have not had a healing arts license disciplined by another state, so if you held some other license. What's important to note is there's two other things that are important to say. This would not apply to, you talked about special faculty permits, and some board members are familiar with the 2111, 2113 specialized exemptions for licensure, essentially associated with the UC. This section would not apply to them, nor would it impact postgraduate training, otherwise known as the PTAL process, meaning that in order to get a PTAL, which is required for an international medical school grad, you must have graduated from an approved school. So what this is, to sum up, it's sort of an alternative pathway. The board has kind of an alternative pathway in the 2135.5 series, which grants the board the authority to issue licenses for applicants that have a non-traditional background, correct?
Yes, it depends on it's a different way to get other doctors who, one of those pathways is the way that we use for students who have gone to a school that we have recognized, but they may have gone to the school a little before the recognition. So those particular applicants qualify under 2135.5, but they're reviewed by the application review committee prior to them being granted a license. So
I guess the fundamental thing to remember here is in this proposal, we do differentiate between an unrecognized school and a disapproved school. And the disapproved school has the 20-year rule. The unapproved school has the 10-year rule, but the board may aggregate. It is permitted for the board to aggregate in that variation, but even if it aggregates, meaning combines, there must be one continuous 5-year practice in a state licenses. So you can't be licensed in 20 states for 1 year in order to aggregate to the 20. So with that, I'll be quiet. I'll be more than happy, as Mr. Warden will, to answer any questions you may have. I believe the board, the licensing committees was a support for this concept, correct? With the amendment?
yeah, the recommendation was for the board to consider it.
So am I looking for a motion?
Yes.
So I'm looking for a motion to adopt what we just heard. We'll then have public comments from the board. We'll have public comments from the public, and then we'll take a vote. Okay?
Am I allowed to make that?
Please.
Okay, I'd like to move that we adopt a support position with the amendments that were presented.
Do I have a second? Second. Thank you. Do I have comments or questions from members? Dr. Ganadev?
Yeah, thank you, Madam Chair. My comments or questions are related to disapproved medical schools. So if you look at disapproved medical school, that term itself sounds pretty bad. So you're mentioning that if they went only part-time but graduated from an approved medical school, that's what we're recommending. Is that correct? But not graduated from a disapproved medical school.
The way our language reads, if you acquired any part of your professional instruction from a medical school that was disapproved, then the 20-year rule would apply. If you acquired any part of your professional medical education at an unrecognized school, the 10-year rule would apply.
So yes, you could have graduated from a disapproved school, the 20-year criteria, 3 years, board certification, not eligible for discipline, applies.
It allows them the ability to apply. It does not mean that.
No, it just applies for the motion.
You're eligible to be considered for licensure. When you can get one, you're eligible.
Well, eligible to apply. Let's be very clear on that.
Well, I think that's the part I do not understand about you're eligible. I have to say I was the vote who didn't go along with the community recommendation, so I'm making that clear at this point. If you have all this and somebody comes in with a bona fide records, they went to disapproved school for 4 years, and they come in and then nothing sticks out. He's good surgeon, good recommendations and everything. Can you disapprove him? Or under this law, can you disapprove him?
This law makes them eligible to apply for licensure. It doesn't guarantee licensure.
This is nothing about the person that is going to be licensed. This is about the person applying for licensure. So it's only that very narrow focus, applying for licensure.
So if I am a student, if I'm a surgeon, I have to be that way for once in my lifetime.
She's never been. She wants to be. It's okay.
Okay. Yeah. If I am a surgeon, I went to Caribbean, got 4 years of disapproved school, and I got my ABMS board certification. I practiced in
Podunk, America.
Where?
Podunk, America. Anywhere USA.
All right. Okay. Missouri. No, probably.
No, not just name. I'm not naming the state in Texas because I don't know what the laws are in other states.
So I come here and I practiced 20 years. I actually probably practiced 20 years. I'm using this rule. And I come in and you look at my application and you turn me down. Can I go to number one, go to the Senate and then the committee and then say, medical board, turn me down, this is not fair. Number two, can I go to state of California and then say, hey, I fit all the criteria that they have. Where is the ground for turning me down?
I can answer that as your counsel to the board. Currently, if you, again, we're not a person who would apply, that, for example, if I would apply in my current status, I would be found not eligible for a various amount of reasons. Number one, I've never been to medical school, never taken the USLA, so I'll use my example. The Division of Licensing would find me ineligible for licensure. My remedy at that point is twofold. I can request a hearing, just like we would do for any person, a statement of issues or a disciplinary proceeding. And I also may challenge that board decision of finding him ineligibility in Superior Court. Those two mechanisms are in place now and would be in place with the passage of this bill.
Well, I'm trying to use the ordinary example. I'm not just a regular example. Someone who meet all these criteria and meet all the criteria, and there's nothing wrong with me. when you say looking at it, to me is once you set this rule up, if an ordinary people coming in here, then you have to give him the license. Ordinary good people coming here, you have to give him that license. So why don't you call it that we're changing the rule and not saying we give them the opportunity to look at the rule?
So let me clarify the process and the procedures, just 10 seconds. Applying for licensure does not guarantee you a license, and we do turn down applicants for a variety of reasons, not these yet maybe, or maybe these, doesn't matter. We do turn down people that want to be licensed in the state of California. We do that. But what you're asking about is what I think also is what happens if we now put you through the 20 years, the board specialty, the no discipline, all of the stuff, and now you are licensed. Who does the public have to go back to and hold responsible if you went to a disapproved school? You're not asking that question.
No. All I'm trying to say is, once we pass this rule, we pass this rule. We gave somebody who fit the qualification not just a chance, and pretty much if he fit the qualification, he is getting the license. So don't say that we're not.
Oh, you're saying it's automatic?
Yeah.
It's not automatic. You still have to apply. You still would have, for example, on the application, if you were committed a crime that was substantially related, all the things that you would normally deny an applicant for would still be in play here.
Okay, Dr. Diego, and then Dr. Salmonson.
But currently, if I apply from a disapproved school, I'm not eligible to apply, correct?
Correct.
I guess what Hetty is saying now, that would not be a reason to not, if I'm perfect, I'm stellar, there's nothing wrong with me except that I'm from a disapproved school. You're not going to not give me my license because why wouldn't you? There's nothing wrong with me.
Correct.
That's what you're saying,
Well,
right? I guess that's why she's saying is.
All this does essentially is make people. You're exactly right, Dr. Under the current law, that applicant would be essentially found to be ineligible somewhat automatically. Wouldn't meet the criteria for eligibility. What this does is essentially remove that automatic bar and say, okay, now it at least is eligible to be considered, where previously it's not. Mm-hmm. There's no automatic granting of licensure. You just fall into the eligibility pool.
I'm going to move to Dr. Salmonson. And then,
I was just going to basically say the same thing, which is, yes, it creates an alternative pathway. And one might argue that it's not necessarily an easier pathway because to get a license coming directly from an approved school or recognized school, you only need 2 years of training in the U.S. And by putting the bar at board certification, I don't think any of us can think of anything that's less than 3 years of, and in one program, sufficient that they actually passed their board certifying test, which is, I think, why I felt comfortable with it. And combined with the fact of 20 years of practice, I think this won't make medical schools not want to go through the recognition process, because I don't think most students would say, it doesn't matter if I go to an unrecognized school, I can still practice in California because I'm going to have to practice 20 years elsewhere first. So I think that still validates the necessity of international schools to want to be recognized.
I'm sorry. I have a hard time saying to the world that Medical Board of California is now accepting doctors who we disapprove the school. I think it's this whole thing. I understand your logic. The ABMS is definitely required. And with the pool of the people who come into the United States for licensure, you know, right now, half of them are from this kind of,
the American-speaking students, and half of them are coming from real foreign countries. And when we're talking about the ABM's qualification, you know, all the United States graduate nowadays, 90% of them has ABMS. The portion who does not are the foreign graduates, whether it's American-born or not. So we are getting the top of that pot, you know, for them to have the ABMS qualification. And I agree with you on that one. My only concern is for Medical Board of California to go out and say, we're now accepting someone we had disapproved the school of. And that was the only problem that I have.
Thank you, Ms. Chang. Dr. Ganadev and then Dr. Levine, and then I really need to hear from public comment.
Just to clarify for me, this 1020 rules is licensed in another state, not in another country. Is that correct?
Another state or federal territory, correct.
Okay, so within the United States.
Correct. Okay.
Dr. Levine?
And I just want to clarify that ABMS certified means at the time of application. So someone who had allowed board certification to lapse would not be eligible through this process.
Correct. Okay, so now I'm going to have some public comment. I'm going to call Bill Gage forward. You've been here all day. I guess you get to your turn now.
Good afternoon. My name is Bill Gage. I'm the Chief Consultant for the Senate Business and Professions Committee. I've been with the committee for 20 years, been with the Senate for 25. I feel I've enjoyed working with the Medical Board over the past 20 years. I think we've done a lot of good work, made a lot of good changes, enjoyed working with Linda. I think we're still friends after 20 years. But this is again one of these issues that we're trying to deal with. Came to the attention of the senator several months ago. He was made aware of the fact that there are physicians from other states that have a number of years of experience. And he thought at the time, he asked me, he said, well, doesn't the board have discretion currently to look at these physicians from other states and make a determination based on the fact that they've been practicing in the state for a number of years? And I said, well, if they're from an unrecognized or disapproved school, then they're automatically denied the opportunity to even apply for a license. But we did go back to our legislative council. We asked them we sort of asked them the question, if you have a physician from another state who's been practicing for a number of years, if it was possible for the board still to make a determination, even though they're from an unrecognized or disapproved school. Council felt that, looking at the language in the codes, that the board did have that discretion. We went back to the board, of course. We met, president of your board and staff and legal counsel met with the senator. We discussed, we don't have a process in place for this, and since there could be a dispute in terms of whether or not the board does have discretion under this situation, that we should clarify it, at least in code, exactly what it is and what the process would be, and at least set what we consider as a threshold for even applicants being considered. Again, we looked at it. It wasn't going to be a mandate. We considered that, in effect, it would provide just discretion to the board in terms of looking at this applicant, but at least setting some sort of number of years that they actually been in practice before they even be considered. Just so you know, I think all of our health boards currently have that discretion from day one. So if they have somebody who comes in who's had 5 years, 2 years, 3 years of experience, they basically can determine based on their practice, even though they're from, and in the instances of most of the other health boards, it's from unaccredited schools. Obviously, we don't have a situation here currently that we have an accrediting agency that looks at all the international medical schools, to determine some sort of accreditation standards that at least the medical board can rely upon. So the medical board is sort of put in the situation like all the other 50 states that you happen to make a determination as to whether you're going to recognize the school or disapprove the school. I think what we're trying to accomplish, at least with the language, we started out, we actually had our legislative council draft the language for us. They came up with the 5-year requirement. We did indicate to the board that, that isn't something we were wedded to in terms of using that 5 years as the threshold. So with that, we came back to the board and said, well, we'll take out the language out of the bill that we had currently. And the only reason we had to put it in initially, because we had to let the Assembly Committee, Business and Professions Committee, know that we were going to be dealing with this issue. But we took the language out of the bill to work with the board in terms of coming up with language that makes, more sense in terms of how we can accomplish this by looking at practitioners from other states. You need to realize the legislature's been really focused on this whole idea of cross-border practice. We've been looking at all the other professions in terms of providing and sort of taking away any arbitrary barriers that we have to reciprocity in terms of those practitioners coming into California. So it's a real emphasis not only on our committee's part, but the health committees, both in the Assembly and Senate, and looking at ways to allowing more cross-border practice and sort of, at least eliminating any what we would consider any barriers to practitioners coming into California to practice.
I need you to wrap it up for...
And I'm finished.
Thank you.
And if there are any questions, I'll be glad to answer.
Thank you. Are there any specific questions? Okay, thank you very much for being here. Thank you very much for listening to our concerns as well. We appreciate that. Stuart Shea. Pardon me? Dr. Feynman, come up. You get the same 3 minutes together. It's a collective 3 minutes here.
I'll be brief. Madam President and members of the board, good afternoon. My name is Mitchell Feynman, and I'm a triple board certified rheumatologist and internist practicing medicine in South Carolina. I support the change of the law and policy of the Medical Board of California to permit physicians who have over time and with appropriate credentials practiced medicine in California. After my graduation from the University of Southern California, I attended Mundial University School of Medicine in Santo Domingo, Dominican Republic. Upon learning that the school was not academically on par with USA regulators, I proactively applied to Ross University School of Medicine, an approved California medical school. After Ross vetted my medical records, my academic records, I was admitted as a second-year medical student. I would like to stress that the board disapproved Mundial University after I left the school and then transferred to Ross University. From that point on, my medical education and career has been, by all accounts, fulfilling, rewarding, and successful. I did several of my clinical rotations at Boston University School of Medicine. I was accepted in postdoctoral programs in 1987 at St. John Hospital and Medical Center in Detroit. I completed my rheumatology fellowship in 1992 at Washington Hospital Center in Washington, D.C., a Georgetown-affiliated hospital. I took my boards in 1990 and 1992. I obtained licenses to practice medicine in Florida, the District of Columbia, Maryland, and Michigan in 1990, and South Carolina since 1996. I have maintained professional and academic affiliations and have practiced medicine in the United States for over 20 years without any disciplinary actions against me in any jurisdiction I have practiced medicine. I think I have proven to the public at large and the medical community that I am competent to practice medicine and protect consumers. I have learned that the current interpretation of the law by the Medical Board of California does not even permit me to apply for licensure, not because I am not qualified or did not graduate from an approved foreign medical school, but because a small fraction of my medical education was at a disapproved school. That interpretation is not the letter of the law. I graduated from an approved medical school, which is the law. I have met all the other requirements under the law. As such, I support the recommended change in the law and policy to permit me to practice medicine here in California. Thank you very much for your time.
Thank you very much. Stuart, did you want to make a remark?
I just have a real quick,
I think I also represent three other physicians who are graduates from foreign medical schools. One teaches at Baylor, is faculty member at Baylor Medical School. Another one is licensed in New York and Connecticut. They all are board certified. They've all been practicing over 10 years. I find it, are very supportive of this. They can't even apply. The general, Member Chang, we were having this conversation. Right now, if they apply, it's immediately rejected. It's done. His would be done too. And it goes on the National Data Bank, if I'm correct. And so he's got if he was rejected, the application, okay.
Finding of
I'm not shaking my head, yes, I'm just...
findings of ineligibility are not reported to the
Okay, that's great. So he can't even get to that level. But they all support the change. And the only other thing I would like to mention was the fact that I don't think 20 years is reasonable. I think it's way, way, way too long. But that's for the board to decide.
Just a question. No.
No?
No. Thank you.
Thank you.
Thank you.
Krista Summers? Three minutes together.
Yes. Good afternoon. I work with the Office of Albert Robles, who represents doctors seeking licensure to California. And in that regard, as to this bill now before the board, we agree with Dr. Salmonson that the reciprocity pathway in comparison to the regular pathway for licensure is not an easier pathway by far. And I'd like to address, in the time that I have, just a few provisions in the proposed amendments which we believe would undermine the board's goal of having this in the first place, which is to promote access to quality care. First, the provisions relating to the minimum required years of practice. By everyone's admission, the 5 years of Senator Price, the 10 to 20 years now before the board has been put in writing without careful consideration of data that might correlate better what those years should be. I believe that they're longer than necessary. We can easily envision a circumstance of a young doctor having actively practiced for 5 years, having had numerous patient contacts each day, and who in that 5-year period would have amassed a track record such that the board could readily see whether there's a pattern that would establish the clear competency of that doctor. And by the same token, someone practicing for 10 years who doesn't have an active practice, who has much less patient contacts, you could not make that kind of a determination based on their track record. So that is something that I would like the board to consider more with reasoned and validated data. The other is one that Dr. Feynman, who spoke before us, raised in his talk, and that is that the proposed amendment makes no link between the timing of the board's disapproval or non-recognition of a medical school with the timing of the doctors having actually attended that school. So the result is, for example, that a doctor, then likely a naive medical student in his 20s, attends and perhaps even graduates from an unrecognized school. Subsequent to graduation, the board evaluates that school, finally gets to that school, and then disapproves it. In that example, the doctor then seeking reciprocity would be subject to the presently set 20-year minimum years of experience for disapproved schools, when it really wasn't his fault that the school became disapproved and had no choice at the time he was making it as to whether or not the school may or may not be disapproved. And with that, I'll turn it over to Dr. Gargat.
Thank you. 1 minute, okay? Seriously, 1 minute.
Yeah, thank you very much. I'll keep this very brief. I know most of the points I wanted to make actually have already been made on a couple of occasions, but essentially, for me, the same story applies. By the way, I'm sorry, my name is Ravi Gargat. I didn't do the introduction, but, you know, I trained as a foreign medical graduate. All of my clinical training has been based in the U.S. From my 3rd year of medical school onward. And since then, I've also, I think in my career, achieved a point where I'm very content, actually serving as a medical director for an inpatient program starting a pediatric inpatient program and being in charge of educating residents as well as medical students where I currently work, which is Las Vegas. And just briefly, we actually my family and I live in California, and I, for the past 6 years, have been commuting to Las Vegas to work, simply to be able to provide my wife with her veterinary education here in the state, which is why we moved. And the main thing that I was trying to get across, or wanted to get across, was I think that as a general consensus, we all feel that clinical achievements and the length of practice as far as clinical skills can be shown to be adequate by the time and the amount of patient contact a physician has. And of course, 20 years, 10 years is the discussion, but I feel like if a physician in my position can prove competency to the board in one way or another, that may help alleviate some of the concerns. And one quick point I wanted to make was perhaps if a topic of discussion could be perhaps using hospital credentialing for these physicians that are applying. For example, getting reports that have been run from the individual hospitals where these clinicians have been credentialed sometimes is a more stringent process than actually obtaining a license in a state. They keep track of your patient contacts, any actions that have been taken against the physician that may prove to be useful to the board to sort of alleviate some of the concerns of competency when it comes to that.
Thank you. Good recommendation. Just out of curiosity, where did you go to medical school?
I graduated from the University of St. Eustatius, which is a neither approved nor disapproved school.
I'm just curious. Thank you. Okay, so we have a motion on the table. We've had public comment. The issue is, again, let me just remind everyone, this is for the opportunity to apply for licensure. This is not anything, from what I understand, other than that. Now, Dr. Ganadev, I know you have a comment, so could you make it brief, please, so we can take a vote?
Yes, I know you do want to go home. The 20 years actually sounds really so long to me. I mean, if what I'm looking at is the California kids who made a mistake and went to a school, got everything else afterwards. And that putting that 20-year period, and also if the school was not accredited by us, but it was not disapproved by us, at that time, I think that we are punishing these people rather than anything else. 10 years, I'm fine with it. If
we're talking about disapproved versus unapproved, they're two different.
We're talking about disapproved schools if they were not disapproved when they went to school.
I guess I would just like to say that there are so many different permutations. I think however many that Kurt told us. So I guess my
it's about 16 or 18. So if anyone's interested in all the different combinations, they're in the book.
So I guess my feeling, what I guess I was hoping from the board was, are we receptive to an alternative pathway, and then the details of the length of time for these alternative could be worked out. But
so the details will be
agree in principle there should be an alternative pathway.
Let me just point out, Madam President and members, that right now it is contemplated that there could be hybrids, or what I called aggregates, that if you were multiple licensed in multiple states, you could get to the 20-year rule, but there would be one block of 5-year continuous license in one state. So the medical board, or at least staff, when it drafts this proposal, had taken into consent the hybrid or the aggregate model.
Okay, thank you for that clarification. I'm going to ask the members now for a vote and support.
We will come back to the board.
It'll come back as a regulation. Sure. So the motion is on the table. It's been everything. We've gone through the process. All those in favor of the motion as it is, please say aye. Aye. Any opposed? Any abstentions? Abstentions. Thank you. One abstention. Okay, that's fine. No, just make sure. Yes. So now we're going to move on to item number 32. And then I promise after 2 o'clock I'll take a deep breath and we'll go a little slower.
Thank you for accommodating my need to go on my volunteer trip.
Well, it's not a volunteer trip. It's a medical mission, so that's
medical mission. No, it's not vacation. I'll be working, but it's by choice. I'm going to be working.
We understand. I just want to clarify. Thank you. Thank you. So we're going to entertain nominations for the officers of the board. It's the time, and Dr. Salmon.
I would like to. Anxious. I am, but I'm anxious in more than one way because I would very much like to nominate Dr. Sharon Levine for the office of president.
I'll second that.
Do we have any other nominations for the office of president?
I would nominate
Wait, we're talking about president.
You have to vote.
Any other nominations for president? We don't need any board discussion on this one? Okay. All those in favor, we're going to close the nominations. No public discussion. No board discussion. All those in favor of the motion, please say aye. Aye. Any opposed? Any abstentions? No. You should have gotten this. It is very conflicting. There's always conflict in life. That's what life is. Thank you. So now, congratulations, Dr. Levine. But I think I'll continue to run the meeting for the rest of the day, okay? Okay, thanks. Okay, so now, do we have any nominations for vice president? Dr. Dussault, you've just been nominated. Do you have a second?
Second.
Do I have any comments on any other nominations? It's just going off the smooth. Okay. All those in favor of Shelton Dussault, Dr. Dussault being nominated vice president, please say aye. Aye. Any opposed? Okay. Now we're going to go for nomination for secretary of the board. Dr. Diego?
I nominate Dr. Carrion.
Thank you. Do we have a second? Okay, thank you. Do we have any other nominations? Nominations are closed. All those in favor of Dr. Carrion, secretary of the board? Say aye, please. Aye. All those opposed? I'm not used to having such a smooth. Thank you. So now we have our team for now. Thank you. Thank you all, and I wish the new board all the best and our congratulations. So now, Dr. Salmonson, safe journey, safe travel.
Thank you.
So we're going to move to item number 16. 15. Physician responsibility. My apologies, Ms. Shipsky. I really apologize. Please, with your report. I apologize for not paying attention. For me not paying attention. Oh. Not you, me.
That's fine. All right, we had the Committee on Physician Supervisory Responsibilities. We met yesterday afternoon, and the purpose of the meeting was to discuss the requirement of SB 100, which was the price bill, which requires the board to adopt regulations regarding the appropriate level of physician availability needed within clinics or other settings using laser or holder input on 4 regulatory proposals drafted by staff. The 4 proposals consisted of the following. The first, that we would adopt a community standard proposal which would require a physician to be available to the provider in accordance with the standards for the community in which the procedure is being performed. Or number 2, an on-premises proposal which would require a physician to be physically present on the premises where the procedure is being performed throughout the duration of the procedure. Or 3, a physically present and immediately available proposal which would require a physician to be physically present, interruptible, and able to furnish assistance and direction throughout the performance of the procedure. And 4, a not physically present but immediately available proposal which require a physician to be immediately available and contactable by electronic or telephonic means without delay, interruptible, and able to furnish assistance and direction throughout the performance of the procedure. The staff recommended that the committee focus their discussion on either option 1 or option 4. However, the committee discussed all 4 options. The discussion did take place on all the options. The discussion then focused on option 4. It was the consensus that option 4 is probably the most practical. And then also we had a discussion about ensuring that any practitioner performing elective cosmetic procedures using lasers and intense pulse light devices and physicians supervising these practitioners have appropriate training to ensure consumer protection. So after much input from the committee members and members of the public, the committee voted to recommend to the full board that it go forward with a regulatory proposal for revised option number 4. And that revised option number 4 reads as follows.
So is this part of your motion, Ms. Shipsky?
Well, I'm going to read it first and then we'll entertain a motion for it. because it's a two-part thing. There's two parts to it.
Okay.
It was recommended that the regulation should read as follows. Whenever an elective cosmetic procedure involving the use of a laser or intense pulse light device is performed by a licensed healthcare provider acting within the scope of his or her license, a physician with relevant training and expertise shall be immediately available to the provider. For purposes of this section, immediately available means contactable by electronic or telephonic means without delay, interruptible, and able to furnish appropriate assistance and direction throughout the performance of the procedure, and inform the patient of provisions for post-procedure care, and such shall be contained in standardized procedures or protocols. It seemed also to be the consensus of the committee that because the regulations that were being sought primarily focused on the supervision of the provider who's performing, the laser, what it failed to do is take into account that the bigger overriding issue is those that are performing and supervising have to be specifically trained to be able to do so. And so the committee also is forwarding a recommendation that this board approach the legislature going forward and indicate to the legislature that we believe further legislation is necessary to enhance consumer protection in this area by requiring specific training and or certification. So what I'd like to do is call for a motion on the proposed language that is a revision of option 4. It does contain additional language requesting that the person have relevant training and expertise. And most importantly, we thought was it added that the patient would be informed of procedures for post-procedure care, and that this all be contained in standardized procedures or protocols.
So that's your motion?
That is my motion.
Thank you. May I have a second?
Second.
Okay, now we have discussion on the motion. Dr. Levine?
Just a clarification. So if the means of contact is electronic or telephonic,
correct,
what does that mean in terms of available to intervene, basically, if necessary?
The committee discussed extensively because obviously we have the issue about telemedicine, but we also have the issue that in many other types of procedures that the physician can be available, immediately available means by telephone, and we're asking that that person provide appropriate assistance. Obviously, if that person is not on the premises or within a reachable transit time, then as the community standard would be, they would call 911 if they needed appropriate backup. The difficulty we had, and certainly Mr. Hepler can comment on this, is that the statutory outline which this board had received to put together regulations is somewhat narrow, and so what we were attempting to do is to stretch that to make certain that we had some additional consumer protections in there. And then with the second part, that there's much more that's needed, and we need to let the legislature know that.
Dr. Ganadev?
Actually, I appreciate what committee did a great job. My one question is what prevents or what are the safeguards where one physician covers multiple laser clinics, quote unquote, of these people practicing without medical license?
We did have that discussion, and the difficulty about setting out, particularly in these regulations, a ratio of 1 to so many, it's very problematic because we don't have that requirement in any other area except with the supervision of either a physician assistant or a nurse practitioner. Many registered nurses are doing these procedures under standardized protocols. So that was discussed, and council can weigh in about why this would be problematic to put a ratio in there.
Thank you, Ms. Shipsky. Dr. Ganadev, the ratios that Ms. Shipsky spoke of are essentially statutory ratios where the legislature has spoken. it was my considered opinion that going to a ratio in regulation would be on the very cusp of what we could do by regulation. And perhaps if there's a statutory ratio that needs to be set, it could be addressed in the ongoing approach or ongoing communication with the legislature. But I felt it was a little bit of a stretch to get to a ratio by regulation.
My concern is still the same. That is that this entire law, in my opinion, was to really make sure that consumers are protected by appropriate supervision by the physicians. So if we don't have any restriction or what they can do, it could be one person in San Bernardino, California, supervising 10 of these clinics, doing things which could be danger to the community.
Mr. Hepler, might I ask you a question? Is there not usually a treatment plan that's in place when a doctor or a practitioner has a treatment of some kind that they're performing with a patient? Is there some kind of discussion that where this would probably come forward automatically? So that it's not like all of a sudden we decided to supervise 10 different clinics in 10 different parts of Southern California by one doctor. In fact, the doctor that is performing or has, we don't have that? That's not part of normal protocol with a patient and a treatment?
Let me just say this. Let me take one step backwards. Of course, what this regulation, the statute really speaks to is some licensed person other than a physician doing these procedures. And so at least I can speak as former counsel of the PA, and I think the PAs were represented yesterday. Some of the supervision and treatment protocol would be addressed already in the delegation of services agreement down from the supervising physician to the PA. So I'm confident that at least backup plans or whatever standardized procedures would be encompassed in that plan. I really can't speak to advanced practice nurses because I really don't know that much about them. But as far as the procedure itself, certainly it's the case. It was a robust discussion, as Ms. Shipsky pointed out, more than a robust discussion, perhaps even going as far as animated yesterday. And my hope, Dr. Ganadev, not to use hyperbole, but if it's a 1 to 10 ratio, that the clause that says interruptible would be that, hang on, I can't take your call right now because I'm talking to my clinic in San Bernardino, Riverside, Orange County, Alturas, and Blythe. And so I would think that would be essentially at least giving guidance to the physician that he or she may be stretching them thin, because obviously I think a fact finder, if we ever took this to accusation order, would be that you weren't immediately available because you weren't interruptible because you were giving advice or treatment or the appropriate assistance to another one of whatever is going on there.
And if I can add there, the part of the discussion that we're going to follow up on is that it's felt that we can pursue some additional perhaps restrictions by taking a look at the definition of Medi-Spas and how they obtain fictitious name permits. And then, as we know, there's new legislation actually that is very, very directed at the corporate practice of medicine in the settings where, in fact, there isn't obviously a physician involvement, and that you do have other people doing these procedures. So there's a variety of tools that we are looking at. Again, the difficulty dilemma we have is statutorily we've been told what specific regulations they're looking for, so we are trying to push the envelope to get that consumer protection, knowing that perhaps the statute itself is deficient, and what we need to do is encourage that to be changed.
As this is set for regulation,
yes,
you will have more public comments and more public engagement and more professional engagement, and I think this is exactly where you're going to get additional safeguards. Dr. Ganadev. Yes. So do I have a motion? I have public comment.
If I could just clarify the motion, you hit on it, Madam President. The motion would be to set this, the first part of the motion would be to set this for regulatory hearing. The proposed regulation.
So moved.
I have a second? Second. Okay, now do I have more comment from the board? Do I have any additional? I don't have any slips from the public, but if there's someone that wishes to speak, I'm fine. So all those in favor of the motion to set this for regulatory hearing for October of 2012, please say aye.
Aye.
Any opposed? Any abstentions? Thank you. So that's done.
And on the second part, Madam Chair, Council can tell me, this wasn't agendized, but it's part and parcel of what we did. The second recommendation needs to go forward, and that is that
Excuse me, I'm sorry?
The second recommendation also needs to go forward from the committee that the board approach the legislature about going forward on additional legislation that we felt would enhance consumer protection by specifically requiring training and or certification for the both the provider and or the physician supervising.
So we should put that on the calendar for a future board agenda?
Council, can we take up this because it was in the course
of... My recommendation to the committee that they essentially be wrapped together, because I think they're sort of part and parcel about what was going on. One is you made the recommendation, but as sort of an adjunct, it was my understanding the committee said, hey, we recognize that there may be more attention needed to be directed to the legislature and statutory revisions to gain the appropriate level of consumer protection.
All right.
So I'm hearing from two different ears, two different statements, and I'm trying to pay attention to what you're saying. And I apologize for having a split personality. So what I'm hearing is that it could be set for 2013 session.
Well, I would hope, and I felt there was the sense of the committee that when we go forward on the regulations, though, that we simultaneously communicate to the author of the legislation that there are some deficiencies that really do need to be addressed.
So staff should take note of that.
So can that be part of our motion, or do we have to make a separate one, Mr. Hepler?
Well, it was my understanding, Ms. Shifsky, I'm sorry, that that was part and parcel of the original
So
motion.
let's have it together with the original motion. Would that be all right? Okay, all those in favor of the motion as now amended, please say aye.
Aye.
Any opposed? Thank you very much.
And so just as reported at our upcoming meetings, we will be reviewing the entire issue about med spas and how, in fact, they do get fictitious name permits because they are medical practices.
Thank you.
And to see what we can do about that.
Good. Thank you very much. We're going to move to the Enforcement Committee. Dr. Lowe?
Thank you. So the Enforcement Committee met yesterday and had a very ambitious agenda in hopes of shortening today's agenda. The discussion started with a presentation by Senior Assistant Attorney General Carlos Ramirez and Supervising Deputy Attorney General Gloria Castro about the topic of amended accusations. So the presentation began with a brief overview of the Administrative Procedures Act, from which the rules relating to administrative law is derived. We learned about the Respondent's Bill of Rights, which essentially calls for due process being afforded to licensees. The crux of the presentation had to do with an amended accusation, what an amended accusation is, and why an accusation becomes amended. Legally speaking, an accusation is a written statement of charges setting forth the acts or omissions with which the respondent is charged, to the end that the respondent will be able to prepare a defense. The accusation also has to set forth the statute and rules the respondent is alleged to have violated. So an amended accusation may be filed at any time before the submission of the matter for decision. Where an amended accusation presents a new charge, the respondent must be afforded a reasonable opportunity to prepare a defense. Hearings may be postponed for good cause. Amendments to accusations are made and served at any time during the course of the case, as soon as new investigations are completed and accepted for prosecution. Once the pre-hearing conference is held, which is 6 weeks prior to the hearing, administrative law judges control whether and when an accusation may be amended, filed, and served by setting deadlines. It's rare that accusations are amended as to new charges during a hearing. When it does happen, it's usually the result of new evidence that was not disclosed in a pre-hearing discovery due to any number of valid reasons. So as an example, for the year 2010 through 11, 25 of 226, which is 11% of the accusations, were amended. Of those, 2 required filing a second amended accusation. There were no third amended accusations. Of the 25 amended accusations, 11 were amended well in advance of the hearing date due to new investigations to an existing accusation. For example, there may be a case pending at the AG's office and another complaint is received in the field that requires investigation. Once the investigation is complete and the case is accepted for prosecution, the deputy will have to add the charges to include the information obtained in the new investigation. So of the 25 cases amended above, one was amended to address an issue required for the surrender of a license, and one was amended the first day after hearing to conform to the pleadings to the testimony of board expert witness. So due process allows continuances so that the respondent can adequately defend against new charges in an amended accusation. Amended accusations prevent the filing of multiple accusations and multiple hearings against the respondent, allowing for more efficient resolution of the matters, and lastly, amended accusations pare down or add charges where justice requires it. Okay, so that was a discussion on amended accusations. I'm sure that Mr. Ramirez will be glad to answer any additional questions. Okay, the next agenda item had to do with the expert reviewer training. So Ms. Laura Sweet gave an update on the expert reviewer training that was held at UC Davis Medical Center on May 19, 2012. So this was a program where we wanted to give expert reviewers more consistent training of what was expected of them, and we hope to carry this up and down the state, and this was our first effort. The training was a huge success. Over 100 doctors attended, and the critiques of the training were overwhelmingly positive. Comments included sentiments such as, "This is the best forensic conference I've ever attended. This exceeded my expectations and reinforces my feeling good about being an expert for the medical board. The scenarios and discussions are great to have viewpoints of both sides. Great seminar, amazing amount of work put together, and thank you." So Ms. Sweet said that there were a few modifications she'd like to make in the training of that will be held in our next sessions, and these are targeted to take place in February 2013 in San Diego, or perhaps UC, or perhaps in Irvine. A few experts expressed justified concern that they received little or no feedback as to their work as an expert, and the staff realizes that this is a problem, and we're working to resolve this, and they have been working on it as well. At one point, Chief Threadgill had allocated 2 of the Consumer Protection Initiative analyst positions to that unit, and they even had space allocated for the analysts, but those positions were lost due to the required 5% personnel reduction. Then the thought was to utilize retired annuitants for those positions, but recently the board had to eliminate the use of 19 annuitants and are constructively forbidden to hire new ones. As far as the training process goes, Ms. Sweet proposed the feedback can be incorporated into the training by paring down the course to 6 hours and then giving the experts additional hours of credit for preparing expert opinions on a sample expert case. Then a panel of supervising investigator, medical consultant, and supervising deputy attorney general will provide individualized feedback as to the written opinion. Additionally, the enforcement program is looking for other ways to augment the one individual who is currently handling the expert program in order to systematically provide feedback to our experts, including the status of cases that have resulted in accusations being filed. But as for the expert training itself, it was incredibly successful and well appreciated. So at this point, I'd like to call forward Ms. Laura Sweet. Can you come up here for a second? Or maybe you can come over and see Barbara.
Please, I can figure this one out.
Here, the staff would like to present
All the time.
Laura Sweet something here.
Actually, I want to thank you on behalf of the medical board, seriously. And Dr. Lowe, your leadership has been unbelievably successful, but I'm trying to think of a bigger word than successful. But inspirational and on point. It finally took your leadership and your strength of purpose to get this done, and I want to really thank you. And Laura, on behalf of the medical board, I want to thank you for your outstanding participation in this. And now, so for any of you that need to know why you put your hands on a certificate when you receive some kind of commendation, is so that in the future they can never remove you from the picture. It's very true. Thank you, Dr. Lowe.
I can tell you that Ms. Laura Sweet and Ms. Threadgill did a phenomenal job, and I think this is going to definitely raise the bar and the quality that we get from our experts. And you can see that these are some of the pictures from that training session. I mean, it was intense. Not anybody left. I mean, everybody was focused the entire day. Okay, so on to the next agenda item. We then heard from Susan Cady, who gave an overview of the CCU process and goals. This is the complaint unit. So the complaint process, the review process is much more detailed than many people realize. When a complaint is received, it is entered into the computer, and by law, an acknowledgement letter is sent. The complaint is then referred to an analyst who reviews the case to make sure that the board has jurisdiction. If it's a quality of care case, the analyst requests a release from the patient, obtains medical records, and a summary from the physician. The case is then sent out to the reviewer in the same specialty to determine if the treatment was within the standard of care. If there is insufficient information to establish that, or if there may be a deviation from the standard, the case is then referred to the district office for investigation. For non-quality of care cases, which might include sexual misconduct or the unlicensed practice of medicine or physician impairment, these cases are sent directly to the district office for investigation. So Ms. Cady showed us a chart depicting the average time it takes to process a complaint. During the past 5 fiscal years, the time has increased about 24 days. Ms. Cady then showed us, under ideal circumstances, the time allotted for each component of the analyst's job. For example, 10 days is allowed from the receipt of a complaint for the complaint to be received, initiated, and acknowledged. This is set forth by law. Overall processing time can take 8 to 122 days. The most time-consuming steps are requesting release from the complainant, which can take up to 25 days, and then requesting the medical records. By law, physicians are entitled to 15 days to produce records. Hospitals are entitled 30 days. Within 7 days of receiving the records, the file is referred for medical specialty assignment. The analyst then has another 10 days to find a specialty reviewer. This can increase if there are too few available specialists. Another 38 days can elapse to receive the review from the specialty reviewer. So Ms. Cady identified areas where improvements can be made, for example, reducing the time it takes to acknowledge and to enter a complaint from 10 days to 5. So I think we're trying very hard to make this whole process much more efficient. Ms. Cady will be giving a presentation about that at the next board meeting with specific recommendations to us. Okay, the next agenda item, Mr. Vern Hines from Department of Consumer Affairs gave us a presentation on potential auditable risks identified in the Medical Board's Central Complaint Unit. So the DCA commissioned Mr. Hines to determine if its programs are prioritizing and processing complaints in an efficient and effective manner. Mr. Hines was tasked with identifying where high-risk enforcement programs can improve their processes and procedures with existing resources to better protect the public. So Mr. Hines assessed 3,599 complaints that were closed in a 6-month period from January 1 to January 30th, 2011. On average, it took 4.3 months to close the 3,599 complaints, and it took 12 months to close 416 of those cases. And so this, I think, was, for many of us, surprisingly efficient. So the Central Complaint Unit plus the field investigation average of 4.3 months compares favorably to the other DCA boards and bureaus that he has reviewed, but 12% of the cases took a year or more to process. Part of the audit scope was to include steps and procedures to ascertain the cause for the delay and provide recommendations to reduce delay. So one of the delays identified was the implementation of Senate Bill 1950 in 2003 that required a specialty reviewer process that essentially calls for any quality of care case to be reviewed by a medical expert before it can be referred to the field. In 2008-2009, only 348 of all quality cases were referred for field investigation. Of those, 14% took longer than 6 months for the medical specialist review. So we identified areas of risk or concern, which incidentally coincides with Ms. Katie's observation. Cases may not be assigned in a timely fashion to medical specialists. Medical specialists may have the cases too long, and CCU tracking are missing prioritizing information. So we made several recommendations. He said that the Central Complaint Unit may want to revise medical specialist contracts or follow up more frequently to try to reduce the medical specialist delay. He also thought that the CCU could print an overdue report to monitor all cases that are awaiting medical specialist assignment, and that the report lists all urgent, non-urgent cases in date order, and that the report be modified to show the urgency level of outstanding cases so that the non-urgent cases aren't assigned ahead of the more urgent cases. Additionally, the CCU may want to revise medical specialist contract or follow more frequently to try to reduce the medical specialist delay. So the next item related to the administrative law judge training program that the medical board assisted in putting on for the office administrative hearing and those judges that hear the medical board cases. This also went extremely well, and in the initial session, the topics included things like pain management, appropriate medication standards, chronic pain issues, and new developments in medicine and other subjects. And it was held up and down the state via teleconference. We see a lot of additional opportunities, and this was extremely well received by the judges, and I think that certainly Linda Whitney and her staff did a terrific job in coordinating things, especially Ms. Threadgill, who worked closely with Judge Liu to set up the program. On June 29th, another agenda item, I met with the medical board and the health quality enforcement staff, and we discussed the reconciliation of data and statistics. I think that was a productive meeting. We're still not completely agreed on all the details, but I think the spirit is that we understand the problem, we're going to try to fix it and be much more efficient. Ms. Kirschmeyer gave us some background on enforcement annual report format and where it has come from and where it is now, and she explained that the enforcement section of the annual report is mainly driven by the information required to be reported pursuant to Business and Profession Code 2313. This year, the board will make a change to the annual report in that it will add a column to the enforcement processing timeframes and add a section where the days have been converted to years in order for the public to have another way of examining the information.
Good idea.
Okay. Ms. Kirschmeyer told us that the enforcement program report always begins with a narrative of what has happened in the last year and outlines any improvements or accomplishments that are noteworthy. She then walked us through the entire report and solicited edits and changes that we would like to see made in the next report. Next, Ms. Katie gave us an update on the implementation of Senate Bill 100 regarding outpatient surgery settings. Ms. Katie provided us with a flow chart which explained how the board will respond to the complaints received regarding an outpatient surgery, complaints from an outpatient surgery setting. The complaints will initially be reviewed by the licensing program to determine whether the setting is accredited or not. If it is accredited, the complaint will be referred to the accrediting agency for inspection. Once the inspection report is received in licensing, the findings will be reviewed to determine if any deficiencies were identified in the categories that relate to patient safety. Patient safety deficiencies will then be referred to the complaint unit to be initiated and referred for formal investigation. Let's see. We then heard from Renee Threadgill and Carlos Ramirez in the process overview of the vertical enforcement program. This was a very detailed report
from both sides, and there was a considerable amount of explanation about the entire process. I think it's clear from the discussion that was that the vertical enforcement program, which began in 2006, is definitely improving things. Not everything is ideal, but we're continuing to make progress, and I think there's no question that it's a worthwhile endeavor. That concludes my report.
Dr. Lowe, thank you very much. Are there any questions for any of the board members, other than our total appreciation for some of you that were not on the board during our licensing fiasco? It was a very hard time. It was really a very difficult time, but we took the bull by the horns and we made some major cultural differences in the way things were handled in the work process and the work product, period. Dr. Lowe has spent inordinate amount of time and energy with staff to start to do the same thing with our enforcement program, and I can't thank him enough. The difference is that it's very detailed. It's not like it's something that just because someone has filed a complaint that it's going to, take 1 day or 20 days or 100 days. We don't know what's going to happen. And Dr. Lowe, I want to personally thank you publicly again for your engagement and involvement in this.
Well, I do very little, but I think that the people that we have working at the medical board do a phenomenal job, and I mean, everything is very complex, and if you look at the very big picture, we do an amazingly strong job protecting the public.
We do. I think that the issue is that we just don't get the good news out. We always hear about sometimes some not so good news, but the good news is that we are doing a very good job, and staff is to be commended for the dedication and time that they're putting into doing all this extra coordination. So I thank you. I do have public comment on this. Ann Robinson, I'm going to ask you to keep it brief and to remember not to talk to us on something you've already talked to us about, please.
Thank you, Madam President and members of the board. I'm Ann Robinson from Chico. I filed a complaint in 2006 about my mother's death in hospital. No one at the Medical Board of California ever really read the letters submitted, nor the medical reports that I got from the hospital. The doctor canceled my mother's medications cold turkey when she was admitted to the hospital because he didn't really know what he was prescribing for my mother. After she passed away, I sent him a letter asking why he had canceled her medicines so that I could understand, and he sent a letter back stating that I was mistaken about what medicines my mother was taking. Now, I had been taking care of my mother, who was wheelchair bound from a stroke, for 18 years. I knew what medicines she took, when she took them, how often, and what strengths. But he couldn't even be bothered to look in his own records. He sent me a letter saying that she was never on those medicines, and yet I got a letter from the legal department of the pharmacy stating, yes, she was on those medicines, and because it was expensive, the insurance company required the pharmacy to call the doctor's office every single month to renew the prescription. So all he had to do, and he did renew those prescriptions every month for more than a year. I called often to check on if anybody had even looked at those two letters, the letter from the doctor and the letter from the legal department of the pharmacy, they would have seen there was something wrong with that picture. I often called to check on the status. I finally got a letter which stated that my mother had died of advanced Parkinson's. This is proof that the medical expert never even looked at my mother's medical records, because my mother never had Parkinson's, was never diagnosed with Parkinson's, and it is never mentioned anywhere in any of her medical records. So where he came up with Parkinson's, he couldn't have looked at at her papers very carefully. In fact, if he'd even looked at the death certificate, which was right on the top, he would have seen she died of respiratory arrest from an overdose of morphine. That part wasn't on the death certificate, but she was given morphine every hour on the hour because she was in pain because the doctor had taken away her regular medications. Is this the kind of an investigation that the board is proud of? I don't think so. When I tried to appeal in 2010, I hand-delivered the complaint to the Medical Board of California. complaint unit. Then I followed up every 2 weeks, but was just jerked around and was told to leave a message. Several weeks went by and no one ever called me back, so I called to speak with a supervisor and had to leave a message. I left the supervisor multiple voice messages. Several weeks later, when I finally got hold of a supervisor, she told me that my complaint was being looked at and she would get back to me. Several weeks passed again. I was told each and every time that my complaint was being looked at and I needed to call back in a couple of weeks. This went on for 6 months, and then I was finally told by the supervisor the statute of limitations had run out and the file was closed. Although I had, I believe, nearly 2 years left on the statute of limitations. I was very angry. I was shocked that the agency responsible for keeping patients safe couldn't be bothered to even read the papers that had been submitted. They didn't even have the decency to send me a letter to tell me they couldn't find any extreme departure in my mother's case and the file was closed. Something is wrong with the system and it needs to be corrected. Thank you for your time and consideration.
I'm going to suggest that you make the time to speak with our Chief of Enforcement, who's sitting over here, Ms. Threadgill, before you leave today, and maybe you guys can figure out how to work this out. I'm very sorry.
Thank you.
That wasn't what I was expecting to hear from you. So we're going to move to item number 23, which is consideration of a petition to amend section 1379.50 of the board's polysomnographic regulations. Mr. Hepler, Mr. Salgado, would you please give us a discussion? So this is going to be a petition to amend regulations, so I want everyone to be listening with that. And that's where we're going with this.
Thank you, Madam President, members. This board just a few items ago considered some regulatory proposals set for hearing. That was directed by statute. Sometimes the board thinks of its own regulations, but there's a provision of the government code that allows an interested party to petition for an amendment to the regulations, and that is the case here. The American Health and Safety Institute has petitioned for the board to revise its regulations to allow a basic life certificate issued by them to satisfy the requirements and regulations for our polysomnographic trainees, technologists, and technicians. At this point in time, what this really means is we're not going to amend the regulations today. What we would essentially do is commence the rulemaking process. If the board so chose to grant this petition, what we would do would be to set this matter for regulatory hearing. And the crux of the change can be found on pages 211 and 212 of your packet. Right now, the basic life support certificate must be issued by the American Heart Association. And what the AHSI would like to do is make sure that BLS certificate issued by them would satisfy our registration requirements. Mr. Salgado, sitting next to me, has reviewed the sort of criterion that the American Heart Association uses to issue said certificate, compare that to the AHSI's criteria, and has found that there is no appreciable difference, if I'm correct, and there would be no appreciable loss in consumer protection. So it would be staff's recommendation to grant this petition, which means that the board would commence the rulemaking procedure and set this matter for regulatory hearing at the October meeting.
So I need a motion to do that, please. Dr. Vanda? Second. Dr. Levine? Okay. Any public comment? Any comment from any of the members of the board? All those in favor, please say aye. Aye. Any opposed? Okay, so that motion carries. Thank you very much.
Lunch break? Next it says lunch break, so.
The levity is very appreciative about now. Thank you. That is excellent. Thank you. We're going to move on to the enforcement, number 30, the enforcement chief's report, please. But she probably wasn't expecting to speak now, so I'm going to ask I don't see him in the room either. I see her, but I don't see him. I see him and I see her. So I'm going to ask that I will speak slowly and ask that Ms. Threadgill, Chief of Enforcement, and Mr. Ramirez from the Attorney General's office come forward, please, slowly, walking, and report to us on item number 30 on our agenda, which is on page 2.1 in our folder, please.
Thank you. Sorry about that. Good afternoon. First, may I have a motion to approve 8 orders restoring licenses to clear status following completion of probation, and 3 orders for license surrender during probation or administrative action.
Do I have a motion?
Second.
Yes, any public comment? Any comment from the board members? All those in favor, please say aye.
Aye.
Any opposed? You have your motion.
Turning to the expert utilization report, which can be found on page 321 of your packet, or it's agenda item 30B. The district offices used 205 experts during the first 6 months of calendar year 2012 to review 293 cases. The total active list of experts as of July 2nd, 2012 has dropped to 944. 267 experts did not return their signed contract during the process of converting to the new contract system. Additionally, 20 experts withdrew from the program because of the low reimbursement rate and retirements and other considerations. Some just found that they were not suited to do this work. They were no longer interested in doing it. Although this appears to be a significant drop, I do not believe that there is cause for alarm. We're still able to do business, and we will still continue to recruit. I am pleased to report that as a result of our appeal regarding the loss of 28 vehicles, we were successful in retaining 24 of our cars. I am also very excited to report that we have identified candidates to fill all of our current vacant investigator positions. Therefore, our vacancy rate, less the individuals in background, results in a 0% investigator vacancy rate. And I am aware that this situation is not likely to continue. However, I'm enjoying this fleeting moment. We still have 4 supervising investigator 1 vacancies. However, there are 2 individuals in background for 2 of those positions. The retired annuitants managed by OST have been essential in order for us to accomplish 41 peace officer backgrounds during the past 12 months. As I previously reported, there were a number of candidates that withdrew from the process after the backgrounds were finished, and that caused us to have to complete more backgrounds than we had positions. But we've managed to do it. A lot of hard work by our staff, but they got it done. Backgrounds are required by Peace Officer Standards and Training, which is known as POST. The Commission on Peace Officer Standards and Training provides us with the areas that we must investigate in a potential hire. And I'd like to share with you what that process looks like just in a very rapid fashion. An applicant completes a 27-page personal history statement and then is interviewed by the background investigator. Their fingerprints and firearm eligibility checks, a DMV driving record check, local law enforcement agency checks, and this can be quite a few because if the applicant has moved around, we're checking with local law enforcement in the areas in which the candidate has lived. There's credit checks. We obtain official transcripts. We have birth certificates, citizenship documentation, military, selective service, marriage dissolution, employer contacts, reference checks, neighborhood checks, neighborhood contacts, and of course, medical and psychological clearance. And this is all prepared in a narrative report, which is submitted and signed off by the background investigator and myself. Post audits our compliance with their requirements annually, and fortunately we've gotten good ratings on our ability to follow the rules and prepare background packages that meet their requirements. We are extremely fortunate to have the retired annuitants perform this critical function because it has allowed existing investigative staff to focus on reduction of case timelines. Okay, turning to page 325, which is related to our strategic plan objective 5.2, we are very close to reaching our goal of 50% of complaints in the complaint unit being under 50 days, but that's only part of it. We do realize that there are, as Susan described in her report yesterday, there are other efficiencies that we intend to seek in order to lower the number of days in that process. But we still only have 8% to go in order to reach the goal that was set in the strategic plan. The number of complaints received by CCU, the Central Complaint Unit, continues to increase. And as you can see on the chart on page 325, we have 209 additional complaints this year, as opposed to the number we had last year. With regard to reduction of the investigation timeline, we have reduced the case age average to 264 days. And I believe that Tim Einer passed a chart out earlier, and I wanted to share that with you to point out that back in 2008, July of 2008, I appeared before the board and I had some goals that were set at that time. And, he's passing them out, so I'll let him catch up. But those, one of the goals was that we would reach, the investigation timeline would reach 275 days. I, at that time, estimated that because we had the change in the complaint unit requiring specialty reviewer, that we were going to go up a few days, which we are, but we just didn't go up to where I thought we would, which is a good thing. So that goal was a little off, and we were well under that. But the goal of 275 days, we've not only met it, we've exceeded that. And I am very, very pleased. I think it's phenomenal that we were able to do this, considering the challenges such as vacancies and furloughs. We do, however, face future challenges with the implementation of our Personal Leave Program 2012. This will result in the loss of 736 hours each month, or looking at it another way, 8,832 hours in a year, in the next 12 months, from productivity from sworn personnel. So
for the people that don't do math in their heads so fast, how many thousand hours are there in a month? Or does this translate to anything that I could understand?
Well, if they're 40 working hours in a week.
Correct.
So if you have 4 weeks in a month, roughly.
Roughly.
So
8,000 hours?
That's in a year. The 12 months that will be required.
So 8,000 in a year divided by... it's a bigger number than we expected. It's sometimes
Well, when I look at this just the sworn personnel, for the month, it's a loss of 736 hours. And that's if all our positions are filled, which most of them are right now.
They are, I'm sorry, okay.
But that will make it difficult to maintain the progress we have made in the reduction of the time frames. But hopefully this will be mitigated with the augmentation of staff. We also had, with the filling of all these positions that have been vacant, and we're hopeful that we'll be able to at least stay abreast and not lose any ground. Pages 326 through 329 in the packet, you'll find the enforcement program statistics. There is they're presented in a variety of formats, and I would like to bring to your attention again the document reflecting the goals. I just as you can see, we surpassed those goals, and we're going to be in the process of setting new goals for hopefully that we'll be able to surpass. But I'd like to point out that on page 327, this is just the one, looks like that. This is a chart that has added the years, the percentage of years along with the average days. So when you look at the process together, when you're looking at the median, it looks like we are on line with what I hope to get, where I hope to get us in 2008, where I said we would go. In fact, the median for the total days with the time at the AG and the time in investigation is 640 days, only 1.75 years for that process. However, the story really is in the outliers. And I'll tell you a little bit about that later. The total average time from complaint processing through the total time at AG, if the average is 741 days, or 2.03 years, compared to 908 average days, or 2.49 years in fiscal year 08-09. So we've completed a lot of work. And this is another example of the outstanding work produced by both Medical Board and HQE staff this past fiscal year. Of course, I need to talk about the outliers. When you look at the median numbers, they seem entirely reasonable. It's the outliers that make the average numbers look less impressive. In that vein, we reviewed cases that were over 700 days old, and the vast majority of them have the same theme. They involve allegations of overprescribing and inappropriate prescribing. They involve other law enforcement entities such as DEA, FBI, IRS, or local police departments, and we are often asked to stand by and allow these agencies to also complete their investigation. And we had done this. However, some of the federal agencies are notoriously slow in moving an investigation forward. About a year ago, we realized that these agencies were not mindful of our statute of limitations and were impeding our ability to complete the investigations timely. Consequently, we have taken a zero-tolerance position in delaying the investigations at the result of their verbal request, and if they are willing to put something in writing acknowledging that it is their request that is preventing us from moving forward, then we will consider that written request. Many of the agencies don't want to put that in writing. So we've been moving forward on those cases. Prescribing cases are also compounded by the need for multiple undercover operations and the planning and staffing that each operation involves. Prescribing cases typically involve numerous patients, which translates to having to procure and review voluminous medical records. Typically, we try to limit the cases to 5 patients, but when there are numerous patient deaths, this may go higher. And then we also need to obtain death certificates and autopsy reports. Often we need to obtain authorizations from individual patients to get their records, or the investigator might have to write a subpoena or a search warrant for the medical records. Then the investigator must visit numerous pharmacies to obtain the original prescriptions, get the physician to attend an interview, and send the case to 2 experts as required by our pain management guidelines. Generally, the patients are not cooperative since they want these prescriptions. Other common themes in outlier cases involve inability to obtain records, inability to obtain timely interviews, and inability to prevent case aging when dealing with cunning defense attorneys. Our oldest case is an example of these challenges. Within 2 weeks of assignment, the investigator served a subpoena on a hospital. 3.5 months later, records are received pursuant to the subpoena, and those records are incomplete. Thus, subpoena enforcement action was undertaken. The investigator also served a subpoena to appear on medical staff individuals. 20 days after assignment, calling for appearance of individuals 20 days later. 4 days before the interview is supposed to take place, defense counsel calls and advises he was unable to make the interview and asked to have the date changed. Investigator agrees to a date 17 days later. Defense counsel subsequently writes a letter that says the subpoena is invalid and he will not be complying. 5 months elapse with the Office of the Attorney General attempting to negotiate an interview with defense counsel, who is not being cooperative. Almost 6 months after assignment, the case is formally transmitted for subpoena enforcement to the Office of the Attorney General. 9 months after assignment, investigator serves a new physician with a subpoena and is able to interview him. 8 months after assignment, a petition to compel compliance with investigational subpoenas was filed by the Office of the Attorney General for attendance of 2 witnesses. About 1 month later, the Superior Court granted the petition to compel, which the defense quickly appealed. 2 years, 1 month after assignment, oral arguments were heard in the Court of Appeals. 3 weeks later, the Court of Appeals affirmed the Superior Court's decision. 1 month later, the defense filed a petition for review in the Supreme Court. 2 years, 6 months after assignment, a remitter was filed by the Superior Court of San Diego, and a judgment was entered against the witnesses. 4 days later, the witnesses are served with a letter commanding their appearance 1 month later. Defense counsel advises he's on call for federal grand jury and not able to attend for an additional week. 2 years, 7 months after assignment, the interviews are finally completed. This is a story of just one of our outliers, and it has many of the problems that we face, all in that one case. Unfortunately, that outlier happens to be the oldest case in the state. Additionally, there are sections of law that were designed to help us. BMP Code Section 2234H was one of these laws. However, it has done nothing to improve problems associated with interview delays on the part of subject physicians. In accordance with our strategic plan 2.3, we've identified this section of law as one that will require substantial modification in order to be of value in eliminating our subject interviews. And we're going to, in compliance with that section of the strategic plan, be going through and making recommendations to the board regarding legislation and amendments to possible proposed amendments to legislation and laws that we currently have in order to become more efficient. In conclusion, I wish to convey appreciation and thanks to enforcement staff for all of their hard work and dedication to our mission of public protection. I think I have a couple of investigators. Could you stand up?
Could you continue to stand?
Yes. Oh, could you continue standing? And also, could I ask all of enforcement staff to stand up that's here? Should be. We don't often see them in board meetings, so I'd like to thank them as well for the fine job they've done this year. Thank you. That concludes my report.
Do you have any questions for Mr. Egel? Dr. Ganadev?
You said about the medical expert. I'm quite concerned about the number of people who haven't signed up. What are we doing to attract more medical experts, especially from a variety of areas rather than just from the academic institutions, rural areas, different specialties? Are we doing something to
Right. As I said, this is nothing to be alarmed about. When we switched, we knew we were to the contract
format.
When we had to change over to the new system for contracting with experts, we knew that we were going to lose a few. So this is not alarming at all. 944 is a substantial number. In fact, we're down, 200 plus. But one of the things we're doing is we're continuing to advertise. In the past, I've asked California Society of Addiction Medicine to run an ad. I will continue to contact those specialty organizations, especially in the areas where we are underserved with experts. We have need for more pain management experts and more psychiatrists that are good. And
they're all good. Now, my concern is also the type of practice and the location of practice too, not just what I see is when I read through my disciplinary action, most of them are at a place like mine or at UC Davis or some large place. But I would like to see somewhere Barstow or some inner cities. I mean, these local standards are a little different, so I'm just curious.
Well, they shouldn't be different, and that's why we're here. The standard of practice...
Maybe he means that they're more available because they have less work to do.
Oh, well, they still have to meet the minimum qualifications.
I was trying to be helpful.
Okay, I hope I am not.
I would suggest also that it's part of the strategic plan from the public information officer to also get back to us, and we've asked for direct input as to what he is doing specifically to do outreach, to do better about getting us some
and we will continue to, if any hospital that we would love to present at medical societies. There was a time that we had the luxury of doing that more. We have certain restrictions now on travel, and so it's made it a little bit more difficult, but we continue to reach out. I would like to add to the expert reviewer program so that I can make an analyst responsible for contacting hospitals, clinics, soliciting individuals in various specialties for participation in our program.
So maybe you can work with Mr. Wood and let us know at the next meeting of the Education Committee where it's been requested what those outreach opportunities are, and then Dr. Ganadev, you can come to the Education Committee and you'll find out what's going on. No, Dr. Ganadev will come to the Education Committee where Mr. Wood and Mr. Egel will present to us. Whoever I said, you got the point.
I can get clarification later.
Ms. Threadgill, I want to thank you very much. The work and the stress and the lack of support, 100% support from a team is hard to get the job done, and I can very well appreciate that. The issue that I have is that the outliers are not the usual, so that those that are taking years, 5 years, 10 years, whatever the number is, it's very frustrating and it's got to be very difficult, but we do realize that the bulk of the work that's being done by the enforcement team is really over and above the call of expectations, so we want to thank you for bringing this to our attention, even though it's getting toward the end of the day. Not that it's not your fault, it's the hours going forward whether you want to or not, which is good. That's what's supposed to happen. The clock continues to move forward.
Okay. I would like to thank Dr. Levine also for her suggestion that we examine the outliers. We will continue to do that. There's a wealth of information that we've learned and opportunity to implement some changes and efficiencies as a result of looking at those.
Great. So now we're going to continue.
Good afternoon,
Welcome, Mr.
Carlos Ramirez.
Good afternoon.
We are continuing to provide statistical reports to the medical board staff at this point. We provide a total of 6 reports. 3 of those are monthly, 3 of those are quarterly, and 3 of those are customized for the special needs of the medical board. We plan to meet with the data section in our office in the future to make sure that the reports that we are providing suit the needs of the medical board staff. With regards to the staffing, we've had a vacancy in Los Angeles. We've moved that vacancy to Fresno to begin staffing that office. That's an office that has long been either serviced out of Sacramento or LA. And obviously that has entailed significant amount of travel, but we are moving to have someone there permanently, someone that lives in Fresno and can service that office. The objective is to have a second position assigned to that office in the future.
That's your report?
Yes.
Thank you very much. Any questions, Mr. Ramirez? Thank you very much. Thank you very, very much. We're going to move on the agenda to item number 19. Ms. Chang, would you give us an update on the Federation of State Medical Boards, please?
You still want to hear?
Well, we don't want to, lengthy report. We're looking for a report.
Okay. Just a couple of things. The foundation has selected additional board members due to the fact that it was the board policy of the foundation board that they do not want more than one person from the same state to be serving on the board. 2 of our board members actually have shown interest, but it wouldn't happen. So what I'm hoping is in the future that this California board person will be off that position, currently treasurer for that. In the future, that will be empty. I'm hoping the same people would apply. And also at the same time, the same token, 2 years from now, I be off the board. And I will still be from California, but I'm hoping one of the board members here will be interested to run for the board position of the Federation. And I know a lot of you are very involved in it already, but please keep an eye on the future assignment to the Federation. That one of them will be in a position to run for a board position, either a public member or a physician member. There are 2 types. Other than that, some interesting development is the national board and the American College of Medical Schools and Federation and the ECFMG. The 4 organizations is getting together to do a joint venture. They call it ePortfolio, which is a online portfolio that started from medical school and with all the records and all the for a medical students all the way up to a physician and licensed physician. It will be it's a initial concept that is being built on, so it will be interesting in the next year or so to see how they evolved. But this 4 organizations already put money in. On top of that, there are numerous other organizations are interested in involved. It will be like a empty cloud. They call it empty cloud. Is when you can go to the empty cloud, trigger something, triggered a mechanism, and then they will collect information from all 4 different organizations, got every piece. When it's complete, got every piece of the information about that physician. It's very different thinking at this moment. And Federation still working on the license. It's the MOL is there are all kinds of pilot program is being implemented. There's 11 boards are implementing the pilot program, and telemedicine and uniform application of license is one subject, and it will happen next week at Salt Lake City. They have a big conference for that. And other than that, I will come back and make reports to you, especially if you're doing it in Bay Area. And I will take you guys out to dinner, and we'll see you again.
Thank you, and thank you for your service on the Federation Board. I want to acknowledge also Dr. Salmonson, who's left, but spent 2 days in Carlsbad, California, just recently for FSMB meeting on step 2 or step 3 of the USMLE, and I want to thank her as well. So we're going to move on the agenda to, let's start with the board member communications with interested parties. And I know Dr. Ganadev has reminded me so many times. I have not forgotten.
I want to make sure that I do disclose that I, as a member of AMA, that is American Medical Association delegation, I was in a June meeting in Chicago and met with FSMB board executive director and the chair of the board, along with the leadership of AMA and CMA. I do meet these leaders quite often, but we do not discuss anything about the medical board issues. I want to make sure that I'll let people know that. And last month, the AAPI, that is the American Association of Physicians from Indian Origin, had an annual meeting. It's a 60,000 member association in Long Beach. And they gave me the most distinguished physician award. So I was there.
Congratulations.
Thank you. But the disclosure here is that CMA leadership came to the meeting and sat with me. So I just want to make sure that people are aware of. I keep that separate, my activity of the medical associations versus what I do at medical board.
Now, I hope you don't expect to hear about every meeting that I happen to see a public official at. You're setting a very high bar there. But as I've mentioned before, as far as my meetings go, is that everybody I meet with is interesting, so therefore I'm having interested parties meetings. But anyway, I have met with, I did meet officially with Senate and Business Professions leader Kern Price, along with our staff and along with Dr. Lowe. I've met with various elected officials, but I do that normally. So I apologize, but it's a joke, but it's not. It's serious. But I have not had any interested parties, meetings with anything that needs to be disclosed, as it might present any kind of a conflict, seriously. So do I have any other meeting statements that anyone else would like to make? Good. So we'll move on that. So as far as the, I'm going to give you a brief education update and just let you know that we did have an education meeting yesterday, and Mr. Wood is staffing that meeting, and I want to thank him very much for his input and engagement. It is a work in progress, to be honest with you, and the work of the two combined meetings, one which has not met since 2010, the other since 2011, gave us pause for opportunity to have a very robust discussion. Forget animated, it was electronic basically. Electronic meaning a lot of dancing around. So it's supposed to be funny, guys. So I apologize, but it will be interesting. We are going to try and put the committees on off cycle, so that we have the time and energy and opportunity for robust discussion, with the opportunity of doing better at what we're doing within these subjects that do impact the medical board. So I know that I have a speaker slip on number 17. Tina, did you want to speak quickly on something?
Tina Manassian, I'm here on behalf of the Consumers Union Safe Patient Project, a nationwide campaign that's organizing patient safety advocates from across the state of California as the California Safe Patient Network. The medical board's website offers confusing information to patients who are trying to understand and comply with deadlines for filing complaints. This has resulted in the medical board refusing to review complaints that patients believe were filed timely. When we met with Ms. Whitney and Ms. Kirkmeyer in January, we supplied them with several examples of problematic, unclear, and misleading communications on the medical board's website related to the medical board's statute of limitations. We did not take it upon ourselves to do an exhaustive search of the medical board's website. Even so, we identified a number of examples and requested that the medical board correct this information. We are pleased that the medical board recently made changes to one document, the How Complaints Are Handled brochure. However, we believe the medical board should develop a thorough plan and make addressing this important issue throughout its website a communications priority. We also request that when the medical board learns of an alleged improper act or omission by a physician from a source other than the patient, such that the 3-year statute of limitations begins to run, that the patient be notified immediately in writing that their SOL has begun to run. In addition, we request that when a patient makes a complaint to the medical board, that the medical board explain the statutes of limitations and inform the patient how much time they have before the statutes of limitations will run out in their case. Further, the medical board should advise patients as their complaint is making its way through the process as to whether it is in danger of going over the statute of limitations time frame. When the statutes of limitations in a case runs out, it can have the impact of allowing violating physicians to continue to practice without discipline. We are aware that the medical board may find an extreme departure and yet close the case because the statutes of limitations has run. We believe the medical board should put in place processes to guard against this happening and to be sure that consumers are as well informed as possible. We hope that the medical board will direct its staff to respond to these matters and report back to the board. Thank you for your time and consideration.
Thank you very much. I'm going to move to the Executive Director's Report, item number 26, and ask that as part of that we also discuss the dates for the board meetings. Let's start with that. Let's start with 26 F.
If you could all turn to your packet, item 26F, and trying to get the page number. We have proposed dates for the board meetings in 2013. That's on 299. Those are dates as well as locations. I've asked that you all bring your calendars to let us know if those dates and locations, 2 of the dates, the spring as well as the fall, have 2 different Thursday, Friday dates on them, and so we need direction from you, or if the other 2, the winter and summer dates, don't work. We've also proposed the normal location area sites, but if you would like to be more specific to give us direction, that would be helpful too.
As part of this discussion, I'm also going to recommend that the dates be held open for 60 days so that you can go back to your offices, you can go back to your staffs, and make sure that in the scheme of things, these dates for real are going to work. So that's the recommendation. I know, Dr. Ganadev, you had your hand up first, so please.
Madam Chair, I would like this board to consider using Ontario area for a one board meeting.
Is that like near Palm Springs? Is that what
It's like on the way.
It is near Palm Springs, yes.
It's on the way to Las Vegas too.
As part of the Los Angeles area, because
Right.
it
Or
is
it's part of San
within-
Diego too, as far as I'm concerned. Yes, Dr. You want San Diego, okay.
I was going to say, I'd just rather not be here for Halloween. I'd rather be trick-or-treating.
Yeah, I would agree that for families and for the safety, the public safety issues, it would be important for us to be in our communities. So, Levine, Dr. Levine? Mike.
May 4th is a Saturday. I think the dates are actually the 2nd and 3rd of May.
You don't want to be here on a Saturday?
That's fine with me. No, but
I actually only have a calendar, to be honest, that goes through December of 2012, so I would go along with you.
She's correct, it's 2nd.
So I'm just looking to clarify, Dr.
yeah,
Levine.
it's just 2nd and 3rd of May is, and I would second Dr. Diego's recommendation that we not do this over Halloween.
I agree.
That's October.
As far as, so the October one, you're talking about the 24th or 25th. For the April, do you have a spring request for spring?
I don't know. I don't know which one's Easter. I don't think any of them are, right? So it doesn't really
I have no
matter.
idea. I don't have a calendar with holidays of any ethnicity.
The May or the April sound fine to me.
Okay, so I'm going to ask that everyone take these back and then it gets back to our, pardon me?
Does staff have a calendar that we could resolve?
They have a calendar here, but it doesn't have any holidays marked on it.
31st of March.
And when is Passover since we're doing Easter?
Do you know which day is the FSMB? It's the week before the 26th. I'm not coming 18th, 19th, and 20th. I'm not going to be here. I'm just going.
So I'm going to tell you that it's for Dr. Levine, let me tell you seriously.
May 2nd.
Having 1 week in between the FSMB meeting and this board meeting is very difficult on your time. So it's my recommendation that you look at the calendar seriously and make an additional alternate recommendation to the staff. Or the 6th and the 7th. I mean, I'm just telling you, if the meeting here is... So when is the FSMB?
The FSMB is the week before the 25th and 26th.
So it's like the 20th?
It starts on the 8th.
Of April?
Yeah, so 18th through 20th of April.
Oh, so then it would make sense to do it in the May?
So it makes more sense to do the May meeting.
And it's not Mother's Day, so we're okay.
Right.
We can make it Mother's Day. Maybe it's Mother's Day somewhere.
It will be in Boston.
Mother's Day?
Okay, so that's good. I'm just telling you that I'm telling you that physically there is a drain on your energy. It's very intense, that meeting, and you need to be up for both meetings.
Yeah, I only have to do one.
Okay, so as of now, we've got the 31st and the 1st of February in the San Francisco Bay Area. We've got May 3rd and 4th somewhere in the Los Angeles, Ontario area. Second and third, sorry. And the mid-July meeting in Sacramento area, and San Diego the 24th, 25th, or the following week in November. Is there? These dates also need to coincide with 100 days for the cases. So understand that these dates are not just random situations, but then there's also the alternative of an interim meeting by the panels. So that is an option.
Before we agree to Ontario, can we check to look at flight availability in and out?
Do we have airplanes that go to Ontario? It's kind of like going to Los Angeles, it feels like now.
And there are Southwest flights there. So it's not.
Why don't we check with airfare costs as well compared to...
Okay, so let's have staff do that and get to us, okay?
Not any different than Sacramento coming to.
Okay, continue with your report, please. This is off the table. This is off the table.
Then starting from the bottom and going up, we'll discuss the status of the Sunset Review. I think that's very important for the board members to be informed about. First of all, a little historic reference for you. Sunset Review is an opportunity for the board, the legislature, the public, and the administration to re-examine the laws and mission of the board to determine what changes or enhancements need to be made or to eliminate the board. Our last Sunset Review was in 2004. The process is receipt of a questionnaire from the Senate and Business and Professions Committee. The responses are due November 1st. Responses are reviewed by the legislative staff, and we may be asked additional questions or clarifying questions for issues that have come up. An informal or informational hearing may be held prior to the legislature going into their session, and that might be in early 2003. But the formal legislative hearing is basically through the policy committee and is done usually in spring, so that would be spring 2013. The bill then moves through the legislative process, and hopefully by the fall of 2013 it would be signed with the extension and enhancements for the board for operations for another 4 to 6 years. We have actually received our questionnaire. We have begun the process of responding and collecting data to respond to the questions. Letitia Robinson, our research program specialist, is working on this with assistance from Janie Cordray, our research analyst previously, who is now a retired annuitant. She has extensive knowledge as she worked on the Sunset Reviews in the past, and we hope her assistance will be available. We have identified her as mission critical in the development of this report because she is a retired annuitant. We are working with the Attorney General to gather data on vertical enforcement prosecution, as that has been promised to the legislature pursuant to our evaluation report that was submitted in March. We are now at a point where we will need a couple of subcommittees of board members appointed to assist with the development of the review in various sections of the final report, so it can be presented to the board in final draft at our October meeting. I will be seeking your interest through the president, the new president, and she then can appoint subcommittees of 2 members to help staff work on different sections of this report. We will be examining the outliers, as you've heard from Ms. Threadgill, to determine what laws may need to be added to the codes to expedite or that process or different pieces of that process, but we will look at it so we do not eliminate due process. And that's my update on the Sunset Report. Moving on, update on the audit report. Ms. Kirkmeyer, could you please give us a quick update on that? It's all in your packet. You'll see that starting on page 284.
Yes, 283 to 298. As stated at the last meeting, the legislation which changed the board's reserve mandate from 2 months to 2 to 4 months also included a requirement from the Department of Finance, Office of State Audits and Evaluation, that they would perform a preliminary review of the board's financial status, including but not limited to its projections related to expenses, revenues, and reserves, and the impact of the loan from the contingent fund to the Medical Board of California, from the contingent fund of the Medical Board of California to the general fund, made pursuant to the Budget Act of 2008. This audit was completed and submitted to the board in its final form on May 31st, 2012. As Ms. Whitney said, it's contained in pages 283 to 298. Please be aware that when the final draft was received, Ms. Whitney and I met with Ms. Yaroslavsky to go over the report. We then drafted our response to the audit report, which you will actually find on page 295. The specific results of the audit, if you want to look at those, are on page 289 to 292. But basically, the outcome of the audit was that although the loans to the general fund have not impacted the board's ability to operate at this time, should the board have the anticipated increase in expenditures and the loans not be repaid, the months in reserve will then drop below the mandated level of the 2 to 4 months. Upon review, we found that the report accurately captured the information provided and met the mandate of the legislature. Are there any questions on the audit?
Any questions? No. Thank you very much.
Then we're going to hold over the budget report and the update on Breeze for a future meeting. You do have all of your budget materials in your packet. If you have any questions regarding any of those materials, the fund condition, please don't hesitate to contact Ms. Kirkmeyer or myself. I'd like to give a brief update on staffing and administration. Ms. Kirkmeyer also has a brief update on some staffing. First of all, I would like to extend a very, very heartfelt thanks to my program chiefs, Ms. Threadgill, Mr. Warden, and Ms. Smoes, plus the deputy, Ms. Kirkmeyer, for the outstanding work they have done in putting these board meetings together and developing their staff, demonstrating excellent leadership skills. Without them, this board really would not function. We often recognize individuals' staff efforts, and I would like to publicly recognize the chiefs. Last month, we were able to promote Mr. Einer. He will continue as the administrative assistant to the board, but take on additional duties related to the executive office. Ms. Kirkmeyer, would you please continue with an update on some of the staffing and issues that we are facing?
Okay, I'm going to go quickly through them, but I just want to give a little bit of a comparison between last meeting and this meeting. At the last meeting, we actually reported that we had 42 vacancies and our vacancy rate was 15%. We also reported that we were going to have 18.1 positions swept from the board due to the budget letter from the Department of Finance. Since this is the beginning of the fiscal year, I'm going to just give a brief overview of what our staffing levels are right now. On June 30th, we actually had 283.2 positions. On July 1st, due to the budget letter, we lost the 18.1, taking us to 265.1 positions. However, with the passing of the budget on July 1st, we also gained 6 Operation Safe Medicine positions, which brings us now to a total for fiscal year 12-13 of 271.1 positions. Of those positions, we currently have 27 of them that are vacant, which is a 10% vacancy rate. However, we have 19 individuals either in background or waiting eligibility or a start date. That brings our vacancy rate to 3%. This is the best we've been probably since I've been with the board, maybe not since Ms. Whitney's been with the board, but for a significant amount of time. And the kudos really do go to the managers and to the personnel staff that really have moved those hirings forward. 11 actually of the 15, there's 15 actually pending backgrounds, and 11 of those are actually not pending with the department or with the medical board, but they're actually pending with the state personnel board, so those are out of our hands. So as soon as those go through, then those 11 individuals will be available to hire as well. In June, we were notified that due to bargaining unit agreements, each employee with the medical board will be given 1 personal leave day. Ms. Threadgill alluded to that earlier. This is actually a leave day that they have to take without pay. This decrease for employees equates to a 4.62 pay cut. And this agreement is going to be effective from July 1st through June 30th of 2013. It's similar to the furlough program that we had previously, but the offices aren't going to be closed. It's the employee gets to choose which day of the month they're going to take. In addition, there were also side letter agreements with these states bargaining units that stated effective September 1st, all students and assistants and non-essential mission critical retired annuitants will have to be released from the board. The board actually identified 19 retired annuitants that do not fit the criteria of mission critical, and those employees were actually, they no longer were working after July 1st. We wrote justifications for the rest of remaining retired annuitants, and we're awaiting State and Consumer Services Agency decision on those retired annuitants. It will be a huge impact if we lose the student assistants and also any of our retired annuitants. I would just like to give you a brief cost comparison for student assistants. Right now we have student assistants that help out in our licensing and information systems branch unit. In looking at a cost comparison of employing those individuals versus having to hire full-time permanent staff, the cost difference is about $90,000 per year. In addition, those students actually only work about 20 to 25 hours per week, and they're very flexible. They assist with extra projects and fill in when individuals are on vacation or extended sick leave. There's a possibility that we may be able to hire these students as permanent intermittent employees, but again, that will be a cost increase. And the last item I just want to touch on is for retired annuitants at the board. These are individuals who have retired from state service and have a wealth of information. In most circumstances, when these individuals are hired, they do not need extensive training. In most cases, they don't need any training at all. And again, these are very flexible. When they're done with a project, you can actually tell those individuals, we no longer have hours for you, but please kind of, if we need you, we'll call you back in the future. So that's another benefit of having the retired annuitants. Just in looking at the cost comparison, it varies depending on classification, but just for those working in our licensing unit, in 1 year we would actually save $30,000 as compared to having full-time permanent staff in those positions. So we wanted to just kind of give you a little bit of an idea of if we do have these individuals in student assistance, particularly come back as permanent intermittents, that would be an increase in cost. We'll let you know about our retired annuitants as soon as we hear the final decision from the secretary, agency secretary. That's it.
So I would hate to, at this point, have a disagreement with my assistant executive director. But in the base of fairness, I think that we all need to understand that the issue of employment in the state is in dire straits. And to be honest, the governor is in a very tough position. And this is not a push for the governor's positions, but more for us to understand that there are a lot of people out there that have no jobs and have no benefits and have no opportunity for the opportunity to work. And the idea of bringing students in does help us financially. It does cost us a whole lot less money, but it's not doing anything for our unemployment rate in the state of California. Our retired annuitants are very experienced. They know what they're doing. They cost us a whole lot less money, but they're able to still collect benefits. So in all due fairness, I just want the public as well as this board to understand that there are hard issues that we have to deal with, and our budget, given the ability for the state to sweep our money, is a consideration. I'm not suggesting that it isn't, but I just want that there's two sides of this coin. So that's all I'm suggesting, not a disagreement or not just a point of personal privilege. Okay? Ms. Shipsky, you don't agree with me.
Yeah, well, actually I was going to say something similar, but I'm surprised that the employee union that represents those employees hasn't filed on that, because when you replace permanent positions with students, that creates a problem, and that's
exactly why the governor's
collective bargaining agreement.
So what I'd like to explain is that neither the students nor the retired annuitants take any of our positions. Those are what are in a blanket temporary help position budget line item. They're not any of our permanent full-time positions. If we did need to go forward to get the work, we have to go through the budget change process. And as most of you will understand how hard it is to get through that process to hire those employees. But these individuals that are in student assistant positions and retired annuitants are not in any of our permanent full-time positions.
And again, I would just caution that taking the side of the the employee association is that, in fact, if this work constitutes something that should be done by permanent employees, that's the same ground by which students cannot replace workers. So I hope that that's not what we're doing.
Okay, thank you very much for your report. I'm going to take another point of personal privilege, and given that the hour is the hour, and it has nothing to do with the amount of time I'm willing to spend here. But to be honest with you, the flights out of Sacramento are very challenging. And if the legislature could do something beside what it's doing, they would do us a big favor by getting Southwest to figure out that they can fly more regularly in California instead of to Kansas or wherever else they're flying. And that's where they're doing. I mean, they are going to Kansas. So anyway, I'm going to tell you that as a result of that, number 18, number 20, number 21, number 22, 28, and 29 are in a saved position. We will take them up at a future board meeting, but we're not going to take up those issues today. So moving forward from that, we have an agenda in October in the San Diego area, and I'd like to ask for agenda items for that board meeting, as well as the opportunity within the next 60 days to let our staff know of issues that they would like to be placed on the agenda. Ms. Shipsky?
I mentioned before the safe medication disposal ordinance that Alameda County has just passed. That could be a real model throughout the state.
Take Back program?
Yes, the Take Back program. And then the other thing that I've run across in teaching healthcare administration is if we could get information, there actually, we're talking about access to care, there actually is a program or a concept that's being used. It's called Christian Healthcare Cost Sharing Plans, where instead of insurance, church members get together and they actually contribute, and it pays for the medical care. And would be interesting to see if that's being used to any extent in California.
Is this an affinity group kind of?
No, and they're not registered as an insurance plan, or it's just something that's being used as a way for access to care.
Yeah. Any other items for Dr. Ganadev?
Madam Chair, I would like to see if we could do any outreach program like on the licensing that, like Mr. Shumke does, and the enforcement to the medical staffs and medical staffs mainly, to really reach to the physicians, prevention of the mistakes they make rather than just pursue.
So proactive kind of, okay, so we'll ask the staff to put that on. Okay, and Dr. Lowe, do you have anything for your, Dr. Giussot? And Dr. Lowe, I'm going to point you to panel B chair. I thought you knew about that, but I apologize, I didn't do that before. So Dr. Lowe will be the panel B chair. So I would just like to say that I've had a very interesting 3 years chairing this board. I've learned a lot, I've forgotten a lot, and I'll continue hopefully to remember occasionally a lot. But the work that this board does and the staff, the dedication, the true dedication to doing the right thing by our staff is way above what I've seen in other similar kinds of boards, staffs. And I want to thank the staff, I want to thank the members of this board for allowing me the opportunity to be at the microphone for the last 3 years. I want to look forward to maybe having a little bit of some time. I don't know what I'm going to do with another 2 hours, but I'll figure it out. Dr. Levine, I want to wish you the best. It's a rewarding experience. I think it's an important experience, and I think that you will bring a breadth of personal experience to this board that we definitely need to move it forward. And I want to wish you all the best, as well as the rest of the people that will be on the board.
And I want to thank the board. I appreciate the opportunity to do this, and I will certainly do my best to follow in your footsteps.
Dr. Ganadev?
Madam Chair, we do want to thank you, actually, for a new member who just came on 6 months ago, and I wanted to see how it functions, so I wanted to meet with you before even I came to the orientation, and you were gracious enough to meet with me and spend a couple hours time and explain to me, so thank you.
It's my pleasure. You've been a pleasure.
I want to thank you also for your incredible dedication and passion. I mean, I don't think many of us would be able to do what you've done for us over the past few years, and I know I speak for the entire board.
Thank you, Dr. Lau.
Yeah, I just want to say, Barbara and Madam President, you've really put your heart and soul in this job, and you've done an excellent job for all of us representing the rest of us. Thank you so much.
My pleasure. It's been really my pleasure. So I'm not yes.
Can we finish up again? Something nice too. I sit here to keep your quorum so you have the meeting. But the more I sit here, the more I wanted to stay. But anyway, I knew Barbara probably 8 years. Yeah, you were here just as long as I was. And I truly enjoy your friendship and the hard work. And this actually goes quite a bit of all the people in this room. Shelton, Linda, Kim, Julie, Kevin, and a lot of you sitting over there, Kurt, and all the staff over there. And it is really goodbye, and congratulations to all the good work that you're doing and you're going to do.
Thank you. So since we're, yes, Ms. Shipsky.
Thank you, Ms. Yaroslavsky.
My pleasure, Ms. Shipsky.
I want to thank you, for your dedication and your hard work, and the passion that you've had to really make, this board an extremely responsive and responsible entity for the work that's, given to us, and it's most appreciated. Particularly appreciative that we're going to have a physician as the new president who understands the importance of going to the bathroom frequently for bladder control.
I thought we were just doing exercises here. Wellness?
Yeah, Barbara. Yeah. Anyway, but and I do, again, in all sincerity, Barbara got reappointed by the speaker, so she will be, because someone just asked. So you will be here for another 4 years, and that's great.
Another 3 years, I think. Was it 4 years?
Yeah. Whatever. Yeah, it's a 4-year appointment. Yeah, unless they were late in making the appointment, then
they've been
good. But I want to thank you, and also thank Hetty. Since I've been on the board, Hetty has always reached out and always made people, I think, feel welcomed, and really has gone that extra step that, particularly as a public member, I think is extremely important, because we are outnumbered here by the physician group. But in all seriousness, that you've really been a good friend and someone who's really taking care of those of us who, when we first got on the board, and we're going to miss you. And congratulations to Sharon.
And I want you to know it is okay to leave. Look at all the presents I'm getting.
Your presence has been a present, Hetty. So I would call for a motion, entertain a motion for adjournment. And I have a motion and a second. Consider us adjourned. Thank you. So I'm gonna ask that.